Good morning, ladies and gentlemen. Nothing can be more satisfying than to introduce your own student, Dr. Ashwini, for the first lecture of the day. Dr. Ashwini is a colonel and he is a practicing physician at Command Hospital at Pune, attached to FMC. He has about 20 years of experience in the field of medicine. And now I would invite Professor Ashwini to deliver the first talk on tips and tricks in MSK examination. Ashwini.
Slide change इसके पास है. Can we change the slides? Slides we can change from here. हाँ. कुछ और लगा हुआ है इस पे.
सर का चल रहा था. सर का चल रहा था ना, उसको चेंज नहीं किया.
इसको मत करो, दूसरा डाल.
ये इसको डाल दीजिए. इसमें सब.
By the time the computer is being set, I will share some
हो गया 9:20 का.
interesting anecdote which happened with Dr. Ashwini when he was appearing for his DM finals. Late Dr. Danda was his examiner, and he got a case of rheumatoid arthritis with the tuberculosis of the shoulder joint. Is that right, Ashwini?
Yes, sir, absolutely.
And then he was asked about impingement, and he did so well on the first ball, then rest of the exam was absolutely smooth. So possibly that's the reason that you are given this topic of MSK examination.
Thank you so much, sir, for your kind words. I'm truly honored to be given an opportunity to speak here. So I was given the topic of tips and tricks in musculoskeletal examination, and I was told that it has to be covered in 15 minutes. So this is the Command Hospital, Southern Command's newly made hospital, tertiary care level, one of the apex institutions in Army, and it's a really beautiful hospital, and we really love working there. So when I was told to present MSK examination review in 15 minutes, so it reminded me of the 12 labors of Hercules. Hercules was given 12 labors by King Euphystheus, which would eventually set him free as a slave. And the only labor out of these, each one of them was impossible tasks. And the only one which was time bound was the fifth task, which was cleaning of the Augean stables. Now, the Augean stables were the largest stables at that point of time, had 10,000 cattle, and they were never cleaned since inception. And so he was told that if he can clean the Augean stables in 1 day, the other 11 tasks were not given a time limit. But here he said he had to clean the Augean stables in 1 day. Ultimately, he finished the task by diverging 2 rivers through the stables, and the stables were cleaned. But he did not get the credit for the task because the king who owned the stables, he said that you have not done any work, the work was done by water. So covering musculoskeletal examination for any forum, UG, PG, DM, is impossible in 15 minutes. It's a mission impossible. And I knew that I've been put front and I'm doomed. But I tried to interpret in my own manner. I hope you like it and you gain something from it. So to introduce, the basic tenets of any clinical examination remains the same in rheumatology also, or musculoskeletal also. So we need to look, feel, and move. So I am a birder. I have developed a hobby of bird photography, so I am going to explain it through my eyes. So first we have to look. So, and what all we have to look at? We have to look at the posture, the gait, skin, scars, deformities, any swellings. So when we are looking at a person who presents with, let's say, arthritis of 1 or 3 or 4 joints, and we find that he has got onycholysis or nail pitting or a patch of psoriasis on scalp, that clinches the diagnosis for us. Or we have a patient who presents with bilateral ankle arthritis, and we look at his lower limbs and we find papery scars or active tender lesions of erythema nodosum. We know that we are probably dealing with a case of sarcoidosis. So that is the importance of looking for these things. In rheumatology, the best thing about rheumatology is even after all the modern development, it still remains a clinical science. And the more cases you see, the more observant you are, you will be more proficient at it, like any other thing. So second is feel. So what do you feel for? You feel for warmth, tenderness, swelling, look at crepitus, and also look sometimes for trigger points. So when you are looking at a joint, I always tell the undergraduate, postgraduate students at my hospital, always touch the joints of patients who come to you with joint pain. Try to touch, feel the joint. Sometimes you will find a boggy synovial swelling that will clinch the diagnosis. Sometimes you will find a nodule. Sometimes you will find a tophus. So depending upon the case, or you may just find that the tenderness is generalized and not confined to the joint. But unless and until you have felt the joint, it is very difficult just by history to analyze whether the patient has inflammatory or non-inflammatory. There are markers to that, but they are really soft markers. And in the end, you need to move. So what do you do when you move? You need to look at the patient joint in terms of passive movements, active movements, and resisted movements, because they will tell you indirectly about the etiology. Like intra-articular disease will have pain throughout the range of motion in both passive as well as active movement. Whereas a peri-articular disease or soft tissue surrounding the joint, you will have normal passive movements, but only active or resisted movements will have elicit tenderness. So with this basic thing, I decided to go by approaching in two common problems and two uncommon problems which I have observed. So one of the most common problems which come to a rheumatology OPD is a patient who says that I have pain everywhere for last 5 years. So pain, now remember, pain everywhere is not equal to joint pain. They do get referred to rheumatology OPD time and again, and our OPD is filled with such patients, all of you will agree. But pain everywhere means that there is something deeper than joint. Generally, it indicates a functional overlay or a psychological overlay. Patient may have fibromyalgia or one of the related things. So there are again pointers to patients who come with chronic widespread pains. So these patients will have short-lasting, disabling, fleeting pains, and they will migrate from one region in a month. Next week they will have some other joint or extremity, then next week it will be something else. And or they can present with a history of having no diurnal variation, no seasonal variation, a chronic pain for last 3 years or 5 years. When you examine them, you will find seldom any objective signs of inflammation. There will be no swelling, there will be no tenderness. So objective signs of inflammation will generally be absent in such patients. And they will come again and again to you with a complaint of no response to analgesics. So once you have this profile of patients, keep on coming to your OPD, please remember to rule out a psychological or a functional overlay in such patients. They may be doing it for some reason, whether professional gain or disability gain, or they may have an underlying psychiatric problem like coexisting depression, by which they are seeking medical attention. So such patient can be easily examined by what is known as Waddell sign. Now I have not seen people usually teaching Waddell sign form in formal education. We have been told in informal education that these occur, but Waddell sign in formal education program I have not seen, so that is why I included it. So there are 5 categories in this. One is tenderness, second is simulation, third is distraction, fourth is regional disturbances, and then overreaction. So I'll explain them one by one. So what are the problems in tenderness in these patients? So tenderness is generally inappropriate to the pressure which you apply when you are palpating the joint. So you try to elicit tenderness, and with a minimal palpation, patient will jump, wince, cry, verbally or non-verbally. They will suddenly, or they'll say that I feel like collapsing. So there is not only the tenderness inappropriate, it is widespread. And generally patient will try to sharply wince and take away the limb away from the examiner. And this tenderness is not confined to a particular structure, a tendon, a bursa, or a joint line. The tenderness is usually to non-anatomical areas. So this also indicates that there is a functional overlay. Remember, these patients can have an underlying rheumatological illness. Does not preclude them from having a rheumatological illness. But then you must understand the problem which the patient is suffering from, and that will help you in gauging that how much he is going to respond from your anti-inflammatory therapy. Otherwise, these patients will keep on getting DMARDs or even biologics or steroids, thinking that this is a pain, this is an inflammatory pain. So that's the mistake which we commonly do. Now, second is simulation. So what we do in simulation is we do axial loading. So we ask the patient to stand up, and we put both our hands on the patient head and try to press it downwards. So the cervical, by putting more pressure on the cervical spine. In usual arthritis patients, patients with musculoskeletal inflammatory problems, this maneuver should not cause any tenderness, but the patient will have sharp pain, and that will tell you that probably this patient has functional overlay. And second thing is acetabular rotation. So you put the patient in standing position, hold both his hands, ask him to fix his or her hands to the side, and then try to rotate them, the hips. Again, this should not have pain in inflammatory disease, but patient will manifest as tenderness. Third thing which we test is distraction. And why I am discussing this happens more in army, because people would gain healthcare attention to avoid certain tasks, certain postings, and we see this very often. And even when I was working in PGI, I used to see these patients in OPD, and we used to wonder what are they ailing from. And one of the best thing was, if you see a fibromyalgia patient or a patient with chronic widespread pains, you try to counsel them, educate them, treat them, that you don't have an inflammatory etiology. You can try some pain modulators, and after 3 or 4 visits, if the patient is not improving, you change the doctor. So that was the common approach. So distraction is, we ask the patient to do SLR while in sitting position, and the patient is able to do straight leg raising, he is able to raise the knee while sitting without any problem. But you ask the patient to lie down on an examination couch and then do SLR, and not even you would have reached a 30 or 45 degree, the patient will say, I am having pain. So there is a gross discrepancy between sitting and supine SLR. So that also tells us that there is a functional overlay. Renal disturbances like inappropriate muscle weakness. The patient has come walking to your OPD, but when you put him in bed, suddenly you start demonstrating weakness of the foot extensors or flexors or plexus of the hip. And this can also manifest in terms of regional sensory disturbances, which are not confined to particular defined dermatomes. overreaction. I've already told this. The overreaction may be in the form of wincing, crying, jumping, excessive sweating, tremors, or verbalization. So these are 5 domains which are checked in. Combined, they are called Waddell sign, and a positive signs indicate that your patient has a functional overlay. Now, then there was one interesting case which I want to discuss. This was a 64-year-old lady, a diabetic and a rheumatoid arthritis patient, and she came to us, referred from a surgical OPD. She was taking her CSD-MAR. She had inability to extend her right thumb for 2 weeks duration. And there was no history of preceding sensory symptoms. Clinical examination also did not reveal any motor or, it revealed inability to extend the right thumb, but no sensory symptoms. And a lump was noted on the just distal to the elbow joint on the dorsolateral aspect. So she was seen by a surgical intern, and it was thought that probably she has had a rupture of extensor pollicis longus. And with that thing in mind, he sought a rheumat consult, whether he should go for surgery or not. Now, this patient, as you all can see, had an inability to extend, but on clinical examination, we did a clinical examination, and what we are doing here is known as the tenodesis effect. So what is tenodesis effect? Tenodesis effect is the effect which the sheer congruence of tendons confined in a small space will exert on the neighboring joints. So if you dorsally extend your wrist, so your PIP and DIP will flex, passive. When you passively do this, these joints will flex. And when you palmar flex it, the MCP will extend. This indicates that the tendons are intact. This indicates that tendons are this is called tenodesis. Tenodesis from Greek, teno for tendon and desis for binding together. And like I said, it refers to the effect which the extrinsic hand muscles exert through the intact tendons on the relative digit position. So with this, we determined that the tendon was intact, the tendon integrity was intact. We did an MRI, and there was a cyst just from the distal radioulnar joint, the proximal radioulnar joint, and this cyst was compressing upon the deep branch of the radial nerve. And this was leading to, we excised the cyst, and the patient recovered well. So tenodesis was something which, again, I had not seen many, and it was not formally taught. I had to look it up and then realize it. Again, it is basic anatomy, I understand, but we all learn. The second, a common problem which I wanted to discuss was late philippic condylitis, how to diagnose it. We have all seen it in plenty, commonly known as tennis elbow. So it is the tenderness of the common extensor origin, inflammation of the, so there are 4 ways to commonly, 4 clinical tests. You can, basic remains that you can ask the patient to dorsiflex the wrist. So there are various variations of it, and which in one variation you ask the patient to rotate the wrist radially. This is known as Cosen's test in flex position, or you can do it in extended position with the same thing, and it is called Mills. There is another version of it where you ask the patient to keep the hand on a cushion or a table or a chair, and you look for resisted extension of the middle finger. That is known as Maudsley test. So these are common clinical tests. You can easily identify, and while these tests, you are always, with the other hand, palpating the common extensor origin. Another test which I found was that chair test. So if you ask the patient to lift a chair with his hand ulnar deviated extended elbow, generally it elicits tenderness. I also thought I will discuss a little. Boutonniere deformity is called so. Boutonniere is nothing but a buttonhole in which the flower is kept on the collar, on the lapel of the coat. So it occurs because there is this extensor tendon which divides into central slip and two lateral slips. It is the weakness or the rupture of the central slip which leads to protrusion of the PIP through the central slip, and the unopposed action of the lateral slips leads to hyperextension of the DIP. Why it is called buttonhole is that on intra-op, when we opened the surgeon opened it and he saw this hole-like thing with protrusion of the proximal phalanx, and he compared it to the buttonhole on the coat. So this is the buttonhole deformity. Again, you can diagnose the weakness or the impending rupture of this tendon before it actually occurs. So there are two tests to it. One is known as the Elson test, where you hold the patient's hand, flex the PIP, and then try to ask them to extend the DIPJ. To conclude, an understanding of clinical anatomy is imperative once you are doing a rheumatological or any clinical exam for that matter. The basic tenets remain: look, feel, and move. And practice makes a man perfect. So with this, I've finished. Thank you very much.
Thank you, Dr. Ashwini, for a.
Can we have 1 or 2 questions?
Okay.
Can you just, for the benefit of the audience, tell us the red flags, where one must always think of organic cause in all these chronic pains, because unlike, nocturnal pains or weight loss and so on, so that at least, the sinister things are not missed.
Sir, one is, sir, loss of function, especially once you see the joint, you feel the joint, and you try to move the joint. If you cannot move the joint through its range of movement, or when you move it, the patient has intense pain, then definitely, or like you said, in the presence of constitutional signs like fever, weight loss, night sweats, again you should always think of a sinister sign first. But simple thing in rheumatology, if you're not able to move the joint through its range of motion without patient wincing, then there is a problem with the joint. So you must move all the joints and look at all the joints.
So, any question? All right, if none, then we thank Dr. Ashwini for excellent presentation.
Thank you so much, sir.
Thank you once again. Yes.
Thank you, sir, for giving us a snapshot of MSK examination. So from MSK examination, we take a leap towards the laboratory investigations. So this session will be on interpretation of lab reports in rheumatology. And to chair this session, may I invite Professor Biman Saikia, Head of Department of Immunopathology at PGIMER, and Dr. Rajiv Ranjan, Consultant Rheumatology from Gurugram. Over to you, sir.
Good morning, everybody. So after that very basic clinical talk, now we move on to the laboratory aspects of rheumatological investigations. And for this, I invite Dr. Devashish Mishra. Dr. Devashish Mishra is affiliated to the Life Care and LLH hospitals in Abu Dhabi. Dr. Devashish, please.
Good morning, everyone. It's a mixed feeling of nostalgia and a sense of pride to be present in this LT1 where we had multiple meetings previously. And through my session today, I would take you through the journey of interpretation of various lab reports in rheumatology. In rheumatology, nothing beats more than clinical history and examination, as we saw in our first session. And lab investigations are just a part of this. We do not rely on lab investigation as much as we do on the clinical history and examination. So when we go through the journey of lab investigation, we have few questions. Why? Why do we need them? For diagnosis, prognosis, therapeutic implications, and monitoring of the disease. What to do? We have inflammatory markers, we have serologies or antibodies, genetic analysis, and synovial fluid analysis in our routine rheumatology practice. How do we do them? So we need to identify the correct test for each parameter that we need. The correct method to do that. We need standardized lab reports and a proper clinical interpretation of the test. Every test comes with its own sensitivity, which always helps us to find out the true positive cases, specificity, which helps us to know the true negative ones, and obviously the predictive value, which is the positive and the negative predictive value, which is based upon the prevalence of the disease in the community. So overall, if I try to summarize what are the lab reports that we do in rheumatology, we have the CBC, LFT, KFTs, which are not a part of our routine lab, but they are the part of the clinical implement. Then routine labs, we have few like the inflammatory markers, we have serologies and antibodies, and some miscellaneous tests like the genetic analysis, and few non-genetic tests, which I'll tell you. So first and foremost, the basic one, which is the erythrocyte sedimentation rate, or the ESR, which is interpreted at 1 hour based on the RBC falling. So as we all know, sex and age both determine normal ESR values. Female gender and elderly people generally tend to have a higher ESR compared to the males and the younger ones. So what are the advantages of ESR? It's definitely a bedside test, easy availability, cost effectiveness. It helps in disease activity assessment as well, monitoring treatment response. It is reproducible, repetitive, and has been incorporated in many disease activity indices like rheumatoid arthritis DAS score, ankylosing spondylitis disease activity score. But every test comes with its own limitations. It is a very poorly sensitive test with a poor specificity, affected by many physiological factors, does not correspond with disease activity always, shows a poor or a delayed response to therapy, and has a very low predictive value as a standalone test. So these are the different non-inflammatory causes where we can have raised ESR, like the gender, age, obesity, pregnancy, anemia, diabetes, liver, kidney disease, and various RBC abnormalities. Very high ESR, more than 100, can be seen in infections, vasculitis like GCA, lymphomas, and myelomas, whereas a low ESR is also sinister. It can be seen with macrophage activation syndrome, A-gamma globulinemia, afibrinogenemia or dysfibrinogenemia, polycythemias, and conditions causing increased plasma viscosity. So what is there to help us now to differentiate? So we have the CRP. It's synthesized in the liver cells by interleukin-6 stimulation. It is more sensitive, but not very specific. Half-life is 19 hours, so it has a very rapid response to the therapy. And it is more useful in inflammatory arthritis, vasculitis, and autoinflammatory syndromes from a rheumatological perspective. It may not represent disease activity in few conditions like the spondyloarthritis spectrum, which includes psoriatic arthritis, ankylosing spondylitis, and few connective tissue diseases like lupus and myositis. So different labs have a different cutoff for their CRP. This is a generalized snapshot of the CRP conditions. It can be mildly elevated even in diabetics, gum diseases, smoking, obesity, and pregnancy. But we always have to look for the significant elevations which can be there in rheumatoid arthritis and various types of arthritis, cancers, Crohn's disease, and trauma and infections. So what are the advantages? It's a better indicator of inflammation compared to the ESR. Availability currently is easily available test. Cost effectiveness is obviously there compared to other markers. Better response to therapy and disease status. It is not majorly affected by the physiological factors unlike ESR. Can be used sometimes as a standalone test as well in rheumatic disease assessment, and it has a good positive predictive value. But the limitations again are the poor specificity, as it can be raised in traumas, infections, not very useful in differentiating between infective condition and inflammatory condition. And some diseases like spondyloarthritis, SLE, myositis, it may not help in assessing the disease activity as well. It requires obviously a laboratory facility with standardized methods. ESR CRP discordancy has been reported to be as high as 12 to 20% in various reports. And if we have a very high ESR with a low CRP, infections, connective tissue diseases, stroke, malignancies, renal insufficiencies need to be considered. But other way around, if you have a high ESR with a high CRP with a low ESR, infections in the GIT tract or UTI, myocardial infarction, macrophage activation syndrome, as already mentioned before, venous thromboembolism, hypogammaglobulinemia can have very high CRP with a low ESR. So another new inflammatory marker coming right now is ferritin, which is also an acute phase reactant released in response to oxidative stress and inflammation. Biomarker for certain specific conditions like macrophage activation, adult onset Still's disease, catastrophic antiphospholipid syndrome, and also multi-system inflammatory involvement in COVID-19, where typically the ferritin levels is very high, as high as more than 1,000 to 10,000. Other causes of hyperferritinemia could be other different rheumatological conditions as well, infection, malignancies, iron overload, and hepatic diseases. So ferritin, if we consider as a biomarker in rheumatic diseases, multiple papers have been there where in rheumatoid arthritis, lupus, inflammatory myositis, ILD, then in systemic sclerosis, and also as a generalized inflammatory markers, they have tried to study ferritin. However, it comes with its own limitations. So availability and cost effectiveness of ferritin is definitely not as par with ESR and CRP. No robust data till now we have to support is unified use in as an inflammatory marker. Inconsistency in reporting and non-specificity are the limitations for ferritin. Uric acid. Hyperuricemia more than 7 and more than 6 respectively in men and women are considered to be hyperuricemia levels. However, we have to know that it is affected by the physiology. There are under-excretors and over-producers of uric acid. It also affected by diet, exertion, hydration, medications, and various genetic causes. And hyperuricemia is asymptomatic in almost 90 to 95% where it doesn't require any treatment. So hyperuricemia does not establish gout, and normal uric acid on the other hand does not rule out gout as well. Considering uric acid in various rheumatic diseases, it has also been studied as a marker of pulmonary hypertension and is a component of the DETECT algorithm which we use to screen for pulmonary hypertension in systemic sclerosis. It also has a cardiovascular implication, and as we know from the latest paper, colchicine has been used in cardiovascular diseases right now. Then it is also a marker of psoriatic arthritis. Patients with psoriasis, since it's a high cell turnover condition, they have hyperuricemia. It is also considered a marker right now for osteoarthritis, however not a robust one. And in conditions like rheumatoid arthritis, it has been even studied to see the treatment response to various anti-TNF therapies. Similar to systemic other rheumatic conditions also. Now coming to our serologies, first we have rheumatoid factor, the most common one, antibody directed against the FC portion of IgG. Most commonly we have IgM rheumatoid factor, low titer, always need a careful interpretation, can occur in infections, also in allergic reactions. Methods that are commonly seen are latex and agglutination and nephrometry. However, we use the ELISA method most commonly in our practice. Low titers can be seen in 10 to 15% of the healthy individuals, more so in the elderly above 50 years. And higher the titer, more is the specificity, more is the positive predictive value. So various infections like bacterial endocarditis, chlamydia, Klebsiella, then viral infections, anything right from HCV, hepatitis, herpes, HIV. We have parasitic infections, malarias, and also non-infective conditions like cryoglobulinemia, liver diseases, biliary cirrhosis, malignancies, which can have false positive rheumatoid factor. Rheumatoid factor can also be a component of other arthritis like JIA, psoriatic arthritis, and surprisingly, almost 70 to 90% of primary Sjogren patients or the patients with even vasculitis, GPA, can have a positive rheumatoid factor. So if we see RF positive RA, then they are more aggressive, more erosive, high risk of extra articular involvement like vasculitis, ILD, and rheumatoid nodules. Higher the titer, like I said, high positive predictive value and poorer prognosis. Sensitivity is 60%, rheumatoid factor monitoring is for disease activity therapy is not recommended. Coming to CCP, post-translational modification is there. 3 generations of anti-CCPs are there, where anti-CCP2 is most widely available. It can be seen in early RA, it can be seen in late onset RA, and also in JIA. It can be there almost 10 to 12 years prior to RA development, and it is a highly specific test for rheumatoid arthritis. False positivity again can be seen in Hep C, lupus, leprosy, psoriasis, and Sjogren. It has a diagnostic, prognostic, as well as a therapeutic role. Predictive role in undifferentiated arthritis, where anti-CCP can give a direction, and treatment monitoring in RA is suggested, however, is not routinely recommended. These are the various subtypes of rheumatoid arthritis. The most common are the ones who have both positivity for RF and anti-CCP, but to know, patients can also have single positivity or dual negativity as well. So in undifferentiated arthritis, preclinical presence of RF and CCA is an important biomarker. CCP2 is more sense-specific. 50% patients in early RA can have anti-CCP, and treatment with methotrexate can even delay development of RA full-blown and joint damage. There's no sound for this. So yeah, this was a video where they were suggesting about the most abused test in rheumatology, which is the ANA. And it has also been marketed as a test which can detect the smallest sign of autoimmune activity by various labs. So ANA is nothing but antibodies against nuclear macromolecules, and mostly we do indirect immunofluorescence HEP2, which is the recommended method to do ANA. Titer and patterns are important. Titer more than 160 is considered clinically significant, and various clinically relevant patterns like homogeneous, spectral, nuclear, and centromeres need to be looked for. These are the various types of ANA which we obtain. If our ANA is negative, we need to look for anti-Rho and myositis antibodies. But if it is positive, we have to go for the clinical consideration. So these are the different indications where we do ANA. ANA may not be repeated, as 70% patients have no change in ANA status. Coming to ENAs, the only relevant ENAs are the Sjogren syndrome and the myositis spectrum, where with a negative ANA we have to do. This is the most common ENA report that we see. Just for the sake of time, I'll try to just mention about the test. We have ANCA, anti-neutrophilic antibodies. Similar to ANA, RF, ANCAs can also be false positive, and indications for testing ANCA right now, apart from the vasculitis spectrum, anti-GBM, interstitial pneumonitis, and infective endocarditis with nephritis have also been included. So ANCAs, PR3 and MPO have been suggested as a marker of disease activity and also to monitor therapy. This is a paper from PGI where they have studied about various ANCAs in various diseases, and atypical ANCA has been reported in almost 30% of tuberculosis patients from these very institutes. Antiphospholipid syndrome similarly needs to have a proper clinical background with a bad obstetric history or a symptom suggestive of APLA in order to test for them. Higher the titer, more the positivity, higher the relevance. HLA-B27 again has a genetic prevalence of 6 to 9%, and of them only 10% are the ones which are likely to get the disease of uveitis or ankylosing spondylitis. So everything comes with a limitation. HLA-B51 considered to be used in Behçet's disease. However, it is not a part of any classification criteria, and routine testing for same is not recommended. New syndrome, Vexus, where we go for UBA1 mutation study under a specific background of autoinflammatory syndrome with high MCV and vasculitis. DADA2, again, we are from a center where we have the largest data of late onset DADA2. It is not restricted only to pediatric population. Vasculitis is the primary manifestation, cutaneous and neurological involvement, and ADA2 levels are checked along with gene mutation to diagnose the condition. Synovial fluid analysis, in case of any monoarthritis or undifferentiated arthritis, it is definitely a good idea to go for synovial fluid analysis. So my take-home points are, always clinical features will take a precedence over laboratory investigations. To look at all available evidences as a whole picture. Never to rush in making or ruling out a diagnosis based on lab reports alone. And at times, less is more in rheumatology. Thank you.
Thank you, Dr. Devashish, for wonderful talk. We can understand that your topic is a little bit not justified in just 15 minutes. And now the session is open for any question and answer.
I'm sure there'll be a lot of questions to be asked, but that will be, I'm sorry, we have to take the tea time or somewhere else, right? We can have a couple of questions, right? So in rheumatology, it's basically we talk of serology because it's easy to detect antibodies, but many rheumatological diseases actually are cell-mediated diseases where now in the laboratory it's very difficult to elicit cellular T cell kind of to demonstrate a T cell autoimmunity. So what was your opinion about that? So any assays which actually can elicit T cell responses, cellular responses, Because we're looking at antibodies because antibodies are easy to demonstrate.
Sorry, sir, I need to get to that.
Any other questions, Varun?
What about, what's your opinion about this, like HLA by flow and HLA by PCR?
PCR, sir, it is all. PCR is the most recommended way to do HLA testing. Because we know flow cytometry, we will have some patients who have an indeterminate report where we need to confirm that by a PCR. So ultimately, it may become a two-step method. So in order to save time and reduce the cost effectiveness, PCR is always preferred over flow to check for HLAs.
Yes. So mostly we do the sequence-specific priming. SSP method is the, but if your volumes are higher, then you can also think of a real-time PCR-based.
Yeah.
Yes.
Thank you so much.
Thank you, Devash. Thank you so much.
Thank you, chairpersons, and thank you, sir, for such an elaborate talk. Now we move on to next topic, which is how to approach a patient with arthritis. May I invite our chairperson for this session, Professor Navneet Sharma, sir, Chief of Acute Care and Emergency Unit at PGIMER, Dr. Boni Abujam, Consultant Rheumatologist at Sohana Hospital, Mohali. Over to you.
Yes, I think we can get on with the third session of the morning, and for unraveling the mysteries behind the Greek word arthritis and approach, a pragmatic approach probably, in the next 15 minutes we'll have Dr. Chattopadhyay to try to explain to the hall how to approach. Dr. Chattopadhyay, stage is yours.
Thank you, sir. Very good morning, and extend my sincere thanks for this. So my job is to approach to arthritis, and we all know rheumatology is not just a disease of the joints, something beyond joints. So I got lots of help from before two speakers. They have done most of my jobs. So in rheumatology, the main thing of tip to diagnose is to be a good listener, examine head to foot, and don't have a telescopic view. So, sorry. So mostly the three different plots are there in rheumatology. One is the patient with joint pain. So we'll go in detail of the joint pain, like what kind of joint pain, what number of joint pain, whether it's associated with other symptoms or not. Second group of patients presents with widespread pain. So that could be as simple as a fibromyalgia or as difficult as case of metastasis or some kind of other malignant situations. And third group of disease is a systematically unwell patient. So the patients seemingly disproportionate problems, so we need to go in deep to those problems. So there are 4 steps of looking into any joint pain or approaching to the joint pain. Step 1 is what is the source of the pain, whether it's inflammatory or non-inflammatory. We need to recognize the pattern and association, and whether the labs which are the clues or confounders. So if we need to source of the pain, whether it's originating from the joints or other source. Joints, it could be an arthritis or arthralgia, and others it could be the sources from the bones, the muscles and soft tissues, and nerves. So limitation of the pain, location of the pain is very important to go for the next step. Like this case of 46-year-old man with multiple joint pain over the last 8 months. His rheumatoid factor was positive, BNA negative, hemoglobin was 12, CBC normal. So he was treated with hydroxychloroquine, sulfasalazine, and deflazacort, and partially improved, and subsequently the pain remains as it is, and there is not much of improvement. So once you examine the hand, you can see the gross wasting and bilateral ulnar nerve thickening, and also the great auricular nerve thickening. So it was a case of Hansen's, and it doesn't, examine of the hand is very important. And it is not that all pain which looks like arthritis to be treated with methotrexate or tofacitinib. So we need to very importantly differentiate between the articular and periarticular pain. So articular is the anatomic structures originating from the synovium, cartilage, and capsules, and periarticular tendon, bursa, and ligaments. So its painful side, it's deep and diffuse and deep. It's focal in case of periarticular. Active and passive movements, all planes there is a pain in the articular movements, whereas periarticular in specific plane there will be pain. So swelling is common with the articular problem, which is uncommon with the periarticular. Rheumatoid is the classical example, and decurrent tenosynovitis is the periarticular classical example. So next important point is whether it is inflammatory or not. So history of early morning stiffness is very much important. Inflammatory arthritis presents at rest and improves with activity, whereas non-inflammatory arthritis There could be some gel phenomenon and use related pain. So more they work, more they use the joint, there will be more pain. So if the joint pain, so whether we need to differentiate this arthralgia and arthritis and inflammatory conditions, so we need to look for the inflammatory signs. So swelling, but we need to fill the joint, you need to move the joint and look for the other gait, arms, legs and spines. So to differentiate the inflammatory and non-inflammatory, we need to look for the swelling, the classical inflammatory signs, the 5 classical inflammatory signs you need to look for, other than lab parameters, can be helpful in sometimes. So swelling of the joint, always inspect the joint first and look the movement and compare it with the opposite side. So this is not something which look like a joint swelling. This is not a joint swelling how it look like. So this is the joint swelling. There is typical swelling of the joint and you need to feel and examine the joint. The third most important part of approach to arthritis is the recognition of the pattern. So diagnosis can be made based on the history and physical examination in 80 to 90% of the cases. So whether it's a monoarthritis, oligoarthritis and polyarthritis, this is the definition, and probability of the having infection underlying reduces with an increasing number of the joints. So based on the number of joints, there are some possible differential, like monoarthritis usually infective, traumatic, degenerative and crystals. Oligoarthritis usually reactive or sarcoid, sometimes osteoarthritis, and polyarthritis in most of the autoimmune rheumatic diseases. So monoarthritis can be acute and chronic. Under the category of the acute monoarthritis is mostly septic, hemothrosis and trauma, chronic tuberculosis, PVNS and reactive. Polyarthritis rarely could be infectious, and para-infections and autoimmune is the major part of the polyarthritis. So chronic polyarthritis, again, most of them are CTD, and you need to again look for the different kind of pattern of their presentation. Rarely it could be even paraneoplastic. So pattern of the polyarthritis is very important, whether it is symmetrical, but you need to remember symmetrical doesn't mean always has to be absolutely symmetric. And sundry pattern of involvement that's asymmetric. The symmetrical pattern is classical example is rheumatoid, and sundry pattern or asymmetric oligo or polyarthritis classical example of spondyloarthropathy. So diagnosis often written on the wall, just look at the this is the DIP involvement, and if you can see the nail changes, that is a very important clue for the underlying diagnosis. So based on the joint involvement, which joints are getting involvement, like DIP dominant arthritis, it could be an osteoarthritis or psoriatic, MCP and PIP, other common, other rheumatological diseases starting from rheumatoid, SLE and psoriatic that are more common to involve those joints. Also, history of the age and sex is important because some of the disease, the onset of the disease depending on age, like spondyloarthritis is usually the disease of the young, whereas the osteoarthritis and pseudo-gout, these are the disease of the elderly. Polymyalgia rheumatica is the disease of the elderly. Male and female, like females are more lupus, rheumatoid, osteoarthritis male, and psoriatic and spondyloarthritis are more common with the male patients. You also need to unmask the thieves because there is a common phrase. The person is known by the company he keeps. So someone having a joint pain, but along with that, he or she is having enthesitis and dactylitis, that is a very important clue for underlying psoriatic arthritis. So it's not the joint or periarticular structure, is the other clinical association of other different organs is also very important clue for underlying clinical diagnosis. So last part, mostly covered by Debashish, the lab report, you need to corroborate with the lab reports of the clinical situation. So I will quickly go through a few cases. This 25-year-old girl presented with joint pain for the last 5 months. She was on and off steroids and NSAIDs, doing well while on drug, relapse on discontinuation. She was advised for the ASO titer, something called RA factor and uric acid. So this is not the situation where you advise for the ASO titer. This is not something called there is nothing called RA factor. You should know what is called. This is rheumatoid factor is the proper terminology you should use. So she has been, after getting the positivity of the rheumatoid factor, she has got a diagnosis of rheumatoid arthritis and she was started on DMARDs. After 4 months, she got admitted with the high-grade fever, rash and oral ulcer and pedal edema. So finally it turned out to be a case of lupus. So second case, joint pain, leg ulcer and right foot drop, rheumatoid factor positive in a 56-year lady. Her rheumatoid factor was very high. She was started on steroid, worsening of the disease, finally got a diagnosis of HCV-related cryoglobulic vasculitis. Third case, body ache with rheumatoid factor. 36 years old lady, aches and pains, rheumatoid factor positive, started with methotrexate, developed shortness of breath after 3 months of treatment. CT thorax showed this kind of ILD changes. Methotrexate was thought to be the culprit, but it was actually a case of Sjogren syndrome. So what are the common things, common lab things? All these patients have a rheumatoid factor positivity. First patient turned out to be lupus, second is a cryovasculitis, and third is a Sjogren syndrome. So rheumatoid factor, as Devashish already told us, rheumatoid factor is not a specific thing for rheumatoid arthritis. It can be in various conditions for rheumatoid and non-rheumatological conditions. So take home should be all rheumatoid factor. You should not stamp someone as a rheumatoid arthritis. Next case in back pain of a 56-year-old male for the last 4 months. So history is very important. You need to know for the inflammatory back pain. Someone advised for the HLA-B27 that turned out positive and made a diagnosis of ankylosing spondylitis at the age of 56 years with history of just 4 months without knowing of the history of inflammatory low back pain. So when we examine the SI joint, it's absolutely clear. So it was basically case of dish, and HLA-B27 was just positive association. So it's not that each and every patient who are having HLA-B27 positive will be having ankylosing spondylitis. So this is take home should be you need to look for the history, you need to look for the radiological investigations. So all HLA-B27 is not equal to ankylosing spondylitis. Next case is 32-year female presented with pain on the bilateral hand, generalized body ache with weakness and shortness of breath, tailored. Someone advised with a pericardial effusion anemia. Someone advised for the NA was turned out to be positive in immunofluorescence 1:80. So started on steroid, no improvement. Can we classify this patient as a lupus? Definitely not. This incomplete information, so no specific information regarding the specific antibodies. ANA, what does 1:80 mean? So the clinical and diagnostic utility of the ANA titer 1:80 is likelihood ratio increases with the higher titer of positivity. So even with this, we cannot classify these patients as a lupus. So this was basically case of hypothyroid presenting with anemia and pericardial effusion. So each and every ANA positivity, as also Devashish previously mentioned, is not a lupus. And something you need, sometimes the radiology give you a very important clue. If you don't know, you cannot see, because this patient presents with knee effusion, and there is a very clear radiological indication of CPPD. So the line between, this is a, if you can appreciate, there's a calcification line between both the bones. So there's a very classical X-ray for CPPD. Unless until you get it, it's very difficult to get the diagnosis. So whenever we are getting any patients with arthritis, we need to ask this question, whether it's actually you're dealing with arthritis or it's arthralgia, it's arthritis or periarticular involvement, whether it's an inflammatory or non-inflammatory, was the duration of the disease, what the number of the joints affected, whether it's a small joints or large joints, whether it's symmetric, axial or peripheral, and most importantly, whether any extra-articular features, be it a skin, mucosa, eye or bowel, any other extra-articular organ involved or not. I have borrowed few slides from Barundhi sir. Thank you.
Thank you, Arogya, for that exhaustive overview. The session is now open for any comments, questions.
I think I just have something to add. I think probably in practice of medicine, as it is in lots of other practice, rheumatology not excluded, you need to be very observant at each and every visit, because you may have a syndrome which may evolve over a period of time. They may come with monoarthritis but subsequently involve other joints as well and turn out to be something else altogether. So just keep your antennas open and be an open-minded. If you close your mind and look at it, then the initial label will follow, which happens in quite a few percentages of patients. So have an open mind when you're dealing with these practices.
The other thing I might like to add, the other thing, Arogya, I think little bit you could have talked about migratory. I think that was missing. I think migratory, which jumps from one joint to another, and
So migratory is mostly classically described with rheumatic fever, but few of there is specific pattern of the rheumatoid called palindromic rheumatoid.
Yes.
That sometimes can present with a migratory kind of arthritis. Yes. And gout also really can be a presentation of migratory arthritis.
This was a very favorite topic of our chief guest, Professor Bhavri. I remember his lectures are still engraved in the mind, even now up till 25 years later.
Palindromic or gonococcal?
No, the approach.
Approach,
that's
yes,
it. MD
yeah.
students, he used to be unraveling this and was very good at it. Yes, yes, please.
Term used now for any
Anticellular antibodies,
so we have
use.
to get used to that system. You know, if the laboratory report says AC2 or AC1, so we have to now get
Habituated with the using the terminology
yeah,
of
so there are 29 patterns. So even for the laboratory person, it's now difficult. We have to look at the chart, which pattern is what. But we have to get used to the system gradually.
But thank you.
Thank you.
Yeah. There are no more questions. The session is now
Okay,
closed.
thank you.
Thank you. Thank you.
Back to the organizers.
Yeah.
Thank you, chairpersons, and thank you, sir, for finishing well in time and for such an engaging talk. Now we move on to our next session on rheumatoid arthritis. So here we have our very first debate for the day on the topic of biologicals over small molecules in patients of RA who have an inadequate response to conventional synthetic DMARDs. Before we begin, let me briefly outline the rules. 7 minutes each will be given to both the speakers and 3 minutes will be given to the former speaker for rebuttal. Rest 8 minutes will be for discussion. So to deliberate on this topic, we have Dr. Benzita Pinto, ma'am, who will speak for this topic, and Dr. Adarsh sir, who will be speaking against it. To chair this session, I invite Dr. Chandrabhushan Prasad, consultant rheumatologist from Goa, to chair this session, and Dr. Niladri Bhaumik from Hyderabad. Over to you, sir.
Good evening, everyone. Welcome to the first debate of today's this thing. So I like to invite Dr. Benzita Pinto. She is associated professor in Department of Clinical Immunology and Rheumatology in St. Joe's Medical College. Over to you, madam.
So I have spent 8.5 years in the hallowed walls of this institution before I was unceremoniously made to leave, but it's always wonderful to be back. So I am going to speak for the motion, and I think this is a very complicated, very difficult debate, because I think there is enough room to actually support one drug or the other. So we all know that the treatment of rheumatoid arthritis has undergone a revolution in the last 2 decades, and I think that's one of the reasons. Sorry. And I think that's the reason many of us are rheumatologists today. But when you look at the treatment, both efficacy and safety are important components, cost being the other component, and several adverse effects may not be evident in the long term. So when you consider RA treatment, RA is a test match, not a T20, and that's why you require someone or a drug that you can depend on. So when you look immunologically at the mechanism of biologicals, you will understand that they're truly targeted treatment. They actually go and block one cytokine. So when you have an IL-6 blocker, you're blocking just IL-6. TNF, you're blocking TNF. When you're looking at an anti-CD20 drug, that's that specific cell that's getting blocked. But this is the major difference when you look at immunologically between a JAK inhibitor versus a biologic. JAK inhibitor is called a targeted synthetic DMARD, but is it truly targeted? You know, because these are, it's like a pan cytokine. It has got a, you'll see that several cytokines are blocked downstream with JAK inhibitors, and that contributes partly to its efficacy, but also to the innumerable side effects that have come up, some of which we know, some of which we don't know, because once we block, we don't know what the downstream effects are, and that's why we are seeing the thrombolytic events, cancer, and several infections with tofacitinib. So JAK has become like the new steroid with a potential for abuse, and I'm sure all of us in practice have seen how widely abused this drug has become. So it is a broad anti-cytokine action with no significant effect on any cell type. So the first thing that we need to look at when we look at which drug is should be on our prescriptions more frequently than the other, I won't say one shouldn't be on the prescriptions, but definitely it affects how we choose the drug, is efficacy. These are the oral trials with which the tofacitinib was FDA approved for RA. And you have to understand that only one, when we looked at the trials, actually there are no head-to-head comparisons to trials, that is the oral standard and strategy, used adalimumab as an active control. Strategy actually used adalimumab as, to look at a non-inferior outcome combined with methotrexate. So when you look at the responses from the oral trials, you will see that compared with both the doses, it was the active adalimumab did almost as well as tofacitinib. Numerically small numbers are in favor of tofacitinib, but these were not statistics. But actually this trial was not meant to really compare tofacitinib versus adalimumab, but here it was just an active comparator. Oral strategy, on the other hand, again, did not find a difference between tofacitinib and methotrexate versus adalimumab and methotrexate. So as far as efficacy is concerned, it seems that both drugs are similar. Similar sort of observations from the baricitinib trial, the RA-BEAM, which showed similar observations here with adalimumab and methotrexate. So this is the RA-BEAM trial, which showed slightly larger numbers with the baricitinib, but otherwise these were not statistically significant. So adalimumab did as well as baricitinib here also in the RA-BEAM trial. So when you look at real world data, you have to understand that when these registries, obviously there is much more data on TNF inhibitors or on other biologics compared to tofacitinib. This is from the Corona registry recently published, which looked at several efficacy outcomes for TNF versus non-TNFI. The non-TNFI group did contain significant numbers of, this is about 40,000 patients database, and did have a significant number of patients who were on tofacitinib and did not find any difference in the real world effectiveness of both, or whether you use a TNF inhibitor or you use a non-TNF biologic or targeted synthetic demand. So when you look at these, you understand that in the long term, most of both these drugs do well enough. So coming to the safety, and I think this is the trial that changed the way or our practice with tofacitinib, and which looked at cardiovascular and cancer risk. I'm going to go through this quickly in interest of time. I'm sure Adarsh will harp on this trial and will give you a very different perspective of the trial, but this was the inclusion criteria. What is important to focus here, when we look at, this is any active rheumatoid arthritis, which is methotrexate, despite methotrexate, and with one additional risk factor. Important to note here, almost 50-60% of the patients that you see in OPD will come under this category. Have one additional cardiovascular risk factor. It's very hard in our current day practice to actually find patients who do not have any of these risk factors. So this was a non-inferiority trial. There were several allegations that Pfizer was trying to kill off its drug, but when you look at the primary outcome, they took the upper bound as 1.8, which means that 80% more risk in tofacitinib group was considered non-inferiority, the upper bound. So it obviously they were trying to save the drug. So it did not meet the outcome of non-inferiority, and the hazard ratios was 1.3 and for MACE and 1.48 for cancers. So 30% more increased risk of MACE compared to TNFIs, and about 48% more risk for cancer. So it did not meet so this is a cause of concern, especially a cause of this. These are the figures here. Their primary outcome was the upper bound not going above 1.8, which this trial did not meet. And similarly for cancers. So when you look at the burden of comorbidities for RA, you will see that so many patients, up to 50% of the patients will have one additional comorbidity, which indicates that this particular big chunk of patients we cannot really, or we will be concerned using these drugs. And we all know that right now India is at a place where we have a huge burden of cardiovascular morbidity. So this is the Indian data looking at infections, and compared to rest of the world, in the TB rates were quite high. This is from the trial, because it's important to note that, you know, this was in a trial setting, latent tuberculosis, any history of active tuberculosis, several things are excluded. Despite that, in Indian population, the rate was 1.2 per 100 patient years compared to 0.17 in the rest of the world, which is 8 times the higher risk of TB, which is a very important outcome for us because of the we are a high incidence country. Herpes zoster, this is also another important infection because the risk does not reduce with time. It's not like it's only in the first year or second year and it gets no. The risk stays high, the incidence 3.6%, it continues to stay high with continued use of tofacitinib. So I will conclude that there are several new kids on the block, but experience always matters. So long-term safety of a drug is very, very important. It's only with time that we tell that how good a drug is. Thank you.
Now I would like to invite Dr. Adas to speak in favor of biologics for rheumatoid arthritis. Sir is a assistant professor in rheumatology at Government Medical College in Kazigod, Kerala. Over to you, sir.
So a very good morning to the dais and the. So, Bensita ma'am, you are the loveliest senior I have ever had in PGI. But those few extra gray hairs are not going to save you this time. Okay, so small molecules, are they really small? Just let's look at it. So what are those factors that we consider when we start treating a patient with rheumatoid arthritis? We look at the drug, the efficacy, the serious adverse events, we look at the disease, whether there is a prior treatment failure, are there any extra-articular involvements, and patient factors like comorbidities and affordability. So what exactly is small molecule? They act subcellularly. They prevent the signals from reaching from the receptor to the inside. So it doesn't matter whether it's a TNF, whether it's an IL-6, that message is not passed on to the deep inside. So, छोटू ऊपर से गोली नहीं मारते, वो अंदर घुस के मारते हैं, madam. So does that look nice? Okay, let's see how it transfers clinically. So we have multiple drugs already approved by FDA and EMA, multiple small molecules available right now, and the efficacy is proven beyond doubt that they are non-inferior to most of the biologicals. So when you look at deeply, we have upadacitinib and baricitinib, which are not just non-inferior, but rather they are superior to adalimumab on treatment efficacy. Also, they fare reasonably well against other non-TNF biologicals like rituximab, abatacept, and tocilizumab. And the compare and choice trials in upadacitinib shown us that they are superior to abatacept and they are superior to adalimumab on the treatment response. They also help us to prevent radiographic progression. They are comparable to biological drugs and numerically may be better than biological drugs on prevention of radiographic progression. And comes the extra-articular disease. We are all concerned with interstitial lung disease when we start treatment for rheumatoid arthritis. So this is a post-marketing surveillance, and then they have looked at around 20,000 patients on treatment, and they have shown that the patients who are on tofacitinib has lesser incidence of interstitial lung disease. So it is very safe to use in those patients who already have interstitial lung disease. Can we use it as a steroid sparing agent? Please look at the data. When you look at the effect is like within 2 weeks of treatment initiation, you know that we have around 40% of the patients has an ACR20 response just within 2 weeks. That means you don't have to bridge them with steroids. You can even just start them on treatment with tofacitinib and some analgesics, and you can just get rid of steroid, which has many unwanted side effects. And comes the unlimited confusions of biologicals. Genetic, biosimilar, bioequivalent, whether to switch or not, whether I should go for interchangeability. No such confusions with tofacitinib. You have a confusion, am I really treating a rheumatoid arthritis patient? Is it just a psoriatic patient with peripheral disease alone and R factor 21 from a Gadia lab? Yes. In those confusions, tofacitinib comes to your help. It doesn't matter whether it's an SPA with axial involvement, whether it's an SPA with peripheral involvement, whether there is seropositivity, seronegativity, nothing. Chotu ko shuru kar do, chain se baitho. So here comes the oral surveillance data. Okay, so this is her anchor. Okay, so let's look at again. 50 patients, 50 and above, at least one risk factors, right? So at the baseline itself, they have a 10-year CVD risk of around 20%. And when you add Curix-3, rheumatoid arthritis as a factor in Curix-3, you know it's around 24%. So they are at an increased risk that you should start prophylaxis with atorvastatin plus or minus aspirin in them. And when we look at others, the next thing is surveillance. The trial was against adalimumab. So when we look at the factors against placebo, because tofacitinib has a very good control of the inflammation, it helps actually reduces the MACE risk, the thromboembolism risk, the malignancy risk against placebo. It means adalimumab is better in preventing, but it doesn't mean that tofacitinib is bad. Okay, I am giving treatment to an RA patient so as to control the disease. I'm not giving to prevent a malignancy or a cardiovascular event. My primary aim is to control the disease. And the number needed to harm in oral surveillance is 530 person a year. That means I can treat 530 patients for 1 year with tofacitinib, and yet I will have only one cardiovascular event. So which one will you prefer? It's open. And the other adverse events, except for herpes zoster, most other adverse events are comparable in most of the trials already happened. And drug adherence, being a small molecule orally available, cheaper, the adherence is much more with tofacitinib. So we know, we start them on adalimumab, they take it 2 weekly initially, then 3 weekly, 4 weekly, gayab. So I don't want gayab patients with me, okay? I just want patient to stick with me and control the disease. So I prefer tofacitinib in that aspect. And this is the final nail in the coffin. Well, this is a study from Chennai. It's from a tertiary care corporate hospital. Those patients who came with the rheumatoid arthritis, only 8% had insurance. This is in a corporate tertiary care hospital. Only 8% had an insurance with them. And 50% of the patients had catastrophic health expenditure. That means which they put them into debt when they were diagnosed with rheumatoid arthritis. So by treating such patients, tofacitinib is so cheaper. So by treating such patients, you are not just helping the patient, but you are bailing out an entire family from debt. So here I rest my case. We have think less, act fast, making your life a lot easier. It's oral, easily available, less costly, comparable efficacy, maybe better than biological drugs, shorter onset of action, steroid sparing, not so sure, but still we can hope. We have to be cautious. That's okay. We can just get those MACE events with 1.5 rupees aspirin atorvastatin tablet. So I rest my case. Thank you.
Thank you, Dr. Adarsh. I will invite Dr. Benzita Pinto for a rebuttal.
So just one important rebuttal, MACE includes death. Okay, so even if you get 1 in 1,000 deaths, it matters. So, okay, so I don't think we can take death lightly, and that is why in MACE, even number needed to harm of even 1 in 500 counts. And as far as statin is concerned, see, there is only that much a statin can do. Otherwise we would never have any mortality with statin. So that is also proven. And when you look at that trial, obviously here you're looking at a at-risk group. We can't say that only joints matter to us. RA is a systemic disease. The entire disease matters, and the patient is not a sum of his parts. So we can't say, okay, as a rheumatologist, I'm going to take care of his joints and koi aur matlab heart dekh le. No, I disagree with that. And also this thing that patient doesn't come back to you with biologics, patient never comes back to you with tofa, because you know it's so easily available, and so there is such a huge potential for abuse. We are already seeing that. And I really think there are a lot of concerns with that drug in terms of practice. Cost should not be the only way to look at it. Yes, there will be patients in whom we will use, but yes, there are concerns that I don't think we can ignore. Here the debate was which one should be used and not which one is, you know, more easier on our pockets. So that is a completely different debate, health economics. But I do think if you look truly only at the data, biologics should still be the ones that are preferred.
Thank you, ma'am. So now it is who won this debate. whether Dr. Benzita Pinto supporting for biologics or whether Dr. Adarsh MB supporting for small molecules. It is open to the this thing. So who won? Dr. Benzita Pinto or Dr. Adarsh? Yeah, we can raise the hands for Dr. support for Dr. Benzita Pinto for biologics. And for Dr. Adarsh, small molecules. So I think Dr. Adarsh has won this debate. Thank you both of you. Thank you. It's a nice discussion.
Thank you, chairpersons. The goal of debate is not to just win, but to grow, to learn and grow. So thank you for such thought-provoking exchange. Now we will have another interesting talk on how to manage rheumatoid arthritis in 2025 from Professor Varun Dheer sir. This session will be chaired by Dr. Venkatesh Pai from AIIMS Rishikesh and Dr. Adhar Dhuria, consultant rheumatologist from Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. I welcome you, sir, on dais.
Good morning, everyone. First of all, let me say my sincere respect to all my teachers out here, Professor Verma, Professor Bambri, Professor Aman Sharma, Professor Navneet Sharma, and all the other teachers who have missed out. It's a pleasure to be back to my alma mater. It's a couple of decades since I joined here in 2005. It's always good to be back here. I can see one of my seniors, Rishi, sitting here, I think. Okay, hi. Okay. So this is the bread and butter of rheumatology. So I think we'll see much more patients of rheumatoid arthritis throughout our career than any other disease. And an important point to discuss, Professor Varun Dheer, my senior at SGPGI, he's doing a lot of work in rheumatoid arthritis. He requires no introduction here. So, Professor Varun, please go ahead.
Thank you, chairpersons, and good morning, ladies and gentlemen. My talk is basically to cover rheumatoid arthritis in 2025. And obviously, what I'm going to talk about is not only 2025, but what it means is that what's the recent, in the last 5 years or so, what has changed in rheumatoid arthritis? That's what we are all interested in. Now, so this will be the format of my presentation. And the first, I'll talk about what Benzita and others have made the task easier for me. And I'll try to make it easier even more. So the first is the oral surveillance study and its risk. This has been a major development in the last 5 years or so. So if you just look at the timeline, it was in 2012 that tofacitinib, which was the first JAK inhibitor to be approved by the FDA USA, came into the market in the US. And subsequently, the FDA did mandate the company, that is Pfizer, to carry out a study, a post-marketing phase 4 randomized controlled trial to look at what risks does this drug give in terms of MACE, cancers, DVTs, pulmonary embolism, so on. So this was the oral surveillance study. First of all, it was 2019 mid-study that the Data Safety Monitoring Board recommended that the 10 milligram BD, so there were 3 groups in it. One was placebo, 5 milligram BD, and 10 milligram BD. In 2019, the Data Safety Monitoring Board found that deaths in the 10 milligram BD group were much higher than placebo and recommended that it be stopped. So all patients in the 10 milligram BD group at that time were shifted to the 5 milligram BD group. And it was in 2021 February that the results of this trial came out, leading to FDA warnings and regarding the fact that they found increased risk of serious heart-related problems, mortality, and cancers. So let's go on. And we've already had understood that the oral surveillance study was a specific population-based study. You had to have people who were 50 years of age or more with at least one cardiovascular risk factor. As I said, there were 3 groups. I won't go into that. One group was stopped and transferred to the other midway. And the median age, if you look at the study, obviously it was 50 years and above, but actually the median age was around 60 years. And you can see that 67% were hypertensives, 18% were diabetics, and 50% were ever smokers. So what did we find? So as I've shown in this triangle, these were the major adverse effects we were looking for. The first on the top was MACE, which stands for major adverse cardiovascular outcomes. The second is cancers, and the third was serious infections. Obviously, we were also looking for DVT and pulmonary embolism, but these were the major ones. So let's look at them one by one. So as Adarsh has already pointed out, the major adverse cardiovascular events were number needed to harm is 500. That means, as Adarsh defined so beautifully, but it's so important I need to repeat it, that if you treat 500 patients with that drug compared to placebo, which in this case obviously was not placebo, but which was actually TNFI, either adalimumab or etanercept, you would have one extra case of MACE, right? The second one was cancers, which was a number needed to harm of 300. That means that if you treated 300 patients with tofacitinib for 1 year, as compared to treating them with adalimumab or etanercept, you would get one extra cancer, which in this case was mostly lung cancers, lymphomas, and skin cancers, non-melanoma skin cancers. The third was serious infections, which had the lowest NNH. That means the highest risk. So you had 1 in 250. That means you treated 250 patients and got one serious infection, as compared to if you had treated them with TNFIs. So this was overall. Now, this led to, in 2021 September, the FDA got a black box warning that regarding the increased risk of cardiovascular events with this drug, which led on to finally the FDA mandating that this drug be only considered in those patients who have experienced TNFI and failed TNFI. That means that obviously you have the first line was conventional synthetic DMARDs. After that, there was a phase where we went on, if you had failed conventional synthetic DMARDs, which are methotrexate, leflunomide, hydroxychloroquine, or sulfasalazine, what do you go for next? So next, at the phase between 2012 when the drug was approved and 2021, the phase was whether you could go for TNFI, you could go for rituximab, you could go for IL-6 inhibitors, and you could also go for JAK-Is. But at this stage, the FDA mandated no, place JAK-Is lower in the therapeutic ladder. Try them only after you've tried biologics in these CS-DMARD failed patients. However, so this was the black box warning, and as you can see, as you've gone through, this was the major black box warning which came up, that risk of higher rheumatoid arthritis patients with at least one cardiovascular risk factor had a higher rate of all-cause mortality and thrombosis with Xeljanz, 10 milligram twice daily, and this was the group which was removed, obviously. And this was, but the European Medical Agency took a different view. So the European Medical Agency said that in patients, sorry for the fuzzy print, for patients more than 65 years old, or those with a history of smoking and risk factors for cardiovascular disease or malignancy, tofacitinib should only be used if no other suitable alternatives exist, which obviously, as Adarsh says, is fine. Suitable alternatives can or are always modifiable by socioeconomic factors. So EMA took a much broader view rather than taking the very harsh, rather, categorical view of the FDA, which probably was appropriate for the United States. Now, obviously, this is an important picture I took from the internet, which says, there's a bear there, and it's a quote which says, there is risk everywhere. Being alive carries the risk of death. So I think we are all aware as physicians more than anybody else that everything, I would say one of my professors, when he was teaching me, used to say, if a patient has come to the hospital, already the risk has started. So the moment you enter a hospital for some reason, you are at a higher risk than others. And that's why you'll find that the older people, obviously they took it to an extent which is often harms them, but they would obviously say, nahin, let us try ghar ka nuska, take it to the doctor later. So obviously anything we do, obviously we feel great as physicians, but probably everything we do does carry a risk. But obviously we are physicians and we are doing well and we are doing good for the society because it carries the benefit as well. So this is very important. So what do we do to mitigate, to handle the risk? Is there a right way to manage risk? So one is obviously to understand the risk, which we are trying to understand. What is the risk? And so we can even communicate to our patients. They can take a decision. Obviously, in our case, most of the time, we have to take a decision for them in India, with most of our patients, at least, which we are seeing in PGI. Second is try to use a safer alternative. Obviously, as Benzita said, if socioeconomic conditions are not a factor, most of us would prefer a TNFI. Whether it is TNFI is leading to better because it's safer, or whether there's a difference, whatever it be, obviously we would try to use that. And obviously the third, again, as others said, is try to mitigate the risk. Sometimes you have to use it. I have used JAK inhibitors in a lot of patients, even with cardiovascular risk factors. I have used a JAK inhibitor even in a patient who's had a MI in the past, because sometimes there is just no alternative. Either you leave him to pain and morbidity, or you discuss with him and you understand that you can mitigate his risk and what is exactly the risk versus morbidity. And it's a very difficult decision. So this is, I'll just go through some of the very interesting articles which came through, which was one, was that FDA expands JAK inhibitors warning, going beyond the data. And this article said that the blanket warning regarding JAKis based on a high-risk population extrapolated to a different risk population with different safety data is heartening. Obviously suggesting that if you're treating a 30-year-old with RA, and obviously in India we are seeing younger patients with rheumatological diseases, would you have the same risk? And none of us know the answer. And this is another, see how beautifully it is written, oral surveillance in JAK inhibitor safety, the theory of relativity, that everything we are doing is relative, obviously, the risk versus benefit, and that's why we are there. And this is beautiful, as discussed with Benzita and others, and I'm so happy that they spoke before me, is that there is no standard size for number needed to harm. So we were debating what is 500, is it high, is it low? And as they said that, you know, even if you have triple digits harm, if the harm is very serious, you would think twice, obviously. As Benzita said rightly, that if you have a risk of death, even in 1 in 500 or 1 in 1,000, it's a big risk. Depends on what is the risk you're looking for, and so it's not an easy subject. And but interestingly, that one study, post-hoc study, showed that in the oral surveillance, the patients who were on statins and aspirin actually did not have a high risk of MACE. So, you know, this is a way you can interpret the data anyway, and obviously we have to understand that data will come to us from all sides, and it's often contradictory data, and we have to make a judgment based on these layers and layers of data which come in and which change over time. So the second topic I'm going to talk about is preclinical RA, which has really changed in the last 5 years. So what is preclinical RA? I think most of the people here would be aware that preclinical RA is when you pick up a patient who is having, at the most baseline, you'll have inflammatory arthralgia with probably CCP positive. There is a definition by EULAR, which is clinically significant arthralgia. I won't go into that. But basically what it means, if you have early morning stiffness with your arthralgia, if you have a metacarpal squeeze positive, things like that. And then you have obviously a definition where you have a patient with arthralgia with, you know, no swollen joint, but he's having some tender joints, and with or without ultrasound or MRI evidence of synovitis. Now we must understand these terms. You know, you have to contrast preclinical RA with undifferentiated RA and established RA. What is the difference? So basically preclinical RA and undifferentiated RA both fall in the category which are not till now, you know, which can't fulfill the 2010 EULAR ACR classification criteria. Obviously the 1987 criteria of RA was very, very restrictive, but the 2010 EULAR ACR, you can even classify a patient with RA with one joint which is swollen and tender if he has high titer CCP and so on. So this is RA. Then if you have arthritis, that means you have synovitis, which we say as a swollen joint, at least one swollen joint, but not fulfilling RA, maybe CCP negative, and so you would classify it as undifferentiated arthritis, and then behind it is the preclinical RA. So now the most important part has been that people have seen that almost 30% of these patients would progress to RA within 2 years. So the question was, can we stop RA? Can we totally, you know, make some of these patients, the RA, go away? And so these were a lot of studies which have been carried out mostly in the past 5 years. These have been studies with rituximab, studies with only steroids, studies with hydroxychloroquine, studies with the biological like abatacept, which was supposed to be reasonably very safe, one of the safest biologics, and can we prevent RA? And look at the results. Now in the first column, what you see is at the end of treatment. That means when you ended the treatment, were you able to make a difference versus the placebo group? And yes, the green suggests that in all the cases, whatever drug you gave, you could prevent them from going on to RA as compared to if you did not do anything, which is very remarkable. However, when you look at the end of follow-up, So you had an end of treatment, let's say you treated for 1 year and followed up for 1 year more. At the end of 2 years, what you found is that the other group caught up in every case. So this is, that is the reason, this is remarkable. And this is just showing one of the, studies, the EPIPRA study, just to show you that this is the end of treatment. Look at the divergence of the two, survival curves. But look at the end of study. The survival curves have come together. So there is a catch-up. This blue arm, which was treated, was not developing RA till here, but the moment you stopped the active drug, which was preventing RA to come on, it caught up with the red arm becoming non-significant. And that is the story for all treatments in preclinical RA. The only exception till now has been this study, which was in an abstract presented in last year's ACR, which showed that in increased risk patients, if you treated them with methotrexate for 1 year or so, you could prevent the curve still dissociated even at the end of 4 years. So this is the only study till now presented as an abstract form, but remaining all the studies, none could show a long-term effect. So that is the basic story that, for preclinical RA. The third point I want to discuss, how much time do I have? Huh? For 15 minutes. Okay, so sorry, I'll go a bit quicker. It's personalized treatment in RA. And personalized treatment has come in terms of synovial histopathology. That can we look at the synovial histopathology and predict which biologic is going to work, which target we can achieve. So they look at basically, this diagram is very simple. You can define it as post-immune, myeloid or lymphomyeloid. You have markers like CD3. So you see here it is the brown ones means that the cell is present. So there's a lot of CD3. CD20 means B cells. So again, you can see here there's a lot of this. So this is the lymphoid or the lymphomyeloid type of biopsy. This is the myeloid type of biopsy where CD3 and CD19 will be absent, but the CD68, which is a macrophage marker, will be present. In this also the macrophage. And if you have no markers, this is the post-immune marker. So they defined it like that, and they found that if they followed up these patients, the risk of the lymphomyeloid, the lymphoid or the lymphomyeloid had a much higher risk for biological therapy at the end of 1 year. So then they said, can it drive personalized treatment? So this was the first study, which was the R4RA study, which looked at, patients who had failed TNFi, could you decide whether to go for rituximab or tocilizumab? And look here, whether you had a B cell poor, subset in the synovium, you had a benefit of tocilizumab, as you expect, that B cell poor and tocilizumab is doing better, which is anti-IL-6, and rituximab is anti-B cell, so it's doing better. However, even in the B cell rich, tocilizumab was doing better. So how do you reconcile this? So the reconciliation, although there was some difference in the RNA sequencing, but the reconciliation I'll come to later in the next study, which was the STRAP RA study, or the STRAP EU study, sorry. And this was about which biologic to choose after failing a conventional synthetic DMARD. And again, they decided they'll target the B cell poor and the B cell rich. The hypothesis is obviously, if you have a B cell poor compartment, you'll have much better response with tocilizumab or etanercept rather than going for rituximab. And what did they find? Let's see. Now again, you see that they could not prove, even in the B cell poor, rituximab and tocilizumab etanercept did equally well. Even in the B cell rich, you couldn't find a difference. So this hypothesis for now has failed. Obviously, what was the difference in ACR50? There was a difference. Tocilizumab and etanercept did much better than rituximab, and even in both the things. So again, you couldn't find by histology. It was basically the drug that, it was basically rituximab is a much slower drug. Tocilizumab is a much faster and much more efficacious drug. So that is what it was showing. It was not dictated by the synovial histology, whether you had lymphocytes or not. So that was the main thing. So ultimately, this was one of the editorials which said synovial tissue for personalized medicine, hype or hope. And obviously, what do these findings mean? That decisions based on synovial tissue biopsies, personalized treatment, is still a long way from being implemented, and currently HPE, which stands for histopathology, is still hype. So ladies and gentlemen, with this I come to the conclusion and take home message. First, the JACI oral surveillance study, risks are, yes, are there, but they are not overarching. And probably, I feel they're not so important for younger non-CV malignant baseline risk. And as others said, sometimes, obviously, you have to look at how much is the patient suffering. And it's a difficult decision to make, but sometimes you do make it when you see a patient really suffering. Despite risks, you take a choice which can give risk but gives some quality of life. Second, preclinical RA. We do not have treatment to prevent the progression of preclinical RA2. We can only delay it as of now. And once we stop the treatment we are giving, catch-up does occur. But maybe in a high-risk group, and that was the latest study, we'll see. This might change in the future. And the third is personalized synovial tissue-based biopsy, looking at the immunological cells involved, whether B cells are there, not there, things like that, seems to be currently much more of hype. Thank you very much.
Thank you, sir, for an illuminating talk. Always wonderful to hear you.
Thank you.
So I have a question for you. So you have talked about personalized medicine and the future. Do you think we'll ever come to a stage where we'll be offering CAR T cell to the more aggressive subset? Because if you look at what long-term data we have, only 1 in 5 is going to be in long-term remission. So 20 years of treatment versus one single shot treatment. What would be your take?
I think that's a very excellent question, and that is the same question which comes across as you said, that it will depend on how, because CAR T cells also involve lymphodepletion using cytotoxic medicines as of now. So they do carry a risk. And obviously we'll have to see, and it'll be center to center, how much is that risk? It's probably one step ahead of autologous bone marrow transplant, which also did very well in things like refractory lupus and all, but we haven't been able to reach there just because autologous BMT also, which is high level of cyclophosphamide lymphodepletion, carries. So I think it will be the risk. And obviously, the risk is obviously death here. Well, like for autologous BMT, it's probably 10% or 5% in the best centers or 2% in the best centers. I don't know what's the risk for CAR T cell as it comes up for in the immediate term. So we'll have to look at that. And the second obviously will be the bogey of whether there will be any long-term problems we'll encounter. It's a new therapy. And as clinicians, we've learned, we burnt, and we were always taught by our seniors that wait for the, any therapy also evolves over time. So we'll find out like any cancers coming up or something. So I don't know. My take is probably I'm very conservative. You know me. So unlike you who is aggressive, and it's age as well. So I would be probably not offering it upfront in RA right away, definitely.
So any questions from the audience?
Sir, what is your personal drug of choice after methotrexate failure in seropositive acute?
Oh, so thank you for that question. And although I didn't, and this has been another sea change which has occurred. And Shankar knows that, and all of us know that. It was when methotrexate came in and methotrexate failures were gone to triple therapy, which is methotrexate, sulfasalazine, hydroxychloroquine. Over time, sulfasalazine has been replaced by leflunomide. When leflunomide is a drug which came in 2000s, introduced into the market, and initially we were scared that, getting methotrexate and leflunomide together, hepatotoxicity is going to rise. But leflunomide has been such a remarkable addition because it's so effective and it's fast. Sulfasalazine is also an excellent drug. There's no doubt about it, I'm sure. But sulfasalazine is a slow drug. So that's where I think most of us, at least I definitely, the moment a patient fails methotrexate, I go on to a leflunomide combination with or without hydroxychloroquine. Yeah.
Sir, one small comment.
Yes, please, please.
Sir, excellent talk, first of all.
Thank you so much. Thank you.
But whether it is methotrexate, whether it is JAKis or TNFI or CAR T cell, I think the race of targeted therapy started somewhere in mid-90s when we had this GVAC, which came with BCR-ABL positive CME.
Right. Imatinib.
Now imatinib, sir. Now what we should realize is, sir, that rheumatoid arthritis is not a monogenic or a monolithic disorder like BCR positive, BCR-ABL positive, CML. We do not know, we must accept our limitation. We do not know the pathogenesis of RA, what drives the RA, whether it is T cell or B cell.
That's right.
And every 5 years we celebrate a new molecule as the master of the orchestra. So sometimes it is CD20, sometimes it is IL-6, now it is JAKi. And try to drive the treatment the other way around, from treating the disease. I think the answer will have to come from defining the pathogenesis, and from there the treatment will develop, not the top-down. So all the treatment will have risk and all will have efficacy. So I have the good fortune to work in a setup where I have innumerable biologics at my disposal and no cost to me or the patient. We work in army of this. We provide the latest drug we can find, the most fanciest drug at free cost to the patient or to me. But we always have to make this decision whether we are dealing with preclinical RA or RA, whether to use it or not. Is it really benefiting the patient? So that individualization is difficult. Right now in RA it is difficult. And we have seen it from Adarsh and Bensita's debate also.
Yeah.
We have seen it from your talk.
Well taken.
Dr. Varun, nice talk. Yeah.
Venkatesh here.
Yeah.
Where is he? Oh, sorry. I got confused. Sorry.
Yeah, so Dr. Varun, we have a lot of patients who have polyarthralgias kind of picture and very high rheumatoid factor anti-CCP. So what's your advice on treating such patients?
Same at-risk RA or preclinical RA as we call it. Right now, most of the studies have not shown that we can prevent them going on. But obviously, if they have very high morbidity, let's say, then you might try low dose. I can say what I do. I might try a low dose methotrexate for them if they have very high morbidity. Not that it's going to prevent, but in my mind, I've kind of decided, yeah, this is RA. It's just that probably, and sometimes it's a palindromic kind of RA as well. When the patient comes to you, he's not so bad, but they say, oh, my shoulder gets jammed and my wrist gets jammed for a few days. And even in palindromic RA, it's like that. So we often treat with methotrexate based on the morbidity, even though the damage is not going to be so much. So that's one answer. And the second is I'm hopeful with that study that maybe in a select high group, risk group patient, because right now we know that the way we define preclinical RA, around 30% of them will progress to RA. Maybe if we know that, it's close to 70% are going to progress in this high risk group, then probably we would, and they're having obviously pain and stiffness, which is not a great feeling to have. And then we might start them earlier as well. I agree with you. Yeah. I think that's what you were hinting at. Yeah.
I have a question.
Yes, Akshay.
So, adding on to what sir said, recently I've had a few patients who have osteoarthritis clinically, but positive rheumatoid factor anti-CCP, strongly positive.
Yeah.
Clinically, they look like OA. You do an MRI, it seems like osteoarthritis. But the orthopedics colleague, they obviously prefer to use DMARDs in those cases because their rationale is if you don't treat it, this is going to go for a TKR.
Right.
So how aggressively should we be treating those cases which are clinically looking like osteoarthritis,
Right.
but strongly anti-CCP rheumatoid factor?
I think that's a very good question, and we've also gone through that because the major thing is I think that we have a great benefit that now we have a randomized control trial showing even OA, hand OA, a methotrexate would work. The second thing is obviously that, as Benzita said, that you have time on your hands. So if you want to give a therapeutic trial, I would always suggest a therapeutic trial in concordance with the patient. The patient has very high stiffness. The patient has very high, you feel that there is some overlap between RA and OA. And you're not sure how much is the damage, how much is it OA, how much is it RA. Then sometimes I do go with a therapeutic trial, telling the patient it's not an indefinite treatment. It's for maybe you give a depot steroid intramuscular, you give methotrexate for some time, and then tell the patient, I am doing a therapeutic trial. I am not sure about your disease. So it could be an overlap of both. So that's what we normally would do, because I would think all these drugs are toxic in the long term. But in a short term, I'm giving somebody methotrexate, I'm very confident. I'm not harming the patient, I'm sure. Even if I overtreat, maybe for 3 months I've given somebody methotrexate, I don't think it's going to cause a problem if it's done properly. So
I was just wondering, like, if we are giving a trial for like 3 months, should we be treating with something more aggressive like tofacitinib or something like that?
yeah, again, that's open. You can do that. Because again, for a short term, because that is one way, you might even go with it. Obviously, current guidelines would not go so far, but this would be your manipulations and kind of the patient sometimes comes there, I'm 80% better. Then obviously there's something that therapeutic trial has worked. You don't expect, it might be an inflammatory component in OA as well. So you'll have to keep that in your mind. I'm giving anti-inflammatory therapy and then step down to methotrexate. You won't like to give tofa. So that kind of permutations combination.
May I think, thank you. We've had such a great discussion. We have so many students here. Just to add one more aspect to severe arthralgias and rheumatoid factor positivity, many times we've had the patients who eventually develop another disease, which is not rheumatoid arthritis. We've had a couple of ANCA vasculitis. These residents would remember.
Definitely.
So while we treat for methotrexate, sometimes you suppress the disease for some time and it comes back and hits hard. So it is, and RA is not like myocardial infarction. it will give time for disease to be modified even when it develops. And that rituximab trial, Varun has beautifully highlighted that point. We know something might happen, but in large majority also it doesn't really happen, and it might be a very different disease than what you're presuming, even with all those serologies positive. It is better. It's not like you have to do an angioplasty in a clogged coronary artery. I think we can just wait and hold to our horses before we go blazing all guns.
So one last question from your old student. So I know you have been doing a lot of work on titrating a methotrexate. So what do you think the time is right to now start at 20 milligrams per week, go to 25? Because most patients are going to require a higher dose.
I don't know how much of this audience knows that, and I don't know if you also know that Professor Malviya, who's one of the doyens of rheumatology, he always starts straight away at 25. The second group of people who always start at 25 is dermatologists in psoriasis. They'll always start straight away at 25. They don't titrate. Now this question is a very difficult question without data. I would still think that, as Dr. Aman said, that probably you have the time. What's the hurry? You can up titrate in a month or two. We have come down to titrating over 6 to 9 months to maybe 3 months. So I won't really compress that further right now for me, again being the conservative that I am. But I'll tell you, these two group of people, like one doyen and one dermatologist, many dermatologists would start straight away. And not that I'm saying that, but I won't for now.
Thank you, sir. Thank you for an illuminating.
Thank you so much.
Thank you. Thank you so much. Thank you, chairpersons, and thank you, sir, for such clear, concise, and insightful talk. Now we move on to our next session, which is on vasculitis. So we have, first up, we have a debate on an exciting topic that sparks diverse opinions across different organizations, with ACR, EULAR, and KDIGO. And today our speakers will present their perspectives on whether cyclophosphamide should be chosen over rituximab in remission induction in ANCA-associated vasculitis. So Dr. Joydeep will be speaking for the topic and Dr. Sakshi will be against this. May I invite our chairpersons, Dr. Prashant Agarwal from Ludhiana and Dr. Prateek Dio from Bhopal to chair this session.
Good morning, ladies and gentlemen. First of all, I would like to thank Dr. Aman Sharma for giving us the opportunity for chairing this very interesting session. It is a topic that we actually always consider before we start our patients on treatment, whether to use cyclophosphamide or rituximab. Before I invite the first speaker, I would like to have a show of hands. How many of you are in favor of using cyclophosphamide as an induction therapy for ANCA-associated? Okay. And how many are in the favor of rituximab? I think both the same. So we have to actually look how well Joydeep and Dr. Sakshi Mittal present their case. So first of all, Dr. Joydeep Samanta.
Good morning. I have been interested in the topic regarding what to choose as induction agent in ANCA vasculitis. It is a very dear topic because during our 3 years in DM, we have to manage extensively this vasculitis, which is very commonly seen in our setup. So regarding ANCA vasculitis, what is the need for induction immunosuppression? Because we all know ANCA vasculitis have a chronic relapsing course with an historically very high mortality. So it needs intensive immunosuppression. Steroids are known to be effective. However, long-term steroids associated with its known and unquestionable side effect. So need for alternate agent comes. So first role of cyclophosphamide was reported by Anthony Fauci, published in 18 ANCA vasculitis patients in 1973. The first role of cyclophosphamide was proven that time. He treated, their group treated 14 patients of ANCA vasculitis with cyclophosphamide, and they used oral cyclophosphamide at a dose of 2 mg per kg. Among them 18 patients, so they had a significant ENT involvement, pulmonary involvement, renal involvement. Among them 14 patients received cyclophosphamide. And if we can see that among them a significant high, 12% had remission, 2% had death. So these data showed that cyclophosphamide are a promising option for induction immunosuppression in ANCA vasculitis. However, the problem is oral cyclophosphamide, because oral cyclophosphamide has associated with various side effects, mainly cytopenias, hemorrhagic cystitis in one patient, and cellular atopia of unibladder in 3 patients. After this, there are many works to whether to avoid that risk of cytopenias and other malignancies associated with the oral cyclophosphamide. Works were done, and subsequently the landmark Cyclops study was done by European Vasculitis Group. They compared pulse versus daily oral cyclophosphamide for induction immunosuppression. It was a multicentric study across 42 European centers, in which they recruited 149 newly diagnosed ANCA vasculitis patients. They had 2 groups. In one group, they used IV cyclophosphamide at a dose of 15 milligram per kg, and in the other group, they used a conventional, previously used oral cyclophosphamide 2 milligram per kg per day. They included both ANCA positive and negative patients, and there was a background steroid therapy. So what was the result? There was if we see the survival curve, there was a similar remission rate at 9 months in both groups. There was no significant difference between the groups, pulse versus oral cyclophosphamide, and time to remission also didn't differ between the groups. If we see the disease activity measures, the BVAS and the inflammatory markers like CRP, it was similar across both the groups. So the pulse group had a lower cumulative dose of cyclophosphamide. If we see, it is 8.2 gram versus 15.9 gram in the oral group, and a few episode of leukopenia as we expected with the lower cumulative dose of cyclophosphamide. So these studies showed that pulse cyclophosphamide as effective as daily oral cyclophosphamide for induction remission in ANCA vasculitis, with a significantly reduced cumulative dose and obviously a fewer adverse events associated with the lower cumulative dose. So this trial was predominantly in the GPA and MPA. So what happens to eGPA? So another trial gives this answer. So by the French vasculitis group, in which they recruited 48 patients of eGPA, they were also recently diagnosed with at least one poor prognostic factor in the 5-factor score. They compared 6 versus 12 cyclophosphamide pulse. Here actually they used cyclophosphamide pulse in both the groups. Their main aim whether the prolonged therapy offers some more benefit. There was a background pulse methylprednisolone followed by oral glucocorticoid therapy. And as we can see from this study, both treatment regimens achieved comparable remission rates. The 12-month pulse regimen was more effective compared to the 6-month pulse regimen. However, the main message from this study is that cyclophosphamide is as effective option for the remission induction in eGPA2, similar to the GPA and MPA. So what happens to those patients in the Cyclops study, because initially it was 2 years. So what the long-term follow-up data shows? The long-term follow-up data of the 148 patients recruited from the Cyclops trial with a median follow-up duration of 4.3 years showed that there is a slightly higher relapse rate in the pulse group compared to the oral group. However, there is no significant difference in survival, renal function, and end-stage renal failure between the groups. So there is a relapse rate was slightly more in the cyclophosphamide IV group, but which can be managed very well. However, there is from the survival curve, we can see that there is no significant difference in the renal function and end-stage renal failure, which is our main aim. So it reaffirmed the role of IV pulse cyclophosphamide in remission induction in the ANCA vasculitis. So there is a concern regarding the cyclophosphamide side effects, infection, cytopenias. What happens to the elderly population? Because the risk is more in the higher age. So this answer was also given by another beautiful study namely Cottage study, in which they used in the 60 elderly patients more than 65 years age. They used a fixed dose of 500 milligram IV cyclophosphamide at 2 to 3 weeks interval compared to the conventional dosing at 500 milligram per meter square. So what was the result? From the survival curve, again we can see that no significant difference in the remission rate or survival between the groups. There is a slightly more relapse in the experiment group. However, it was not statistically significant. So the main debate was whether cyclophosphamide or rituximab. So what the study shows about the efficacy? So there is a after this landmark cyclo study, there are some anecdotal reports, some case series showing efficacy of rituximab in the remission induction of ANCA vasculitis. The first RCT came in 2010 in the famous RAVE study, which was randomized double-blind and double-dummy non-inferiority trial. They recruited 197 patients of GPA and MPA. There was rituximab versus cyclophosphamide. They used oral cyclophosphamide and rituximab at a 375 milligram per meter square dose. So in the 64 patients in the Ritux group achieved remission, and compared to the 53 in the cyclophosphamide group, it proving it is a non-inferior. However, it was not superior. Both rituximab and cyclophosphamide equally efficacious for patients with DH, severe disease players similar between the groups. However, this study showed that for the relapsing disease, Ritux was superior to cyclophosphamide. So, is rituximab the magic wand, as we are seeing? So, RAVE trial explored patients with a serum creatinine more than 4 and DH requiring mechanical ventilation, and all patients are ANCA positive. So, efficacy in the ANCA negative patients is doubtful. So, the next study was Ritux First, which tried to answer that question. It's an open label trial in 44 ANCA vasculitis patients where they compared Ritux versus IV cyclophosphamide groups. And as we can see, the remission rate is not different between the Ritux group and the cyclophosphamide group. Ritux-based regimen was not superior over cyclophosphamide-based regimen in severe AAV. And recently, another study came in 2024 in which, from the real-world data of the Japanese population of 687 life-threatening ANCA vasculitis patients treated with either Ritux or IV cyclophosphamide, there is a short-term effectiveness on mortality is similar. However, short-term renal prognosis is inferior with rituximab compared to cyclophosphamide. So this is very important. And if we go by the cost effectiveness, rituximab is cyclophosphamide is still very cheap. The whole induction regimen comes at a cost less than 3,000 to the patients. Compared to the rituximab, even after so much biosimilar cost reduction, it still comes at significant higher cost. And if we see the guidelines, our guidelines also doesn't prefer between the cyclophosphamide and rituximab. But considering all the data we had regarding the severe disease and disease with the more severe renal involvement and cost effectiveness, I will say that except relapsive disease, cyclophosphamide should be chosen over rituximab for remission induction, considering it's effective across all the spectrum of ANCA vasculitis and being a cheaper and cost-effective option. Thank you.
Dr. Sakshi ma'am.
Yeah, first of all, I would like to say it's so nostalgic being here on the stage and feels so good to be here presenting this talk. So thank you for this opportunity. So you heard my friend Joydeep talk a lot about cyclophosphamide. He did say cyclophosphamide is a wonderful drug and we should be using it. And I agree, cyclophosphamide is a wonderful drug, but he was not able to say in any way that rituximab is also not a wonderful drug, and in any way that cyclophosphamide is superior to rituximab, because there's no data to support saying that. The only thing he could say was that cyclophosphamide is cheaper than rituximab, which we all know, but then is cost the only factor when we are deciding the treatment of a patient? So I'll be speaking in favor of rituximab in this debate. A RAVE study Dr. Joydeep already talked about, and as he himself highlighted, when talking about the new patients, cyclophosphamide and rituximab were equally effective. Adverse effect-wise also, there was no difference between the groups. And definitely in the subset of patients, which was relapsing AAV, rituximab fared better than cyclophosphamide. We all know that AAV is a relapsing disease. The course of an AAV patient is marked by frequent relapses. So if we see the number of patients that we get in our clinical practice, the new patients versus the patients who have had relapses, at least 50% of patients are the ones with relapses. So a good proportion of patients is where rituximab would work better. This was another study. This is a real world data, not a trial data. And they're looking at the composite of the risk of kidney failure and death. And here they have looked at different centers in USA, and the primary outcome was kidney failure and death. And they found that there was no significant difference at 1 year, 2 years, 5 years between the rituximab and the cyclophosphamide group. There were some secondary outcomes. So steroid dose reduction could be better achieved for rituximab group as compared to cyclophosphamide, and the risk of severe infection was comparable. Another interesting point in the study was that 60% of the patient in this study received rituximab. So this study actually looked at the patient from 2002 to 2019. RAVE results were published in 2010. So what I want to say is that even before 2010, physicians were probably more comfortable using rituximab as compared to cyclophosphamide, and that's why the numbers with rituximab are more. And in the RAVE trial, more patients were PR3 positive, but this real-world data is showing that even the MPO positive patients did well with rituximab. This is another study which was published by the French vasculitis group. This is also an observational data. It again compared rituximab with cyclophosphamide. This was more of GPA patients, PR3 positive patients. The interesting point about this study is the primary outcome, which was disease remission, which they have defined by a BVAS of 0 and a prednisolone dose of less than 10. Here they're kind of showing a superiority of rituximab over cyclophosphamide. So in this study, the primary outcome was reached for 73% of the rituximab group, whereas only 40% with the cyclophosphamide group, and the relative risk difference was 33%. So they concluded that rituximab induction therapy for GPA was more frequently associated with remission than cyclophosphamide. This is another study. This was the follow-up of the RAVE trial. So it's an interesting study, not what we do in clinical practice. Here, they've not used any maintenance therapy. They took the RAVE patients who had received the rituximab for induction, and the cyclophosphamide group had received oral cyclophosphamide for 3 to 6 months, and then they were given azathioprine for maintenance. The interesting point is that the maintenance of remission at 18 months comparable in the two groups means that if you've given only rituximab for induction without any maintenance, was comparable to giving cyclophosphamide followed by azathioprine maintenance. So this just goes on to show the effectiveness of rituximab. And there was no difference in, again, the efficacy or adverse events in both the groups. This was a study which we had published at our center, just our experience in GPA patients with rituximab. So here also we've used the similar biologic rituximab, and we got good results in new cases. We had not compared with cyclophosphamide in the study, but what we want to say is that we got good results with rituximab. And there were 18 serious infections, but we did not have any major infusion reactions with rituximab in our study. So why not cyclophosphamide? There are a lot of issues with cyclophosphamide. Infertility is one major issue. ANCA vasculitis, traditionally we used to read, is a disease of older age group, maybe 50s, 60s, 70s. But in clinical practice, we are seeing more and more young patients coming to us with ANCA vasculitis where we are needing to use these drugs. Hemorrhagic cystitis and malignancy are other concerns with cyclophosphamide. We'll just come to in a bit. And as Dr. Joydeep has already mentioned, why not rituximab? It's expensive, right? So what are the costs and the hidden costs? So for cyclophosphamide, you need 6 infusions. You need to get admitted for those infusions. The patient needs to take a leave from their work, loss of pay for those infusions. Rituximab, you get 2 infusions 15 days apart because that's the other regime we use, and then you're done with it. And then there are a lot of insurance and government schemes also, central government, health employees, Delhi government, all these schemes, they do provide rituximab at free cost as well. So wherever we can make use of the cost, it's also about how you counsel the patient. If you tell the patient, say you have to use 2 infusions and then you're done for good for 6 months, the other one maybe is putting you at risk for infertility or at a risk for malignancy. Let the patient decide what is the cost of life or cost of getting a malignancy. What do they want? So this was a study looking at infertility risk among males who receive cyclophosphamide. So we didn't have any, I didn't get any data for connective tissue disorders, but I did find some data for male patients who received cyclophosphamide for malignancy. So here the dose of cyclophosphamide which was given was similar. It was not very high compared to what we use. So this is 0.75 to 1 gram per meter square, and this was given every 3 weeks IV. So this was 17 males who underwent semen analysis, and 10 of them had azoospermia, 5 had oligospermia, and only 2 were found to have a normal sperm count. So all the patients treated prior to onset of puberty had an abnormal semen analysis. So it does lead to male infertility. And this was another study. This is not from ANCA vasculitis. This is from lupus nephritis. So this looked at infertility in females who received cyclophosphamide. This is the lupus nephritis dose that we use. And sustained amenorrhea occurred in 12% of women below 26 years of age, 27% aged 26 to 30, and 62% in those more than 30. The majority of our ANCA vasculitis patients, compared to no amenorrhea in patients who received only steroids. And this is my last slide. So this is looking at the effect of rituximab on malignancy risk in patients with ANCA-associated vasculitis. So here there were 323 patients who were followed for 5.6 years, and there were a total of 45 malignancies, a huge number in 33 patients. There was an increased number in the cyclophosphamide group compared to the general population. The standardized incidence ratio was 3.1, which is quite high, whereas the similar risk was found in the rituximab group compared to general population. So if somebody told you that a drug was more expensive, but it may give you a slightly high risk of malignancy, if you could afford it, you would definitely go for that drug. You won't want to take that even small chance of malignancy. Yeah, if somebody cannot afford it at all, given everything else, then cyclophosphamide remains an excellent option. Thank you.
Dr. Joydeep for the rebuttal.
So Dr. Saxi tried to show that cyclosporine is inferior to rituximab for remixin induction. So the trial she highlighted is the JAMA study. So what she omitted is that in the JAMA study, there is a significantly more number of patients in the cyclosporine group with a pure granulomatous disease. We all know the pure granulomatous disease, only orbital granuloma, with a pure ENT disease is very difficult to treat and very difficult to resistant. There is a less number of pure granulomatous disease in the rituximab group, which was more, almost 50% in the cyclosporine group. So apart from the JAMA study, no study showed superiority of rituximab over cyclosporine. So, but in the JAMA study also, I have a doubt regarding the pure granulomatous population. Secondly, malignancy. She highlighted one study in the last about the malignancy risk of the cyclosporine. However, she didn't comment how many patients of those group received oral cyclosporine. Because if we look towards the RAVE data or RETEX data, surprisingly, rituximab group had more malignancy numerically than the cyclosporine group. So cyclosporine is not associated with the higher malignancy, is not a very, because that study only showed. We all know the oral cyclosporine associated with the higher risk. However, currently we have shifted to the IV cyclosporine. And regarding the fertility issues, we extensively use IV cyclosporine with lupus nephritis. However, with the cumulatively lesser dose with the IV cyclosporine, fertility issues is not a big concern. So what I tried to say that there is the main motto of the cyclosporine. In the patients with a severe renal dysfunction, the real-world data shows slight superiority of the cyclosporine for the short-term renal outcome in the cyclosporine group compared to the rituximab group. And in our population, cost always remain a thing. The hospitalization cost can be taken care of in many parts now. Daycare centers are available with a minimal or nominal cost for admission. So still, I feel cyclosporine is a better suitable option for remission induction in AV, except obviously in the relapsing group of patients where it is definitely rituximab is superior. However, other patients, in newly diagnosed patients, cyclosporine is still a better option for immunosuppression in our population for remission induction. Thank you.
Dr. Sakshi, would you like to add something? So it was an excellent debate. After the debate, would anybody like to differ by the show of hands, like still the ones who are favoring cyclophosphamide still in favor? Mild change. However, still in favor of rituximab? So there's still a 50-50 debate, but deep in the heart when we say ki, we will give the patient option, choose between rituximab and cyclophosphamide, everybody sitting here knows we have already made the choice what we are going to choose, and we tend to counsel regarding that. And in my personal experience, when CNS vasculitis, foot drops, myocarditis, very sick patients, one with pulmorenal syndromes, and where we are expecting faster results, cyclophosphamide is always the drug of choice.
Thank you so much for your patient listening. We close the session now. Thank you.
Thank you, chairpersons. I hope we have got some answers. And thank you for such heated arguments and for such a wonderful show. Now it's time to hear from the doyen in this field. This session will be on management of ANCA-associated vasculitis in 2025. May I invite with extreme honor Professor Vinay Sakhuja sir, ex-dean and head Department of Nephrology at PGIMER, and Professor Sanjay D. Cruz, head Department of General Medicine at Government Medical College and Hospital, Sector 32. Over to you, sir.
At the not at the outset, I'd like to thank Dr. Aman Sharma for the kind invitation to participate in the program. It's a pleasure to be here. Gave us an opportunity to meet Dr. Bhambri after a long interval, one of our close friends. And so I'm really very happy to be here. We've already had some discussion in the preceding session only on the ideal treatment, the induction treatment for ANCA vasculitis. And I'm sure Dr. Aman would take this forward. I'm sure there are several issues that are still uncertain about the management. One such issue is the role of plasma exchange, which after a recent post hoc analysis, the question has been reopened because that analysis has shown that plasma exchange did indeed help those patients, although the original Pexivas analysis concluded that it didn't help. So that is one of the major issues. The issue of which was at question during the debate, that is another issue. And yet another issue, in my opinion, is when should, if at all, one combine cyclophosphamide and rituximab while trying to induce a remission in patients with severe ANCA-related disease. So I'm sure you'll be taking up all these issues.
Thank you very much, sir. First of all, thank you for accepting our invitation to be here. It is always good to have you, Verma sir, and all seniors, and of course, Dr. Bhambri amongst us, and being on the same podium which you chaired during the CPCs and many other sessions in PGI. I think the ball has been set very rightly by the debate and the questions which have been posed by Sakhuja sir. With his insightful and in-depth analysis of the situation actually. And my brief is to talk about management of ANCA vasculitis in 2025. I mean, how does this really work? I'm so sorry. The question is, we try to answer these questions in the guidelines that were published by the Indian Rheumatology Association last year. And okay, I'll do it from here, no worries. My apologies. We we are trying to answer some of these questions with the data which is available with us. For the residents, actually, the phases of ANCA treatment are: first we have to induce remission, and once the remission is induced, there has to be a phase of maintenance, and then there has to be a long-term follow-up looking at the problem. But the challenge arises when these diseases are relapsing diseases, and sometimes these relapses can be life-threatening, and that is when you have to do the reinduction in these patients. So if you look at how the science has evolved over a period of time, with so many different guidelines developed over a period of time, like the ACR guidelines which came in 2021, published in 2022. There was initial document from KDIGO which has been updated also, part of which Dr. Sakhuja alluded to. And then we also developed our own data-driven Indian Rheumatology Association guidelines, wherein we thought that perhaps our socio-economic situation is different. That is what was highlighted. Some people can't really even afford cyclophosphamide. We can forget about rituximab. And there are other demographic and clinical profiles. So these were the guidelines which were published in autoimmunity reviews based upon the grade methodology involving rheumatologists, nephrologists, pulmonologists, and it was a complicated process. The entire published data was served, and there were more than 13,000 studies which were assessed, and we gave 20 recommendations. So beyond this, I'll straight away switch gears, and the first question which is commonly asked is, if you're suspecting ANCA vasculitis, which test do we do? Do we do immunofluorescence or we do ELISA? With the current generation ELISA test, we should only do phase 3 ELISA assays for PR3 and MPO, and the days of immunofluorescence are actually out. And even if the first one is negative, you should do ELISA again with the second kit, and if it is negative, then you should send a sample to an expert center which does ANCA with immunofluorescence. The next question is again, with which drug we can actually induce remission. The current recommendations, actually we have no trial which shows superiority of rituximab over cyclophosphamide in naive patients. So you can look at, whenever we are taking a call on treating a patient, we look at the efficacy. As of now, in naive patient, with the data available, efficacy for both the drugs is the same. The second is safety. You can look at the safety concerns with both. While people talk about hemorrhagic cystitis, we must also remember, in the RAVE trial itself, there were some solid cancers reported with rituximab, which we should not forget. So the cancers have also been reported with rituximab. It's not that they've not been reported with rituximab. And then there is cost. So, and the ease with which the patient can get those drugs. So all these things should have to be taken into consideration. But having said that, in a naive patient, you can either use rituximab or cyclophosphamide or rituximab in that order. If you choose to use cyclophosphamide, always only use IV pulse cyclophosphamide. Please do not use oral cyclophosphamide. We did a Twitter poll some years ago, and we were surprised to see that even 10% of global researchers, they were using oral cyclophosphamide, and oral cyclophosphamide is very, very toxic. Please do not use oral cyclophosphamide. That's recommendation number 2. The other, we have one of the pioneers of nephrology in India sitting at the dais, but I can tell you that many of our nephrology colleagues are very fond of mycophenolate. But please do not use mycophenolate for inducing remission in ANCA vasculitis. That CME-C trial, if you look at the addendum, there was more mortality actually. You may not just read the paper, but also read in between the lines. And it was more mortality in the subgroup with PR3 positivity. So please do not, this is also, the recommendations are data driven. Do not use MMF as first line therapy. And we also recommend against methotrexate. People talk about NORAM trial, but then on long-term follow-up NORAM trial, there were more relapses, more cyclophosphamide use, more steroid use in the methotrexate arm. So this is not a 100-meter dash that you have to reach in 100 meters. You have to treat patients for a long period. And over a period of time, those who kind of where methotrexate was seeming to be doing well, it didn't hold for a period of time. So you should not use methotrexate in patients even with non-severe GPA or MPA. So the only drugs that you practically have is either rituximab or cyclophosphamide. We also strongly recommend using rituximab over azathioprine for maintenance. So we know that Sacaziram trial azathioprine became a standard of care for many decades. But now with Manitsan trial and the 5 years follow-up of Manitsan trial, which showed that there is a survival benefit with only 500 milligrams of rituximab, which just cost 7,000 rupees for 6 months, I think you should only use rituximab for remission maintenance. You should not use azathioprine. And if you can't really use, can't really afford, then you might consider giving this as an alternative, not as a first-line therapy. Maybe then you consider azathioprine, methotrexate or leflunomide. But here also, please do not use mycophenolate and maintenance also. So we have a recommendation, data-driven recommendation against MMF, even in maintenance phase. So it's not a good drug either for reduction of remission or for maintenance of remission in ANCA vasculitis. And there was a WEGE anti-trial which showed that etanercept doesn't really work, so you shouldn't also be using etanercept. The other question which is asked is, whether once you started therapy, $1 million question is, how long do we really give this therapy? These are toxic therapies, there are side effects, but one also has to remember, this is not a iffy disease. The next relapse might kill, and we've had CPCs presented in this very hall, one probably which Sakhuja sir chaired, wherein, and Dr. my friend Ritesh who's sitting here, he presented a coronary arthritis killing the patient in a very stable patient. So the next relapse might kill the patient actually. So it's not an easy decision, but the data, and actually there was Manitsan trial, Manitsan 2, Manitsan 3, and we wrote a letter, I think Siddharth was a part of that write-up, wherein we asked that if remission, long-term remission seems to be a mirage. And Louis Gillivan, the great man himself, with H-index of 118 and 50,000 citations, he's acknowledged that at least 4 years of maintenance is required. And based upon that data itself, our recommendation suggests that at least 4 years of maintenance therapy is what is required. Although Benjamin Terrier, the younger lot, might disagree, but as was very beautifully shown by Benzita, you have to go by experience. And actually Louis Gillivan has far greater experience than his prodigy Benjamin Terrier. So I think you should all give maintenance therapy for at least 4 years. Then fixed schedule, this was based upon Manitsan 2 trial, but actually if you read in between the lines, although they said that who were given rituximab only when the B cells, they repopulate, or there is an ANCA titers which either after negativity become positive, or they have doubling of titer. But when you see in between the lines, even those who did not have B cell repopulation or CD19 positivity, and also in those who did not have ANCA positivity, also in the Manitsan trial, 2 trial, they also relapsed. And actually we wrote a letter, Argo, I don't know whether he's sitting here or roaming around somewhere, then we did a critical analysis of that data and wrote a letter, wherein we showed that they had calculated a sample size based upon a minor relapse rate of 30% and a major relapse rate of 15%. But in actuality with rituximab, the major relapse rate was 5% and the minor relapse rate was 11%. And if you take that into account, the data of Manitsan 2 was not powered enough to go for that conclusion. And we wrote that letter was published, and Louis Gillivan group himself accepted. And these recommendations this paper could never make into any of the international recommendations based upon what we wrote. So you should never give based upon either ANCA positivity or B cell repopulation, but give them a scheduled 6-monthly maintenance therapy. So the other is, in a relapsing disease, rituximab has been shown in more than one trials to be beneficial than cyclophosphamide. So if you have a patient who's had a relapse and is PR3 positive, I think there is no debate now. We have enough evidence either with a rituximab trial or from the long term of RAVE trial also, that rituximab has to be given in a relapsing disease because there is a mortality benefit. The other question which is commonly asked more out of fear, whether we should be using IVIG. Actually conditionally, just out of fear, you should never use it. If I may borrow what Dr. Bhamri used to say, it's more of an apology in a full-blown ANCA vasculitis. If you don't, you should only be using it if there is a full-blown infection, proven infection, by some time by using, but don't fall back upon out of fear of a multi-system disease that there might be some infection also. This is not a very good drug. If you don't have any other option, then only use IVIG. Plex, sir, the Michael Walsh has published in BMJ and the analysis of plexivas, and I think the nephrologists and the rheumatology community is divided as of now. One thing their consensus is that with advanced renal failure, you should use Plex because there are scoring systems also, and either we should do a biopsy in the beginning in the advanced renal failure or dialysis dependent renal failure, we should give Plex in those patients. But jury is still out, or there is still debate in DAH. Actually, Walsh group, they themselves don't believe, and there is a previous older data from the early Specs group from the Mayo Clinic, which showed that Plex doesn't really work in DAH. So, and there is increased risk of infection. So as of now, I'll side with my rheumatology community and would say that I will use Plex in advanced renal failure, but I may perhaps not use Plex in diffuse alveolar hemorrhage because of the risk of infections. So we use rapid tapering of steroids. This is the Plexivas regime. Some people also use 0.5 milligrams as induction therapy also. There is a TAPIR trial. There are other trials also. We don't have time to go over those. I think, and the other important question is, other important thing to remember is please always do serum immunoglobulin levels before giving rituximab. And if it is less than 3 and there have been recurrent infections, please give a replacement dose or a single day dose of IVIG before giving rituximab. Otherwise, the patient might die because of overwhelming infection. So in EGPA, in life-threatening disease, again, we have only cyclophosphamide or rituximab. Mepolizumab has to be in non-life-threatening disease. For maintenance, we have azathioprine, methotrexate, or mycophenolate in severe EGPA. So to compare various guidelines, I think the ACR guideline, they say you should only use rituximab. Actually, this is not based upon data, and we had written a letter against this also, which is also published. They say that it is more out of fear of presumed safety of rituximab over cyclophosphamide. But if you dig deep into RAVE, even they have reported mortalities, and once infections occur after use of rituximab, they are actually far more severe than when they occur with cyclophosphamide. So jury is still out. We don't have data to support that rituximab is much safer, as nobody has done that trial to answer that question actually. And dosing also 1 gram into 2 versus 375 milligram per square weekly into 4. My friends have encouraged us. I think Dr. Raja is not here. He was after me to do a trial. We're doing a trial of 1 gram into 2 versus 375 milligram per meter square into 4. And Ritesh and pulmonologists have actually supported us also. We need 112 patients. We've already recruited 89 patients. And I think we'll probably complete the recruitment by the end of this year. And after 6 months of follow-up, we'll have that data. Whether 1 gram into 2 or 375 milligram per meter square into 4, which of these doses you should. There is no RCT as of now. I think with this, I'll probably, this is the summary of recommendations. So active GP or MPA, agent formation inductions with steroid, rituximab, or IV cyclophosphamide. And for maintenance, rituximab over cyclophosphamide. For severe EGP, again, IV cyclophosphamide or rituximab. And in maintenance, azathioprine. So this is the difference between maintenance in GP or EGPA versus MP or GPA versus EGPA. Non-severe EGPA, actually you can use mepolizumab. And non-severe maintenance, we can only use corticosteroids. We do not have a avacopan as of now. So we have not actually included that in our recommendation. This is a serum-sparing drug. Not supposed to take position of rituximab or cyclophosphamide, but supposed to take position of corticosteroids. I think with this, this is the textbook. I'll be happy to hand over to any of the residents if they want. And with this, I'll conclude. Thank you very much for your patient hearing.
Thank you, Aman, for an excellent talk. A couple of points needs to be stressed. It's a disease which needs the consent as well as the cooperation of the patient. Patient education is often overlooked in the clinic setting. Plus she or he, whosoever it is also a stakeholder. We should offer them the choices available to us depending upon their finances and socioeconomic and other literature that we know about. So many things are still unknown. And in patients who are in the vaccination group, I would definitely, vaccination age, I would prefer cyclophosphamide. This is another plus point for that.
Would you ever consider a combination of cyclophosphamide and rituximab?
Sir,
And
actually,
one more question also after
so
that.
I'm sorry I didn't, because
No problem.
so the Hammersmith group have actually used rituximab plus cyclophosphamide combination. The doses that they've used is 10 milligram per kg body weight cyclophosphamide and 1 gram into 2 rituximab. So they showed that eventually those patients, and there is no randomized trial to compare. They've compared it with the historical UVAS data, where they've said is that if you use a combination, you end up using less corticosteroids. But in our pool, wherever we've used, there are much more severe infections, and we've ended up losing patients. So while the Western data suggests that infections are lesser, we have used it ourselves, but we've used it ourselves where the disease is absolutely refractory. We now have 500 plus patients. Fortunately, in large majority, even with advanced renal failure, with our data, Indians either do not have very severe renal failure of the kind which is reported from the West, that's published from us and by Dr. Ashok Kumar from Delhi, or even if they present with advanced renal failure, a small subset only ends up being dialysis dependent or with ESRD. So maybe genotypic, because of the genotypes prevalent here, the prevalence is 50% as compared to 70 to 80% reported by the European cohorts. So perhaps we should use it, but use it only in a subset which has a, when you are up against the wall and nothing works actually. There, of course, we should use, but not like what Hammersmith group has been proposing it in majority of conditions, including ANCA vasculitis.
One more small question.
Sir.
You were talking about preclinical diagnosis of rheumatoid arthritis a short while ago.
Sir.
So is a preclinical diagnosis of ANCA vasculitis known or possible?
Sir, it's a very interesting concept, but I don't think that debate has yet started. It's only in the realm of rheumatoid arthritis. Actually, we do not really know what is the pathogenesis, to be very honest also. We have rheumatoid factor, we have anti-CCP which plays some role in rheumatoid arthritis. But we don't actually know whether ANCAs play a pathogenic role in ANCA vasculitis or not. And we do not really have any good animal models. The only animal model that we have is MPA actually for microscopic polyangiitis. So that constrains the research. We don't really have a discussion as of now of a preclinical ANCA vasculitis.
Yes, there's some questions there.
Yes, sir. Dr. Sikka.
Regarding infusion-related reactions with rituximab, how common they are, how
Sir, they were, sir, actually excellent question. They were, the black box warnings were infusion reactions and the pneumocystis girovasi with rituximab when it came. It came to rheumatology by serendipity. Professor J.C.W. Edwards in University College London, while treating lymphoma patients, saw that 5 patients of rheumatoid arthritis got better. The infusion reactions, practically I have seen none. They are reported from lymphoma. Actually, you have to give it very slowly. Give 125 milligrams of methylprednisolone, 2 tablets of paracetamol and maybe an Avil. We never see infusion reactions. In small subset, 1 or 2 patients, minor things, you just slow down the infusion. But we have never needed to omit rituximab because of an infusion reaction in a large number of patients that we've used rituximab on. Maybe it is the disease factor, not the drug related factor which is playing a role.
A word about, sorry, there's a question in the audience.
Sir, what to do after 4 years of maintenance therapy? Because I have 2 patients from last 2 years and they are doing well, and I have given almost 4.
If you go by the guideline, they'll say stop it after 4 years. If you believe the teachers, Gary Hoffman has written in Clinical La Presse Medical in 2013 that where the patient has tolerated the therapy well and there are no concerns of fertility or malignancy or infections at all, if I remember correctly, then I'll give the therapy indefinitely. So probably the truth lies somewhere in between. So probably you might switch from, in somebody who's done very well in the first and hasn't had any problem at all in 4 years, probably you'll consider stopping. The first thing that will stop is steroids at 1 year, year and a half, and the patient hasn't had any problem afterwards, probably stop at 4. But if the patient has had some bumps on the way, switch to some other drug actually. Nobody really knows for how long you need to give these.
Can we do like, sir, yearly after 4 years of giving maintenance for rituximab, something like that?
That answer has to be in a setting of a trial. Standing on a podium, I don't think that can be given based upon the trial setting. Individual decisions have to be taken based upon your overall clinical assessment. And what is your threat of that disease lapse in a given patient?
Yeah, this question is persisting with regard to the duration of maintenance therapy in lupus nephritis as well. There also we still don't have a clear answer that this is the upper limit of maintenance therapy, and the same applies to ANCA vasculitis. There's one more question. There's one more question there.
Currently considering the emerging therapy avacopan, so once it's available in Indian context, where do you really place it in your treatment?
Replacing the steroids.
Yes, sir. So
yeah, you'll use it instead of steroids, but you will still use rituximab or cyclophosphamide along with those.
Yeah, but it's going to be extremely costly, so
as of now,
almost impossible to use.
Yeah, 1 CR as of now, I think, yearly cost.
Yeah, so we've come to an end to this interesting session. Thank you very much indeed, Professor Aman Sharma.
Thank you.
Thank you, Chairperson. Thank you, sir, for an incredibly valuable talk. Another captivating talk is on our way by Professor Ritambra Nada ma'am on histopathology in vasculitis. May I invite Honorable Professor Kusum Joshi ma'am, ex-HOD of histopathology at PGIMER, and Dr. Benzita Pinto to chair this session.
Photo doesn't match the person. Good afternoon all. So again, let me express my gratitude to Dr. Aman Sharma for bringing us together. The little bit that I've attended, it has been very exciting and wonderful for us. Nice to have met Dr. Bhamri again, who actually, I've been in the I was in the PGI, how many years back? 41 years back, or wherever. And I think he is the person who introduced us to the topic of vasculitis. It's with nostalgia that I remember his CPCs, how beautifully they were done. And I'm very happy to meet you once again. Thanks, Aman, for bringing us together. Dr. Ritambra, everybody knows her. I'm not supposed to introduce her, is it? Dr. Ritambra, everybody knows. She a deep interest in vasculitis as a renal pathologist, along with the other team in her department who are interested in the pulmonary part and the skin part and so on. So this sort of multi-system disease brings us together, and that's very, very nice. PGI has really, I think it's again credit to Dr. Bhamri, has been in the forefront of vasculitis. I used to belong to AIMS before I came here and knew Dr. Malviya personally as my teacher. And yet when I came here, I realized that we in PGI are far ahead of anybody else. So Ritambra, everybody knows, she is heading the renal path and the GI, whatever, branches of histopathology, and is a very astute histopathologist with a passion for detail. So, let me ask you to start.
Thank you, ma'am. And thank you, Aman, for giving me this opportunity. What I'm showing you is really a collection of photographs which we have collected while working up these rheumatology cases. And most of the faculty now who are DM here must be part of this collection. You will recall all these pictures whenever I'm going through this. And putting me in front of Ma'am Joshi, it gives me butterfly in my stomach, having an exam again after 30 years. I hope I shall go through it. So let's see what this collection means to us. So as far as pathology is concerned, there are certain set of conditions where the clinicians already had made up the mind that the clinical diagnosis of vasculitis is already in their mind, like skin biopsies, kidney biopsies done for renal failure, nerve biopsies, nose for GPA, lung biopsy, non-resolving nodules, and temporal arteritis. So here clinician is generally has already made up his mind, whereas conditions where pathologist sitting on her microscope has to take a call would be cases where there are ulcers, GI bleed, or stenotic lesions in GI or limbs or digits. These are the situations where it's a pathologist's hunch to pick up those vascular changes. And very importantly, at this point of time, we need to have a rapid diagnostic communication between our rheumatology team, which those who are here know that we have a WhatsApp group. We immediately call our clinical colleagues, because by the time patient goes from surgery, the patient would have lost this connection of getting a rheumatology consultation. So we make sure that before his discharge, we try to get rheumatology consultation while still the last discharge book is not made. So this is very important to, give the immediate concern which is required. Now this diagram, I think everybody sitting in this hall is aware of. I've put these boxes where it means that in large vessel vasculitis, though it's mainly radiology and clinical scenario would help us, but staining with IgG4 can help in a differential diagnosis. Similarly, medium vessel vasculitis, which are polyarteritis and Kawasaki disease, here again a role of immunofluorescence to pick up immune-mediated vasculitis of this caliber arteries is also a possibility, so we shall do that. And more importantly, in small vessel vasculitis. So here we know it's mainly the RPRF or the renal presentation which is important. Here there is a significant role of immunofluorescence to say whether it's post-immune or is an anti-immune or is a immune-mediated disorder. So we need to take help of these ancillary techniques. And as we know, in small vessel vasculitis, there are these groups which again are dependent, to some degree dependent on the tissue reaction. So to make a GPA, I would need to see granulomas, whereas absence of that will not really matter because they are present in only maybe 20% of the biopsies which we examine. Similarly, demonstration of immunoglobulins in leukocytoclastic vasculitis is the only way to make these diagnoses. And before I go further, what are large arteries, which are medium and small? We all know these are the large arteries. Visceral arteries are mainly the medium size and small ones are these smaller ones. But we have to remember that there is always an overlap. A small vessel vasculitis can involve even aorta, and a large vessel arteritis, we have seen in this very hall that pulmonary capillaritis has been demonstrated. So this kind of a overlap is there. So we always have to go by clinical, pathological and immunological summing up. It's not that sitting on microscope we can decide what way it is. Now, importantly, while we are evaluating, we look at the age of the injury to the vessels. So acute vasculitis means fibrinoid necrosis with neutrophilic debris. When this fibrin is resolved, we are left with lymphomononuclear infiltrate and some edema. And after some months, what we'll have is no reaction except for the fact when we do special stains, we would be able to see broken internal elastic lamina. So these are the features which would help us pick up these kind of stages of vasculitis, and it is important to age these vasculitic changes because there is a concept of when do we make a diagnosis of PAN versus an MPA or a GPA, where generally regions tend to be of different age, segmental involvement in PAN, whereas in ANCA-associated involvement of medium vessel vasculitis, it may or may not be same. For vasculitis, it is important, this neutrophilic debris is very important to pick up along with fibrinoid necrosis, because only presence of fibrin could mean this could be a thrombotic microangiopathy, but we need to see this neutrophilic debris as well along with endothelial injury. As a result of this vasculitic changes, the tissue reactions may differ depending upon the site and the duration. Like for in glomerular pathology, if it is immune-mediated injury, we tend to get proliferation. But if it is ANCA-associated or anti-GBM-mediated disease, we tend to see necrosis with or without sclerosis and crescents. And in GI, we may see small bleeds because of small vessel involvement. Similarly, if I come to medium vessel vasculitis, the polyarteritis nodosa will never involve lung and will never cause glomerulitis. So what we are likely to see there would be infarcts, and in GI again either infarct or stenosis depending upon what stage we have examined. Similarly, in large artery arteritis, the parenchymal damage could only be seen because of osteostenosis, which one could see. Now, coming up with some examples, I'll start with the kidneys first. So this elderly male having some hearing loss, these constitutional symptoms, hematuria, and there was a mass in the lung, and renal biopsy was done because he had ANCA positivity and PR3 positivity. So just a normal glomeruli. This is how they should be, and this is the Bowman's capsule where we will see crescents, and this is how arteries should look like. So what on a low part itself, you see there were many crescents which were occupying these glomerular spaces, and on microscopy there were different ages of crescent. This is necrosis, this is sclerosis, and these are the crescents. And then for crescents also we tend to age them. So necrosis here, special stains done for them, and the reason for necrosis is always a break in this basement membrane. That is the basic cause of having a crescent. And then this break in Bowman's capsule is again a feature which is seen in because of crescents, and then you age the crescent depending upon the constituents of its whether it's all cells or fibrosis. So this different kinds of crescents were seen here. In addition, we see a granulomatous reaction around the Bowman's capsule, but this reaction is not diagnostic of anything. That what I mean to say, it does not differentiate between GPA, lupus or any other situation. It's the interstitial granulomas which will be of use to differentiate. So if you have a granuloma around the glomerulus, so that does not differentiate, helps us differentiate between different categories. But these kind of interstitial granulomas would seeing that, I will favor a possibility of GPA over MPA or eGPA in absence of eosinophils. So IF has to be negative as it was, and since it was negative, so it was a post-immune crescentic GN. So we know how to differentiate them. The two main points which are differentiate between different kinds of these crescentic GN is high number of IgG4 cells and presence of different ages of crescent as compared to anti-GBM disease. Now we know this classification of crescentic GN is known. So what we know is that 75% of ANCA-associated GNs are systemic, but we should remember that a proportion will be renal limited also, and then we are supposed to differentiate between these three categories, and it is, as you all know, the granulomatous inflammation here with presence of eosinophils in eGPA, but the presence of clinical condition of asthma or atopy would be required. In absence of that, sitting in a lab, we cannot make the diagnosis. So once again, it comes to a clinico-pathological and radiological, a combined approach is required. And also when we are making this approach, we need to know what are the different systems involved in one particular set of diseases. So for that, this kind of a table becomes very handy. So another important point which I want to make here is P-ANCA, which is not very specific of GPA but can be seen. So in one such case, we had almost everything which looks like granulomatous polyangiitis. We have granulomas, we have the suppurative granulomas in the interstitium, we had periglomerular granulomas and vasculitis. and different ages of crescent. So we had almost labeled it as P ANCA positive crescentic with the possibility of being a GPA. But a lung biopsy done in this case had a necrotic lesion, and you see it was AFB positive. So the point I want to make is whenever we see this kind of a necrotizing granulomatous lesions, ruling out infections by all means, by morphology, by microbiology and by PCR studies is mandatory, because sometimes we may go wrong and it can be fatal. So we as a group, as a working team, we always take care of this part, that we definitely rule out infections by whatever means. Now coming to the lungs, we have MP, so lungs, in GPA one tends to have granulomatous solid nodules and different ages of granulomas with vasculitis, whereas in ANCA-associated pathologies, fresh and old hemorrhages with vasculitis is what we are going to see. In PAN, you never see any evidence of lung involvement. Now coming to skin, you do see this kind of leukocytoplastic vasculitis with an element of even what we call paniculitis when it involves subcutaneous fat. Then depending upon the nature of cells, the presence of granulomas, you would tend to put it into EGPA if you have a lot of eosinophils, as in this biopsy, and presence of accompanying granulomas. Now coming to role of IF, if you have a band test along with immunoglobulins, it is likely to be a lupus associated skin lesion. Depending, even you can have C3 associated vasculitis that has been known, and if everything is negative, then that is post-immune. Coming to medium vessel arteritis, PAN, Kawasaki and Dada, these are the main lesions. So I already showed you this vasculitis, but in Dada 2 vasculitis, the changes what we have seen is either almost leukocytoclastic type of a vasculitis like this, but situation where only these kind of a fibrin is seen, what we call something like TMA. So people call this as vasculopathy and vasculitis. These are the changes which are seen in Dada 2 vasculitis. In PAN, nerve biopsies is usually the ones which are sent to us, and this kind of arthritis where general principles of vasculitis are applicable are known. Now coming to GI, so if in biopsy once in a while you may have, because they are not really deep, sometimes we may have one fragment which may show us vasculitis and the diagnosis could be clinched, but otherwise it's generally the resections where we tend to make these diagnoses, where you have muscle deep ulcers, and within these muscle deep ulcers you have to locate these arteries and obliterated veins by special stains like this, and then depending upon your ANCA serology, you would, and presence of occasional granulomas or giant cells if present, you will favor GPA. If you have seen different stages, which is in a case which is ANCA negative, then you will put it as polyarteritis nodosa. And these are the pictures from our autopsy material where heart, this pancreas, and this periadrenal arteries, they are showing different ages of vasculitis, acute, subacute as well as chronic, and since it was ANCA negative, so we made it PAN. Similarly, even in an immune setting, if you have any kind of vasculitis and immunofluorescence shows presence of positive immunofluorescence, then it is immune mediated vasculitis, which is also known. Learning from Kawasaki autopsies, what we have learnt is that if you have myocarditis and coronary artery ectasia or ectopias or aneurysms, those are the conditions where non-fibrinoid necrosis kind of arthritis, if present, is the one which should prompt clinical team to consider Kawasaki, because we don't want to reach that stage of autopsy. But point is, if we are seeing, if there is some inference of having arthritis by coronary angiogram in adults, what they call a missed Kawasaki during childhood, and on autopsies corresponding to that we have seen this kind of angioectatic coronaries which are a clue. So that means in a clinical context, an ANCA negative patients which have this coronary angiograms showing you ectasias, those are the cases where Kawasaki disease could be considered. In DADA 2 vasculitis, skin, nerves and GI are the ones which we have experience with. The first case we had this leucoclastic vasculitis in the GI, and this is how the crypts were withering. So fibrinoid necrosis present in the wall and lumen. So obstruction, the thrombosis is very dominant picture here, and this kind of vascular unfolding is not seen in any other vasculitis other than DADA 2. This we have seen in multiple GI specimens which we have seen as if the capillaries have unfolded. So these seem to be unfolded capillaries with some evidence of vasculitis at other places. That is how the DADA 2 vasculitis has been in our experience. Large vessel vasculitis, mainly at autopsies. We all know that this kind of moth-hidden appearance of media with adventitial thickening having granulomatous reaction like this. But parenchymal lesions could be seen if the ostia are encroached, like here we saw renal infarct. And differential diagnosis of this is an IgG4-related arteritis, where this inflammation will tend to be plasma cell rich, IgG4 positive, and even medium vessel arteritis with storiform fibrosis, plasma cell rich inflammation, arteries of different sizes showing us different degrees of obliteration, and when you do IgG4 they were increased. So that is how we make large vessel or medium vessel arteritis because of IgG4. So in summary, what we have to understand is that in appropriate clinical context, we have to suspect, seeing on the in our whatever surgical material which is available, do special stains, rule out secondary causes. Always infections have to be ruled out. Key is morphology, and a rapid communication with the clinicians is the key to get them to the right diagnosis at right time. So that is all I have to show, and collaboration between all our teams is very, very important. Thank you.
Thank you, Dr. Ritambra, for that informative session and taking us through all types of vasculitis. And I think it brings back the memory of CPCs. I really miss the CPCs, and I must say that even in our national conference, when Madam does CPC, the hall is overflowing. So I now open the session for questions.
It's pathologist. Anybody? Yeah, very right. Yes, I think the key point, one of the key points is that for usual practicing pathologists, one should always be aware of vasculitis. It's the skin we are seeing, but it's come from the patient. So therefore, systemic vasculitis, once you make a diagnosis or you suggest a diagnosis, then the Vasculitis Society must be part of your curriculum as a pathologist. Yes, that's right. And it is gratitude to our forefathers, really, who had set the stage for autopsies and CPCs that, diseases which are systemic have really, given the knowledge from the PGI to the world. I think that comment is required, so that the CPCs, they started in sort of 63 rather than now. Thank you.
Yeah. So I think even surgeons, they take out gangrene, they take out stenotic segments and send without wanting to have the results back. But once we see, because for them they have done their job, but we have to make the diagnosis and communicate at the right time so that they get connected to our rheumatology team. And Aman he can vouch for it, that way we have really, made the patients take treatment. Otherwise they would have gone home.
Very true. And outside the world, outside of PGI, the world surgeons don't want to know, So here at least we had that advantage that they all wanted to know, yes, we saw vasculitis, which had caused the gangrene,
Thank you.
Thank you.
Thank you, chairpersons. Thank you for such a visual greet and an informative talk, ma'am. Now we are heading towards the most awaited moment, Professor S.D. Deodhar Memorial Lecture. We are privileged to have with us today Professor Pradeep Bamri sir, a distinguished personality and eminent speaker who has left an indelible mark on everyone gathered here. We are accustomed to hearing your accolades with great admiration every now and then. So for this session, may I invite our esteemed chairpersons, Professor Amod Gupta sir, ex-Dean Academics and Head Department of Ophthalmology, and Professor Subhash Verma sir, ex-Dean Academics and Head Department of Internal Medicine at PGIMER, to chair this session.
आप करो नहीं this is your show I'm just an addendum
Yeah.
I don't know how many of you have seen this.
So, good afternoon. Thank you, Aman, for asking both of us to be present on this very important oration. I think people of my times, that means most of you are sitting in the front row here, Pradeep and Dr. Amod Gupta, knew Professor Deodhar very well. And not only was he a gentleman, but he actually had a rheumatologist, but he was a wonderful human being. So he started rheumatology here, and you now see how rheumatology has progressed. That is how many things in Department of Medicine actually started. We all started together, and then the department grew. What Pradeep is showing you is something that he was very adept at before we had PowerPoint projections. And these projections were actually, we always looked for, were better than PowerPoints at any time. The animations that you see in PowerPoint came much later than PowerPoint came, and this came much earlier. Dr. Pradeep Bamri has already been introduced. We were together. In fact, we shared the same floor, and our rooms were across each other. So I can take all time talking about him, but I would not take any more time. Pradeep is a wonderful orator, and I would just like you to see how he would do things earlier and what he has to say about Professor Deodhar and rheumatology in general. Pradeep?
Thanks, Subhash. It is a moment of great nostalgia being here. The first time I ever addressed an audience in this room was in a statistical meeting, and I opened my mouth and no words came out. Now they don't stop coming out. So it's a little different. But the late Professor Deodhar taught me how to present. And this is an example, an early example of presentation. This transparency was made for a palliative care meeting in 1999. So it is 25 years old. But it is timeless because we looked at the problems of communication between the doctor, the patient, and society, which are as relevant today as they have always been. So what I looked at here was trying to see the various aspects of this problem and the expectations of the doctor, the patient, and society. And we used another flap, which brought the doctor, and this time brought the society into it. right? And then there were issues regarding where conflict came in, with expectations of treatment and treatment conspiracy, the control of costs, the preservation of patient autonomy. And all of that, as you know, yeah, so resulted in chaos. Now there's a lot of chaos on this transparency, but it comes in stages. It doesn't come as one. And that chaos is persisting in society. I read reports of doctors being killed, attacked, hospitals being burnt, and that's a reflection of this conflict. And we wanted to talk about another thing, and that was the acceptance of futility. So I'll leave this here because this is not the subject of my talk. My talk was about Professor Deodhar. It has something to do with what he taught me and what I think he thought, but it's also about the milieu of medicine that we work in. How does one start this? So that's Professor Deodhar. He was a wonderful, benign human being. How does it move? From here? May the 3rd, 1938 to May the 6th, 2011. And for me, he stood for a, how do I get this to work? Research curiosity, scientific honesty, intellectual probity, fiscal integrity, the ethical practice of medicine, a commitment to teacher training, humility, departmental democracy, and honoring a bet of a bottle of beer for a bet that he'd lost. So nothing sums this up better than Mark Antony's words at the end of Julius Caesar. His life was gentle, and the elements so mixed in him that nature might stand up and say to the world, this was a man. What's happened now? It's not moving. All right. Just click here. Here? Just go back. Thanks. Yep. In the year Professor Deodhar died, the term Wegener's granulomatosis was renamed, or the disease of Wegener's granulomatosis was renamed granulomatous with polyangiitis. So I thought I'd use both events occurring in 2011 as a starting point of some reflection. It's not necessarily medical, but it's a reflection because he was involved with our studies, he encouraged our studies, and while all America was saying Wegener's granulomatosis, RIP, I thought we need to look at the disease a little bit better. Now, Professor Deodhar's wife, Shashi, started off as an ophthalmologist and became a poet. So I have made an attempt at some poetry in this presentation as a tribute to both of them. And that's especially for Anant and his family. So, while Weimar died a stuttering death, the Weimar Republic was what was forced on Germany by the conquering powers at the end of the First World War. And this is a manifestation of that. It's a banknote of 50 million Deutschmark. which probably bought you a loaf of bread in those days. Impatient Hitler waiting in the wings. So that's the history. Medicine witnessed a painless new birth. And this was due to a first description of this condition by Hans Klinger, and that's the reference. Tied in Klinger's autopsy apron strings. A friend at school, he and Wagner were friends at school. He joined the fray, adding insight to its shades of gray. Now, shades of gray had a funny meaning in 2011, but I don't want to go into that. And that's the reference from Friedrich Wagner. And this is a photograph of both of them together late in life. Initially thought a nose, lung, and kidney puzzle, because that's what's in the name of the reference. More patients seen made it a bigger muddle. In time, the spectrum did emerge, and as we know, all organs could, in its depths, submerge. Nothing escaped. Clogged up sinuses without a break, ulcerated agony, often hard to take, and these are patients seen here while Professor Deodhar was still here. Copious crusts making kerchief gore, sleep brought rising decibel snore. Deafness, pain, and oozing ear, and these are all my patients. So this is a patient whose biopsy from here gave us a diagnosis. There's another patient with a grommet. Bad luck mixed with many a tear. And this is for Mod. Red eye and bulge, tears and pain, scleritis, dacrocystitis, proptosis, and perforation. Treatment merely monetary drain. Skin spots and knots, and Dr. Bhushan will be interested in these pictures. Ulcers and sore. Painful darkness, blotchy fingers wore. Febrile ache, fatigue, no go for chore, drenching night sweats, frequent encore. Constant cough and bloody spit, delivered hard, unanswered hit. X-ray request, the radiologist call, a TB twist wasn't quite on the ball. Defeated physicians, we proclaimed the dead. A pathologist's wise nod we came to dread, because that's the CPC culture of the PGI. And this is an unfortunate patient of mine. This is a fresh specimen photographed at 2 o'clock in the morning. And Rithambra has just done all this, so I'm sorry to tread on your toes. Vasculitis, nephritis, granuloma, and more, thrombosis, necrotic dysfunction galore. So that's the summary of the pathology. No bragging man, he claimed it not. So Wagner never wanted it named after him. The first reference to it, his name, was in paper in Nord Med in 1947 by Ringertz. But indeed, Godman and Chugg made him hot, because this is the first major publication in the English language, which is 1954. For years it did with lives elope, death sentence without any hope. This is a summary in 1948, which showed a 2-year survival of less than 10% and an average untreated survival of 5 months. And the reference is there for everyone. Steroids alone in generous amount failed to register a cure account. Then Fauci and Wolf tested illnesses tied against cancer drug cyclophosphamide. And remember the debates, and this is all part of history. This is a young Anthony Fauci, not, here's a picture now, Sheldon Wolf, who he considered his mentor. The skirmish was most handsomely won. The drug was crowned, we took step one. And that's the reference one of the debaters gave today. Mayo's bulging records in a numbers game found ELK, and elk is this animal, but they made a classifying system which was a precursor of lots of other systems in 1976, where it was E was for upper airways, L for lung, and K for kidney. Protocol NIH emerged. It wasn't in vain. It held its sway to worldwide acclaim. That was the protocol for treatment of all systemic necrotizing vasculitis, 1979. The 5-year survival of 75%, which is a far cry from 20 years earlier. Somebody will have to help me again. Sorry, Aman. Okay. The gaping void for a laboratory test, ANCA ably filled after strong inquest. This is the first report by Van der Wood, and that was putting the seal on it several years later. In monitoring patients sick and well, does Birmingham's scoring trio dwell? Professor Paul Bacon graced this hall on more occasions than one, and he was responsible for developing BVASC and the vasculitis damage index. Systematized trials by European merge let rational treatment steps emerge. And these are examples of what collaboration in science can do. There are such just two references. Then the tide of science at full surge met a rising cry for a name to purge. Right? And these are two papers that questioned Friedrich Wegener's past. It is in 2006 and in Chest in 2007. Oh, sorry. Can you go back? Yes. The charge was a tainted mentor, which we can talk about, a missing file from a war times tribunal, and a letter that he wrote to somebody to blame. His work as a pathologist in the ghetto in Lords marked his wartime shame. So tainted mentor, missing file, and letter to blame. Pathologist's work in the ghetto in Lords marked his wartime shame. I think you better stand here, and I'll say next slide, please. Right. Less likely to make a mistake. So this is a little digression. So Friedrich Wegener was born in 1907. He joined the Nazi Party like many Germans in 1932. He described the condition in 1936. He worked as a pathologist in Poland near a Jewish ghetto. In 1989, he was awarded Master by the American College of Chest Physicians. He died in July of 1990. In 2010, the American College of Chest Physicians stripped him of his master title And his name was removed from the disease by a consensus between the American College of Chest Physicians, the American College of Rheumatology, and the American Society of Nephrology in 2011. Now, his mentor was Martin Stemler. He was a firm believer in racial hygiene. So that's the euphemism for National Socialism. But Wagner, not a single shred of evidence has been unearthed by the people who wrote those papers, and they went looking for it. Next, please. So, convicted without defense of unsought fame, soon Wagner's had a posthumous new name. You realize the absurdity of it all, right? So we're talking about medical politics, sorry. So it was renamed this. Next, please. And the Church-Strauss syndrome was also renamed as eosinophilic granulomatosis with polyangiitis. Europe didn't resist the pressure to rid it of its scientific treasure. And that was Jacob Chork, who's from Belarus, although he worked in the Mount Sinai Hospital in America, but they removed his name as well. And Vinay will know him as one of the founders of renal pathology. And Lotte Strauss was a founder of pediatric and perinatal pathology. She was German, and because she was a woman, she had to study medicine in Italy. And that's a reflection of the times that they grew up in. The Japanese held firm against the drive, keeping Takayasu and Kawasaki alive, right? The question is, but can we really expunge a name from all the tomes we need to tame? And that's a library. A Google search merely found out 747,000 new jobs to worry or cheer about, depending on whether you're a librarian or an economist. Because that was the number of citations for Wagner's granulomatosis before the name changed. Now, there are some facts here which I want to share with you. There were Nazis who achieved their fame, people who didn't hide their Nazi past. Next, please. And this is one of them. This young man, now just go back. Just go back, just go back. No, back, not forward, back. Yes, go back, yes. This young man, studying music in the 1930s, became Herbert von Karajan, who is recognized by all music aficionados as the greatest interpreter of Beethoven's music and the musical director for the Berlin Philharmonia Orchestra. Next, please. So he was born in 1908, around Wagner's time, joined the Nazi Party in 1933. He held a rank in the Nazi Party of General Music Director. He was a lifetime chairman of the Berlin Philharmonia Orchestra in 1938. They got rid of all their Jewish musicians at that time. He conducted Wagner all over the conquered countries in Europe. And he became musical director for life in 1955. And when he died in 1989, and his centenary was celebrated by English musical industries with 5 boxed sets of his CDs. So that's the tribute that he got. Next. And that's one of those boxes. Next. There's another young man, seen here in a military uniform, and he's keeping interesting company because this gentleman here is Heinrich Himmler. He was the chief of the SS. This young man, next, became Werner von Braun. He made the V-2 rocket with which he pulverized London, and he used Jewish slave labor to build the ramps in Western Europe. He still couldn't stop making rockets, and he made Saturn V for the United States. And he liked fame and company, so here he is with President Kennedy, ended up becoming Times Man of the Year. Next. He was born in 1912. He also joined the Nazi Party in 1933, became a full professor at the age of 31. He had a rank in the SS, which was the most vicious of Germany's instruments of its expression against Jewish faith. He developed the V2. At NASA, he developed the Saturn V, made cover of Time magazine, and died on the 16th of June, 1977. He died of pancreatic cancer, and he is buried in the Ivy Hill Cemetery in Alexandria, Virginia, along with descendants of George Washington, right? Now this is Kurt Waldheim as a young person. He was born in 1918. He was a military, he was a soldier and then rose up. He got the Iron Cross for his work in the Balkans in the Second World War. And he was on the staff of General Alexander Lohr. General Alexander Lohr was executed as a war criminal, right? Next. Kurt Waldheim, however, became an Austrian diplomat. He was foreign minister from 1968 to 1970. He was Secretary General of the United Nations 1972 to 1981, President of Austria 1986 to 1992. He got a papal honor from the Vatican, Order of Pius IX from Pope John Paul II. And when he died in 2007, he was given a state funeral at St. Stephen's Cathedral in Vienna. Next. Not only that, as Secretary General of the United Nations, he recorded the greetings from Earth on the 2 gold records on Voyager 1 and Voyager 2. These are the farthest man-made objects in the universe. They are 15 billion kilometers away. So his voice is the human voice that has gone the farthest. Next. And he was buried at Zentralfriedhof in Vienna. Next. So we come back to our story. There were Nazis who achieved their fame, Karajan, von Braun, and Waldheim to name. Next, please. They lived post-war to salutes and acclaim. And this is a picture of Hitler watching a Karajan concert in the 1930s. This is von Braun with Himmler, and that's Kurt Waldheim with his superior officer. And in later life, this is Karajan being escorted into the presidential palace in Germany by the president of Germany. This is, he's traveling with President Kennedy, and Kurt Waldheim having polite conversation with Golda Meir. So it's the irony of it all. Next, please. Death brought more honors, not disdain. And that's the crux of the matter. Next, please. The question that I wanted to ask all of you in the audience today, because I asked myself this question, is should thinking men in science's fold, taking footsteps good and bold, bay for blood that's long gone cold? So Wagner died in 1990. They went on a witch hunt 20 years later. Next, please. So, by the same yardstick, should Karajan's Anif Memorial burn? This is the town where he lived in near Salzburg, who erected this memorial for him. Next, please. 200 million discs with it in an urn, because that's the number of discs he has sold as a conductor. Next. Or will Saturn V to ash and dust return? It's in Houston. It's a picture I took. Next, please. In an unmarked grave at Houston's turn. Next, please. Will Waldheim's presidential rest be vandalized, as is the fashion these days? His remains desecrated before they are balkanized? because that's where he played his mischief. Come back to the question, should thinking men in sciences fold, taking footsteps good and bold, bay for blood that's long gone cold? Or, next please, or should we just let bygones be, look ahead and let it be? And I think Dr. Deodhar would have agreed with me. Thank you very much for your attention.
Thank you, Pradeep. I thought I knew you very well, but I didn't know your poetic side.
Oh, I never done anything else. I just did this.
Yeah. But I think you should continue to do that. Very, yeah. Teach rheumatology in poems.
Okay.
I think it was a wonderful oration, and I think way of remembering Dr. Deodhar, who would have actually enjoyed it very much. All of us did. And thank you for raising that question, actually. Should we actually change history, or should we take away the names of the people from where they actually belong? It's a question that requires introspection. Thank you very much, and I hand over to the organizers for the next bits. Yeah.
Thank you, sir. That was truly once in a lifetime experience for most of us. Sir, you. So may I now request the chairpersons, Professor Amar Gupta sir and Professor Subhash Verma sir, to felicitate Bhamri sir.
I'm overwhelmed by this. Thank you so much. Thank you so much. Thank you so much.
Pradeep, if you allow me a few words, and I think all of you, probably you have not seen him in action in this lecture hall, which he did with great aplomb 20 years ago or 18 years ago. You know, there used to be spellbound, the pathologist included, when he spoke to speak, got up to speak. I think he has raised a maybe $1 billion question of ethics coming in conflict with science, and even the Nuremberg trial probably didn't do justice, hanging some of those physicians and their assistants for doing some of the experiments. So we don't know whether the science, was practiced by Wegener, was in alignment with his political or his, alignments. Even today, we have doctors, we have scientists who are politically aligned, with a particular viewpoint, and we have people who are simultaneously doing great science. Doesn't mean that we should be. So I think he's made a very strong point, Bhamri, and I think heartiest congratulations to you, bringing out the best of this conflict, which I called crossroads at the science and ethics, which we all deal with every day. Thank you.
Thank you so much, sir. May I request everyone to please wait for a couple of minutes. Director, sir, is on the way. We will be having inauguration in a couple of minutes. Yeah, yes.
DPGI had a delegation from Delhi. He's on his way. He's just about to reach amongst us. We'll put the things together, and once the things are put, probably we'll have those. We can have this projection off, I think. So because we have the backdrop, can somebody stop the projection?
Good afternoon, everyone. And I, on behalf of the organizing team, I welcome you all again to this CME-Current Perspectives in Rheumatology 2025, being organized by the Department of Internal Medicine. Now I would like to welcome our distinguished dignitaries onto the dais. Our chief guest, Professor Vivek Lal, sir, Director PGI. Sir, please. Professor Sanjay Jain, sir, Dean Research and Head Department of Internal Medicine. And Professor Aman Sharma, sir, Organizing Secretary of this conference. May I now request Professor Sanjay Jain, sir, to give the welcome address.
Good afternoon, esteemed colleagues, distinguished guests, and my dear friends. It's my great pleasure to welcome you all to this CME on Current Perspectives in Rheumatology. It's a gathering of some of the brightest minds and the most dedicated professionals in the field of rheumatology. It's a profound honor to stand before you today as a part of the family that represents 3 generations of medical professionals. Being a part of this legacy is both a privilege and a responsibility. To the first generation, that's our pioneers, our teachers, Dr. Amod Gupta, Dr. Vinay Sakuja, Dr. Subhash Verma, Dr. Pradeep Bamdi, Dr. Kusum Joshi, Dr. Dilavri, Dr. Bhushan Kumar. All of you, sir, have laid the foundation with your dedication, wisdom, and unwavering commitment to the patient care. Your guidance has shaped not only our careers, but also our values. To my own generation, the second one, we have had the benefit of learning from those before us while adapting to the rapidly evolving landscape of medicine. It's now our duty to bridge the gap between tradition and innovation, ensuring that the core principles of compassion and excellence remain central to our practice. To the third generation, that's our students and alumni, that's our future, you carry the promise of progress and new discoveries. You have come a long way on this demanding yet rewarding journey. Your resilience, dedication, and hard work are a testament to your passion for the medicine. We are proud of you for what you have achieved and excited for the contributions you will make to the medical field. It's an honor for me to talk about the sacred and time-honored tradition of Guru Shishya Parampara, a cornerstone of the transfer of knowledge and wisdom in Indian culture. This tradition dates back to thousands of years, and it represents the profound relationship between the guru, that's teacher, and the shishya, that's the student, built on a foundation of trust, respect, and devotion. A teacher's role in medicine goes beyond just the lectures and the textbooks. It involves mentoring the students in decision-making, critical thinking, and the human aspects of healing. Let us uphold the spirit of this sacred tradition in our medical practice and education. May we, as both teachers and students, continue to honor this timeless relationship, ensuring that the light of knowledge and wisdom is passed from one generation to the next. On behalf of the organizing committee, I extend my deepest gratitude to our speakers, sponsors, and participants for making this event possible. Your dedication and expertise are what drives progress in the field. Thank you for being here, and I wish you a very productive and promising CME. Thank you very much.
Thank you, sir. May I now request the dignitaries on stage to lamp the... And now I invite our Honorable Chief Guest, Professor Viveklal sir, to address the gathering.
So, my teachers, my gurus, and all those in this hall who made a man out of me, at least that is what I think. I'm really grateful to each one of you to be here today. This is a Sunday afternoon, sir. And I often say one thing. I always begin my speech that way, that this generation does not know how much we owe to these founding fathers. So may I request you all to give them a round of applause before I move on. Friday morning 8 to 9, this used to turn into a war zone. Something called a statistical meeting used to take place. It still takes place, but nowhere compared to what it was during our times. Okay? But once they were out of this room, it was PGI, and the betterment of PGI and patients, which mattered to those who fought like lions here. That is what we grew up with. Love for PGI, love for our patients, dignity to the flag of PGI, and do everything possible to keep the flag of PGI flying high. That is what we expect out of you. Professor Bhamri was no exception. I came like a vagabond from Amritsar Medical College, and those of us who knew Professor Bhamri, he could smell me 2 miles away, because I work and Vivek Lal were 2 poles apart, this side, and he could smell me 2 miles away. Then my good luck, I got engaged to a girl called Sadhna Bhasin, and he caught me outside the, 4th floor lift and said, "Hey man, you got engaged to the right girl." And things changed after that. That was Professor Bhamri. If he hounded you, no one could protect you. Let me tell you, no one could protect you if he would hound you. And if he loved you, he would give his life for you. Sir, we've learned those values from you. How much he cares for his students, we know. And Aman is a living legacy. Aman is also a chatterbox. I mean, you talk to him, he just go on, he doesn't stop. He talks more than I do. But he is a classic example of having been mentored by a giant called Professor Bhambri. We owe you an acknowledgement, sir, that we can never muster. We are very honest about it. We can never muster the acknowledgement that we owe to you. You did so much for us, Professor Amod Gupta, Professor Vinay Sakuja, Professor Dilavri, Professor Bhushan, Professor Kusum Joshi, Professor Subhash Verma. We can never repay our gurus. We can never repay our gurus. It's very easy to come and speak in front of the mic. Itna research impact factor, tab tha, ab itna, so all that is cosmetic. But the true value of what they have done for this institute was evident today. That forced me to miss Professor Bhambri's lecture. Why did I miss Professor Bhambri's lecture? Because the government of India had sent the Secretary of Chemical Industries specifically to PGI because they wanted inputs from PGI to conduct clinical trials in the medical field. Why? Because they felt PGI is the only institute which does clinical trials without a conflict of interest and an open mind. So a high-level team had come, and you can imagine, all this is because of the values that we are imbued with. All this is because of what you have given us in your legacy. Thank you so much, sir, for coming. Sir, we, for selfish reasons, would want you to be here again and again. I know Australia is very far, I understand that. But for selfish reasons, we would love to see you again and again, maybe annually once, sir. Let us know you are here so that we all can gather together and go back to those years when knowledge reigned supreme and when you had those lovely, lovely transparencies. Thank you so much, sir. God bless you, students. This has been, you are lucky to be here today. You are lucky to be here today. I can tell you just how badly I was hounded by him. Oh my God. I can tell you. No ends. But that is it. That made a man out of me. At least that's what I think. I mean, that's what I think. You have to understand, when we would have our rounds were followed by tea. The hounding was forgotten. 5th floor, chat pe. You call it 6th floor, right? There were no solar panels then. Kasoli hills were visible, and once a while Professor Bhambri would. Well, that's besides the point, right? Okay? We would all enjoy a cup of tea, and we would then come back and get back to brass tacks again. These are our values. This is what we want each one of you to know. This is what PGI stands for. This is what our flag exudes. And that is what makes PGI a mecca and a powerhouse of medical knowledge in this part of the world. Namaskar.
Thank you, sir. So now it is a time to felicitate our legendary professors. It is with great honor and admiration that we invite you to a special felicitation ceremony to recognize your outstanding contribution for this institute and the field of medicine. Your dedication and lifelong commitment to excellence have inspired countless students and academicians, and we wish to celebrate your remarkable achievements over the years. So may I now request the dignitaries on dais to felicitate, starting with Professor Vinay Sakuja, sir, who was ex-dean and head of the department nephrology. So may I now request Professor Ahmad Gupta sir to come on stage. May I now request Professor Kusum Joshi ma'am to come on stage. May I now invite Professor Subhash Verma sir on stage. Director. May I request Professor Dilawari sir to come on stage. May I request Dr. Bhushan sir to come on stage? Sir, please. Oh,
and we can recycle, don't worry.
Thank you, sir. May I now request Sanjay Jain, sir, Chairman, Organizing Committee, to felicitate our Director, Vivek Lal, sir. Thank you, sir. I now invite Professor Aman Sharma, sir, to propose the vote of thanks.
Good afternoon, everyone. It is indeed very difficult to speak after two legends, Professor Bambri and then once Dr. Lal has spoken. But it is my great privilege, actually, amongst this august gathering to propose a vote of thanks. First and foremost, I must thank Professor Vivek Lal, sir, Director PGI, for sparing his invaluable time to grace the occasion. Actually, to tell you, I mean, those of you who are working in PGI, they know that Lal sir doesn't really get associated with many of the inaugural functions in the conferences and CME. So it probably I'll consider this as one of the few exceptions where he comes and inaugurates the CME. Thank you very much, sir, for being with us here and making that exception. And now we know the reason, because his fondness for our teachers, for PGI, for ethos of PGI, and I think the sentiments associated with it were probably the reason behind that he's here. He's always been very supportive of our efforts, which goes way beyond what has been said, and many times what is not said also, but what is meant. Actually, thank you, sir, for being with us today. I must also thank Professor Sanjay Jain, sir, Chairman of the Organizing Committee, for all his support for conduct of the CME. Thank you, sir, for being with us. I must thank my mentor and guru, Professor Bambri, who has been my motivation behind the field, and you've heard about him. The words actually fail me to express, and I think part of what has been echoed by Professor Lal sir already. And those of us who listened to him in his element, they know what it meant. Actually, I was one singular lucky person who was accompanying him first as a senior resident and then as a junior consultant. And I can tell you, each day taking rounds with him was such a pleasure. Whatever the words that he would speak would actually get imprinted on your mind. And I got so many life lessons from him. Couple of those were like, once he told me, Aman, your competition is with yourself. That day I decided that I have to evolve as an individual. I don't have to compete with anybody else. So we shouldn't be in a rat race with anybody else. We should try to become a better version of ourselves, actually. And you know, the other thing that which he told me, which we have our residents here, which they must always remember, and I think that has a meaning if you understand what it means. He told me that if you do whatever you do, you should remember that your name is associated with it. If you value your name, whatever you do, you will do it to the best of your ability. Actually, that's what my father has also told me. Try to do things to the best of his ability, and I think he's also in attendance today. He wanted to hear Professor Bambri. So I think the residents must remember these things. And I can tell you, if you remember these two things, you will be different from the rest of the lot. Although you've come to PGI, you are already better than the best. But still, you can't just be the leaders here. You can be the global leaders. You can be the leaders in the world. So many people who moved from these halls are leading so many societies across the globe. And what stops you from thinking on those lines? Once you start thinking on those lines, one of you or many of you will be there. Actually, so that is what I have to thank Professor Bambri for that. I also have to thank all the legends we've spoken about. Professor Vinay Sakhuja, sir. The time restricts me, but when Dr. Bambri had left, and sometimes you need a shoulder to fire a gun. Yesterday in the alumni meeting, people were telling me, when I used to tell on the rounds, you have to give methylprednisolone, well, you want my shoulder to fire the gun? Actually, many times, I don't know whether sir would remember, I would go take the file, go to him, because giving immunosuppression in somebody who's very sick, and I was scared of that Friday morning more than anything else, he would say, you want to give steroids? Okay, you can write my name and give steroids. So these are the legends who give you so much confidence. Actually, it was post Dr. Bambri era, and and then many occasions later on. And then I was also lucky. After one joint, I was associated with Professor Amod Gupta. From him, you could not only learn medicine, but to how to be a good individual, how to be a good professional, how to conduct yourself. It was my good luck. Once Bambri sir left, I had to work with him for many years. Till his retirement, I used to go to the Uveitis clinic. And then Professor Subhash Verma sir, actually he was a role model teacher. Those of you who attended LT once, they know he was sitting here at 8 o'clock. If he is not here at 8 o'clock, means he is not in Chandigarh. So that is the kind of discipline that all the younger generation need to have. If you have to come here at 8 o'clock, and that's what the first thing he told me when I became a consultant. Aman, I want you to be here at 8 o'clock. And I think I did try to be here at 8 most of the times, if not as much as you were, but most of the times I tried to be here at 8 o'clock. And also Kusum Joshi ma'am, I think we all know, we've seen the CPCs done by them. A vasculitis person can never be complete without pathology. And I think we saw Bambri sir and madam doing CPCs together. Wagner's case you had done. I was probably as a senior resident, I saw that case as the first case. So we cannot thank them enough, actually, even if we try. So with this, I think I also thank Anant, Dr. Deodhar's son and his family. They are in attendance today. Thank you very much, Anant, for coming here. Many of the people sitting here must have been your uncles and aunts, and they'll be very happy to meet you once again. I think I thank the CME faculty Many of them are our PGI alumni who have spread all over the country. There are only few states where they are not there, and those states also we have the current generation of DM students. Probably in next couple of years we have the entire country covered by the PGI DM alumni all over the country. So, and also I must thank the faculty from GMCH, Dr. D. Cruz was here, and there are other faculty from the surrounding government medical colleges who are here to support. I thank my faculty colleagues, especially Shankar, who has done a lot of behind the scenes work. I must thank him. He's got, thanks to the selection committee and our DPGI, he became additional professor. I think yesterday his one foot was amongst the organizing committee efforts and the other was in Carom Block to probably join as an additional professor. I must also thank all my DM students. Some of them, they said yesterday that of all the people they dreaded me the most. But probably, you know, you can now understand what was there in the past and what is there now. So, you know, probably ye dar thoda acha hai, I think that's what I can say. So thank you very much for putting all that effort. And I thank all the delegates, those who are here in person. And we have more than 100, sir. I think Pankaj can tell me more than 100 online, I think, who are also listening from, and people are tweeting also already, listening from those who are not here. They are already tweeting about the activities which are going on. So I thank the projection team, Mr. Hiralal, Hiraji, telemedicine team, Pankaj is there, the catering team, Nand Kishore ji is, I think he has been the caterer for generations of PJ CMEs, and I think the housekeeping team, our departmental colleagues, and everybody else. I might have missed out a couple of names. My apologies, and I think with this we'll finish off. Thank you very much.
Thank you, sir. May I now request everyone to stand up for the national anthem.
We are now moving on to spondyloarthritis. First up is debate on the topic of whether TNF-5 should be chosen over anti-IL-17 inhibitor in psoriatic arthritis. Dr. Siddharth Jain will be speaking for the topic and Dr. Saket Jha will be against it. To chair this session, may I invite Professor Sunil Dogra sir from the Department of Dermatology at PGIMER and Dr. Shankar J from RNR Army Hospital, Delhi. Over to you, sir.
Good afternoon, everyone. So in this post-lunch first session, it's going to be on spondyloarthritis. And the first part of this session, we have very interesting debate whether anti-TNF should be preferred over anti-IL-17 in psoriatic arthritis. And to speak on this, we have two young rheumatologists, Dr. Siddharth Jain and Dr. Saket Jha. And for this, now I invite Dr. Siddharth Jain, who will be speaking for anti-TNF should be preferred over anti-IL-17 in psoriatic arthritis.
Can I have my slides, please? सीक्वेंस वाइज है
पूरा कॉपी कर लेता हूँ इधर
it's my job to not make you feel bored. I am here on this podium after a gap of 3 years. Last I did a staff CPC as a pool officer in this very department, and it gives me immense nostalgia to be back on this platform. Today I'll be debating on anti-TNFs and whether they should be chosen over anti-IL-17 in patients with psoriatic arthritis. I'll be speaking for the motion. And since I've been pinned against the mighty Nepal Naresh, as the departmental people would know it, I would be failing in my duty if I don't start this debate by paying my humble obeisances to him. And what I'll be doing over the next 7 minutes would be trying to play the role of Birbal to Akbar and trying to make him realize that probably he cannot survive without Birbal. So when we talk about psoriasis, psoriatic arthritis, we need to understand it's a complex heterogeneous disease. There are different pathogenic mechanisms which are operating at different sites, and the health related quality of life for the patient depends upon both the activity in the skin as well in the joints. So this is how we need to look at psoriasis or psoriatic arthritis. So there you have the skin and the nail disease. Then you have a musculoskeletal disease which can span from peripheral arthritis to spondylitis to enthesitis dactylitis. On the periphery you have extra-articular activity, the form of uveitis and IBD. And there is a significant chunk of cardiovascular morbidity, more so in psoriatic arthritis because of the association with metabolic syndrome and a whole lot of comorbidities. So this is the entire spectrum of psoriasis, psoriatic arthritis, which we need to keep in mind while interpreting any data or any published literature in this field. So psoriatic arthritis is one disease where there have been a whole lot of class 1 evidence that has been generated over the last 2 decades. It's like ANCA vasculitis, class 1 evidence in rheumatology is sort of rare, but in psoriatic arthritis it's a fertile ground. So as we can see the timeline of approvals, so early in the 2000s we had anti-TNFs coming into the picture, both approved by the FDA and the EMA, and then around 7 to 8 years back we had anti-IL-17 coming into the picture. And the last kid on the block is the IL-12 or the IL-23 blockers, which is not the talk of the current debate. So if we talk about the different domains of psoriasis, psoriatic arthritis and the responses of various drugs that we have at hand, today we are talking about TNFs and anti-IL-17, and we can see that all of them are working very well across the board for the different domains of the disease that we talked about, leading to us having a problem of plenty. So we have so many choices, so many options, but as a clinician, what do we want to know? We have a conventional synthetic DMARD inadequate responder. We want to start the patient on a biologic. So the question that we want to answer is what biologic to start upon. So the problem is all these class 1 evidences, or most of these, are placebo controlled trials, as is the norm in rheumatology. Head-to-head trials are very difficult to conduct, and that's a problem. So what we end up doing is doing indirect comparisons, performing network meta-analysis, etc., but they have their own methodological flaws. What we need is head-to-head trials for which there is a paucity. So I have known Dr. Saket for more than a decade now, and I know what he's going to say in the next 7 minutes after I leave this podium. He will be educating you about the IL-23, IL-17 axis, how it's central in the pathogens of psoriasis, psoriatic arthritis. TNF is something for rheumatoid arthritis. Then he'll make you get lost in numbers. So look at the numbers of IL-17. Look at the numbers, numerical significance. How can you go against IL-17? Then being in India, he will also talk about TB, anti-TNFs. TB, look at IL-17. Absolutely safe from a TB aspect. You give the IL-17 once in 4 weeks, once in 8 weeks. और यहाँ anti-TNFs देखो हर हफ्ते, हर 2 हफ्ते. And you have better persistence. So this is what he's going to be talking to about, as I anticipate based on my knowledge over the last 12 years. But what I want you to understand is, if you are knowledgeable, you are immune to propaganda. So what I'll be doing over the next 5 minutes is make you knowledgeable about all of these things which he's going to tell you about, but in a way that he's not able to influence you through his propaganda. So this is the head-to-head trial that both of us will be talking about. There are 2 head-to-head trials. One is Spirit H2H and one is Exceed. So Spirit H, both of them were published in 2020, one in ARD, one in Lancet. This one was ixekizumab versus adalimumab. This was again, both of them were in conventional synthetic DMARD inadequate responders, psoriatic arthritis, B DMARD naive. So if you read the abstract of the paper, most of us at the initial stages in our training read the abstract. So the abstract of this paper goes as, so this was a superiority trial. The primary endpoint of superiority of ixekizumab over adalimumab was met. Higher PASI 75, 90, 100 responses. DAPSA remission, MDA, VLDA, all in favor of ixekizumab. And this response was maintained at 52 weeks in a subsequent study which was published by Professor Joseph Smolin et al. Later. So you look at this abstract, very beautiful. IL-17 is the way to go. IL-17, 23 axis, that's what we have to target. But let's go beyond the abstract and go into the details. So this is the first figure that is shown. So the composite outcome, the primary outcome for this trial was a composite of ACR 50 and PASI 100. That is including both the joint responses and the skin responses. See the beautiful divergence. So orange is ixekizumab, purple is adalimumab. Beautiful divergence which starts in as early as 8 weeks. Everyone is happy. IL-17, IL-17. Let's look at the individual responses. So the moment we separate the composite outcome into ACR 50 and PASI 100, so whatever this divergence is happening is essentially because of the divergence in PASI 100. That is improvement in skin activity. And that is not a surprise to us. Professor Dogra sir is here. There are head-to-head trials in psoriasis which have already established that IL-17 is superior to anti-TNFs in skin. That's not debatable. What we are talking about is the joint. Look at ACR 50. Same. Look at other composite disease measures. So look at DAPSA, look at MDA. Very subtle differences. Most of these differences again being mediated by changes in overall physician or patient global activity, but not much per se by the musculoskeletal response. Then came the second trial, the EXCEED trial. So this was secukinumab versus adalimumab. Previously we had ixekizumab, now we have secukinumab. That was open label, this is double blind. Similar, conventional synthetic DMARD inadequate responder population, higher dose of secukinumab so that we don't miss out on any anti-IL-17 effect. Let's give higher dose of secukinumab, 300 mg. Good outcome measure. So this is what we are interested in, pure musculoskeletal response. So their responder index was proportion of patients who attained an ACR 20 response at 52 weeks. So no conflict with skin, no conflict with anything else, close to 400 patients, no concomitant CS DMARDs allowed. A lot of people say anti-TNFs work in combination with methotrexate, anti-IL-17, we don't need to give methotrexate. Both stopped in this trial. Let's look at the results. Similar graphs, although you can see some numerical differences, which I am sure Dr. Saket will highlight, but these are just merely numerical differences. Look at the OR, 1.3, confidence interval crossing, p-value, non-significant. So this was ACR 20 response, similar. This trial was even significant in a way that it also looked at resolution of enthesitis. No difference between the groups. ACR 50, no difference between the groups. Absolutely similar from a musculoskeletal point of view. The only difference, they also looked at dactylitis. So across the board, all musculoskeletal measures essentially similar between the two groups. What was different again was what we already know, that is the skin response better to IL-17 than anti-TNFs. So MSK efficacy, ladies and gentlemen, of the two drugs are similar. Let's look at efficacy from other aspects. Look at IBD. Anti-IL-17 is a strict no. With IBD, you're not giving IL-17. With uveitis, TNF is the only biologic which is effective. No IL-17, no IL-12, 23. So efficacy wise, we are already getting a tilt towards anti-TNFs. Let's talk about safety. So left is the data from Spirit H2H, right is from EXCEED. So more or less similar safety data. Apart from sporadic events of IBD seen in both the trials with IL-17, which we somewhat expect, serious infections same. These patients were not low TB endemic countries, so no risk of TB. So if you look at the safety profile, apart from TB reactivation, which would obviously be more than anti-TNFs, the others are more or less the same. Fungal infections, more in anti-IL-17, but non-serious. But these are trial-related safety events. What we need to look at is post-trial surveillance. Look at what happened to tofacitinib. A lot of safety data emerges after approval. So what do we have with anti-TNFs? A body of data which is spanning more than 2 decades. Safe. Can we say the same about IL-17? We do not know yet. They are in the market for 8 to 10 years. So anti-TNFs are time tested. Cardiovascular morbidity, very common in patients with psoriatic arthritis, most common cause of death. We need to reduce that. And there is evidence, published evidence to say that TNF-Is work. They reduce the cardiovascular mortality, morbidity. Whether that is inflammation mediated, whether that will be beneficial by IL-17 blockade or not, we do not know. With anti-TNFs, we already have that data. Very important for us to understand. This is a case study from the GRAPPA guidelines. GRAPPA guidelines itself gave a case study which will prove my point. A 33-year-old female, 12 swollen tender joints, nulliparous, not using contraception. She says, my husband and I would rather wait a year, but if pregnancy happens, that's fine. What does GRAPPA say? Prefer anti-TNFs. This is GRAPPA, this is not me. These are what the Asia guidelines say. TNF inhibitors are safe throughout pregnancy. Can we say the same about IL-17? No, not at all. So when we are dealing with patients of this age group, anti-TNFs win hands down. Question to the audience, how many people know what is Copilor? What is Copilor? Just one. Post-TM trainee cannot count. So the audience is silent about Copilor. And that is what it is for most of us. So this is ixekizumab. We do not even know the name. How would we know the dose? How would we know the cost? How would we know anything about the drug? And we have anti-TNFs on the other side, readily available. So many biosimilars, MRs going around here and there. Decent cost. What do we have? Everything on the platter. And this is not just us. Look at cycling data published in Nature Scientific Reports. They looked at a TNF switch interclass vis-a-vis TNF to IL-17 switch. Only 13 patients, TNF to IL-17 switch. The others, large category, still anti-TNFs. Everybody is using anti-TNFs, but I am sure my Dr. Saket would try to convince us that IL-17 is beautiful. We are rheumatologists, we believe in guidelines. This is what the guidelines say. They put along both of them along the same spectrum, and they say that consider the other non-musculoskeletal involvements, and clearly says in IBD, in uveitis, anti-TNFs, very severe skin disease, IL-17. So ladies and gentlemen, this is my final slide. Concluding what I have said, in efficacy from a psoriatic arthritis point of view, they are similar. Higher efficacy in IBD, uveitis, lower in skin. Safety profile comparable. TB, yes, lingering around in the background. Time tested effect, no long-term side effects, easily available, easily accessible, whole lot of biosimilars, cardiovascular risk reduction, safety in pregnancy, prescription practices, guidelines. Why do we need a debate for? Two scenarios where you'd probably give it very severe skin and probably when there's high risk of TB reactivation. Thus, numbers may say anything. There will be a lot of Virat Kohlis, there will be a lot of Rohit Sharmas, but Sachin Tendulkar will remain its place. And thus, I humbly request my mighty Nepal, Naresh, जहां बना तुसी ग्रेट हो तोहफा की जगह एंटी-TNFs कबूल करो. Thank you.
Now I invite Dr. Saket Jha from Tribhuvan Medical University, Nepal for his talk in favor of IL-17 inhibitors.
I'll see with you. Just a second.
ये ना
Thank you. At the outset, I'd like to thank Department of Internal Medicine, especially Aman sir, for inviting us here. And I'll be talking about IL-17 drugs against the motion that anti-TNF IL-17 is better, as my dear friend Siddharth has tried to convince. So the track of my presentation, I'll be slightly delving into the history of interleukins, and then I'll be talking about the efficacy evaluation, safety evaluation, patient suitability, and why should we choose IL-17 inhibitors. So if you look at this picture, now IL-17 inhibitors is a young kid. He himself, Siddharth, said that it is just available in 2015, and he still looks in eye to eye, head to head with the anti-TNF. So it is a recently described molecule, IL-17 inhibitors. It was the year 2000 when IL-17 was first discovered. Till date, we just have 6 ligands, 5 receptors, and it has been implicated in the pathogenesis of psoriasis just in around 2008, and the first approval is around 2015. So very young. Now, if you look at the pathogenies, both anti-TNF, IL-17 have been implicated in the pathogeny of psoriasis as well as in skin, bone, dactylitis, enteritis. But if you look at the role of the most central molecule, it is IL-17, which has the central role in psoriatic arthritis, more compared to anti-TNF. Till currently, we have these are the molecules. We have IL-17A inhibitors. We have receptor inhibitors like brodalumab, and the most recent molecule, which is a dual inhibitors, that is 7A and F inhibitors, which is bimekizumab. Now, if you look at the timeline of drug constitution, prior to 2005, it was all conventional synthetic DMARDs. Then the 2005 to 2010, it was ruled by anti-TNF. Now, if you look at the third, that between 2010 and 2015, when the IL-17 inhibitors are being approved, biosimilars of anti-TNF is being approved. So we see that it is a very young molecule. So the shortcomings were that in subset of patient IL-17 was anti-TNF was not responsive. There have been reports of exacerbated disease, secondary failures, and there are safety concerns. So the tagline for anti-TNF is that it has been approved when any improvement was considered success in psoriatic arthritis. Then that's the time when it has established its place. So to study about IL-17, there were initially the placebo control trial, head-to-head trial. Siddharth has told about the ACR response, the skin response, the resolution of enthesitis, and dactylitis. Now, this is the overall data from systemic review, which showed that in placebo control trial, if you look at the data, both IL-17 as well as anti-TNF has a response in musculoskeletal system. However, infliximab appears a bit better as compared to IL-17 inhibitors. But if you look at the initial data, that is the biological naive patients, IL-17 inhibitors also has a potent than in patients who are biologically challenged initially. If you look at the skin response, it is hands down IL-17 inhibitors. There is no comparison with anti-TNF on skin responses in placebo control trials. If you look at the resolution of enthesitis and dactylitis, there are very limited data of anti-TNF. Only adalimumab has its role in basically resolution of enthesitis and dactylitis, but all the anti-TNF IL-17 inhibitors has shown that there is response or resolution of enthesitis and dactylitis by using IL-17 inhibitors. Now the head-to-head trials, Dr. Siddharth has shown that these graphs had already been shown that the combined response of arthritis as well as skin response is better with IL-17 inhibitors. The arthritis or the joint response individually is more or less comparable. And if you look at the skin response, again, hands down, it is IL-17 inhibitors. If you look at the other head-to-head trial, that is the EXIT trial, which was secukinumab versus adalimumab. It was a double-blind placebo-controlled trial published in Lancet. If you look at the ACR responses, it is better in, it is comparable in both. However, the skin response as well as resolution of dactylitis or enthesitis is better in cases of IL-17 inhibitors. Now, there was a third triangulation study, which studied all anti-TNF, IL-17 as well as IL-23. Now, this trial showed that both IL-17 as well as anti-TNF were more or less comparable. However, IL-23 superior, which is not the topic of our debate. Now the safety analysis. Now Siddharth basically smartly removed the side effect data, but if you look at the data of discontinuation of treatment because of adverse effect, you see that most of the patient has discontinued anti-TNF in comparison to IL-17 inhibitors. Similarly, yes, the candidal infections in fungal infections are more in cases of IL-17 inhibitors. However, if you look at the hypersensitivity and measure basically local site reactions, it is mostly in anti-TNF. Now, Siddharth had lightly told about risk of reactivation of tuberculosis. So most of the data that we see are mostly in those countries where the incidence or prevalence of tuberculosis is very limited. But in our setup where the epidemic or endemicity of tuberculosis is very high, this needs to be highlighted. So I have kept read for Siddharth that anti-TNF has very high risk of tubercular reactivation. If you look at other subgroups like hepatitis B, hepatitis C, HIV, though there are limited data, still hepatitis B reactivation is found to be less with IL-17 inhibitors as compared to anti-TNF. However, those data are very limited. If you look at the factors of patient suitability, both IV and subcutaneous formulation is available. The dosing is 4 weekly. Without loading dose also can be given. Similarly, onset of action. Now it is definitely faster with IL-17 inhibitors. And cost effectiveness, there are ACR reports in Brazilian and US cohorts where it has seen that IL-17 is cheaper alternative. Now this is the mostly in the skin response. If you look at the onset of action of IL-17 inhibitors, it is more with bimekizumab was compared, and it hands down bimekizumab has faster onset of action as compared to all anti-TNF. Similarly, if you look at the Brazilian and the US perspective, the cost analysis, cost-effective analysis, anti-TNF seems to be more expensive as compared to IL-17 inhibitors. So why to choose IL-17 inhibitors? So all of us like 1+1 offer. So whenever there is joint psoriasis does not come alone with arthritis. There is associated skin enthesitis, dactylitis. So whenever you like 1+1 offer, if you look at the resolution of joint plus arthritis, joint plus dactylitis, joint plus enthesitis, the response is better with IL-17 inhibitors. The onset of action is rapid in IL-17 inhibitors. There's less reactivation of tuberculosis and hepatitis B, and it seems to be cost effective. Dr. Siddharth has also told us that we have uveitis, the response is, but how many cases of psoriatic arthritis has uveitis? The risk is low. He has smartly removed tuberculosis from his debate, but has brought uveitis into the context. So let the kid grow. I think it will beat IL-17, will win over anti-TNF, and let it stand the test of time, which anti-TNF also already taken. With this, I'd like to say thank you.
Do we have 1 minute rebuttal? Okay. So I'm sure post-lunch hours, both the speaker didn't allow anyone even to blink the eye. They did excellent job. And now we'll have 1 minute rebuttal from both the speakers. Dr. Siddharth Jain first.
So a very, very interesting debate. Two things. So can I open his last slide? Yes. So very conveniently, I told you he'll play with numbers. So with hepatitis B, hepatitis C, HIV reactivation, 1-2 cases, lesser risk of Hep B, lesser risk of Hep C. For uveitis, कितने cases देखते हो? I told you we'll play the numbers game. That's why I wanted to just cut the propaganda in between. So while I agree with the observations, those conclusions cannot be relied upon. So the data about reactivation of Hep B, Hep C, etc. is very, very sketchy. Very, very sketchy. So would not come in the debate. It's like the numbers of uveitis. So that's point number one. Second, numericals, so continuing with the numbers. So numerical differences have to be seen very carefully. So numerical significance, statistical significance, and clinical significance all need to be weighed in very carefully when deciding one drug over the other. So numerical significance is not landmark. Point number 3, cost effectiveness. So very beautifully, you know how we manipulated you anti-IL-17 cheaper than anti-TNFs. What is the MRP of adalimumab? Anyone? MRP of adalimumab? MRP 42,000. No. Yeah, I'll tell you because I indented these things through so whenever you have a hospital indent, the indent is through the MRP. So let's not keep the exact figures, but what I'm trying to say is adalimumab is available to us at a cost of 5,500, 6,000. Biosimilars have completely altered the balance from a cost perspective. So this cost effectiveness analysis that has been beautifully presented to you is a comparison of cost of originators. IL-17, no biosimilars yet. Copelor to किसी को पता नहीं है. Biosimilars आने में अभी time लगेगा. So till that time, when cost is such a major factor in all of our analysis, this cost effectiveness analysis is just a curtain in front of you that you need to brush aside and realize that cost of biosimilars versus cost of bioregister is dramatically different, and that would also go off from his list. So 1+1 offer dubious, better skin response definitive, everybody knows that. And I think with that both of us come on the same page that for skin, IL-17 hands down. For the other time, the kid needs to grow more and probably have cheaper alternatives before it can replace anti-TNF. Thank you.
Now I invite Dr. Saket Jha for rebuttal.
Thank you. So, dear Siddharth, so how many, what is the percentage of skin involvement in psoriatic arthritis? It is around 2/3 of cases will have skin involvement. No, it's arthritis, but you have 1+1 offer. There is 1+1 offer. That is what I'm telling you. So it works in joint. You yourself have said that it has ACR responses. But what about skin? So you need to have 1+1 offer. Again, you showed cardiovascular risk factor. What is the incidence of cardiomyopathy? If the patient has developed cardiomyopathy, would you be giving anti-TNF to those patients? So again, your checklist, I'll be cutting down your checklist. Okay, thank you so much.
Thank you once again, Dr. Siddharth Jain and Dr. Sakeja. That was best possible debate on this topic. And I thank organizer for giving me and Dr. Shankar this opportunity to chair the session. Thank you very much.
Thank you, chairpersons, and thank you very much for such a wonderful show, for such compelling arguments. Now we'll move on to management of spondyloarthropathy in 2025, and for this we have Dr. Amit Kansal from Ludhiana, who will be delivering a talk on this topic. May I invite Professor S.S. Lahal sir from GMCS 32, Chandigarh, and Dr. Amal Basnet from Maldives on dais to chair this session.
Good afternoon, everybody. I would like to welcome Dr. Amit Kansal on the podium. And now he will be delivering his talk on management of spondyloarthritis in 2025. Over to you, sir.
Thank you, Chairperson. Good afternoon, everyone. First of all, I would like to thank Professor Aman Sharma and his team for giving me this invitation. So I'll be speaking on managing spondyloarthritis in 2025. I have just made an overview of spondyloarthropathy for general physicians and the DM students so that we are well aware of making the diagnosis of spondyloarthritis. So spondyloarthritis, as we know, is a chronic inflammatory disorder which primarily affects axial skeletal involving the sacroiliac joints and the spine. It may also cause peripheral arthritis, inflammation of the enthesial sites and the digits in the form of dactylitis. Various extra-articular manifestation by causing inflammation of the uvea in the form of uveitis, inflammation of the skin manifesting as psoriasis, or inflammation of the gut in the form of IBD. Onset usually occurs in the third decade of life, and if we talk about the prevalence of radiographic spondyloarthritis, it is 2 to 3 times more common in males, whereas non-radiographic spondyloarthritis is equally prevalent among males and females. The prevalence is 0.3 to 1.4% worldwide, whereas Indian data shows it is 0.7 to 1 per 1,000 population. If we talk about the incidence, every year after a population of 1 lakh, 7 patients of spondyloarthritis are newly diagnosed. These figures are probably underreported because lots of patients are still not diagnosed at the accurate time, and there is considerable burden on the patients and their families. If we talk about the clinical manifestation, inflammatory back pain is the key symptom of axial spondyloarthritis and does not exclusively belong to it. The characteristic features of inflammatory back pain are that there is prolonged morning stiffness of more than 30 minutes. It improves with exercise but does not improve with rest. It is gradual in onset and usually occurs before the age of 45 years. Almost 80% patients of axial spondyloarthritis, they have inflammatory back pain. So the sensitivity of this symptom is around 75 to 80%, but the specificity is quite poor, that is from 25 to 45%. If we talk about extra-axial manifestation, peripheral arthritis is seen in around 30 to 40% patients. Enthesitis, same number, 30 to 40%. Dactylitis, only 5 to 7% of the patients. Acute anterior uveitis seen in up to 45% of the patients, psoriasis 10 to 15%, and IBD less than 8% of the patients. If we go through quickly about the pathophysiology, there are three mechanisms which are possible or plausible cause for the disease. The first is HLA-B27 associated autoantigen presentation. The second is gut microbial alteration leading to translocation through the inflamed gut. And the third is mechanical stress or recurrent trauma at the enthesial site leading to activation of the immune system. So this is a brief description that dendritic cells with their HLA-B27 antigen on the surface, this HLA-B27, this presents a putative self-peptide or self-antigen to the CD8 T cells, leading to activation of CD8 T cell as well as the dendritic cells. These cells, they produce IL-17 and TNF-alpha, and these IL-17 and TNF-alpha, they activate osteoclasts, which cause inflammation at the site of inflammation and erosions also. The IL-23 released by dendritic cells, they cause activation of Th17 cells, which lead to massive secretion of IL-17. Apart from these, there is ILC3 and gamma delta T cells, which reside at the enthesial sites, gut, wall, and even in bloodstream. They also produce IL-17 and IL-23. These IL-17 and 23, they cause activation of mesenchymal stem cells, which get differentiated into osteoblasts, leading to repair of the bone erosion and lead to excessive bone formation also. So these are the sites of inflammation and excessive bone formation leading to ankylosis of the sacroiliac joint and new bone formation at enthesial sites. So the question is how to diagnose axial spondyloarthritis. There are many challenges. There is no single test which can diagnose this disease. The most crucial part is to differentiate between inflammatory back pain and mechanical back pain. There is limited awareness about this entity among the healthcare provider. So majority of the time, general physician, practitioners, orthopedic surgeons, sometimes even neurosurgeons or even neurologists, they are dealing with these patients, and usually they prescribe NSAIDs to which these patients respond to some extent, and the exact diagnosis is delayed. This is the only entity in rheumatology which has the longest diagnostic delay of up to 7 to 10 years. Then is the misuse of AS classification criteria for making diagnosis. These classification criteria actually are meant for selecting a homogeneous cohort of patients for research trials, not for making the diagnosis. So various differential diagnosis causing mechanical back pain should be kept in mind while dealing with patients of low back pain. Commonly seen conditions are diffuse idiopathic skeletal hyperostosis, that is DISH, usually seen in elderly population with mechanical pain symptoms. Then is osteitis condensan iliae, which is seen in young postpartum females with minimal back pain, and on radiograph you can see iliac sclerosis. Most commonly seen is degenerative spinal disease, again seen in elderly population with mechanical pain symptoms or sometimes even radicular symptoms in the legs. Fibromyalgia, usually seen in younger females with widespread pain along with low back pain, but there are no signs of inflammation. Then sacroiliac joint infection or discitis, usually seen in immunocompromised patients with a history of fever and weight loss. Malignancy, again, you have associated features of fever, weight loss, or night sweats. Sometimes you may get history of some recent diagnosed malignancy which has metastasized to the spine. So to make the diagnosis, you have to see the classical symptoms. If you have ruled out mechanical back pain and you are sure you are dealing with inflammatory back pain, look at other parameters, oligoarthritis in the form of involvement of the asymmetrical large joints of the body, enthesitis, most common is heel enthesitis, and then dactylitis. You have to take the help of imaging either in the form of conventional X-ray or MRI of the sacroiliac joints. Definitely you have to look at ESR and CRP to look at the inflammation. And good response to NSAIDs is a very good marker which helps to make the diagnosis of spondyloarthritis Usually these patients, if you ask, they have very good response to analgesics. Genetics, you can do HLA-B27 and do ask about the family history of axial spondyloarthritis or uveitis, psoriasis or IBD in a family member. So this is ASAS modified algorithm for making the diagnosis. If patient of less than 45 years age comes to you with chronic back pain of more than 3 months duration, you can do an X-ray of the pelvis. If it shows sacroiliitis, you can straightway make the diagnosis of ankylosing spondylitis or radiographic axial spondyloarthritis. But if it is negative, then you have to look at other features of spondyloarthritis which are mentioned here and we have discussed previously. If 4 or more than 4 features are there, you can straightway make the diagnosis of non-radiographic spondyloarthritis. If 2 to 3 features are there, you can take either help of HLA-B27 or MRI. If one of them is positive, the diagnosis is non-radiographic axial spondyloarthritis. If only one feature of these spondyloarthritis is present, you have to do both HLA-B27 and MRI. If both are positive, the diagnosis is confirmed. So these are the ASAS criteria which I have talked previously. If you are using these criteria for making diagnosis, because these have a sensitivity of 79.5 or 80%, means you will be missing 20% patients of spondyloarthritis who are not fulfilling these criteria. Then after the clinical picture, various symptoms and signs, you have to come to imaging, which plays the most pivotal role in making the diagnosis of spondyloarthritis. The conventional X-rays, usually they lack both sensitivity as well as specificity. And currently MRI is on the way to replace these conventional radiological imagings because it can capture both active inflammation in the form of bone marrow edema as well as post-inflammatory structural changes in the form of erosions, fat metaplasia, sclerosis, and ankylosis. These structural changes are actually much more specific than the bone marrow edema to make the diagnosis of axial spondyloarthropathy. Alone bone marrow edema is not that specific to make the diagnosis. You must have to look at the structural changes which are more specific to make the diagnosis. For this, 4 sequences has been recommended. 2 are T1 weighted and 2 are T2 weighted. T1 weighted plain semi-coronal view, then T1 fat suppressed, and both the T2 weighted are fat suppressed views which are called stir images. In stir images, you do 2 views, semi-coronal and semi-axial. Semi-axial to look at the posterior aspect of the sacroiliac joint. So these are 4 imagings. These are from the patient of spondyloarthritis. In star images, you see bone marrow edema, and in T1 weighted, you see the more specific changes, that is erosions or fat metaplasia in these patients. So HLA-B27, you can take the help of HLA-B27, but it is a very non-specific test. It raises the suspicion, but it does not confirm the diagnosis. So only 1 to 5% of HLA-B27 individuals, they develop axial spondyloarthritis. So from rheumatoid arthritis in last 2 decades, we have learned that early diagnosis and early aggressive treatment leads to better outcomes because rheumatoid has taught us inflammation into time is equal to damage. So the more is the inflammation, more it lasts, more is the radiological damage. So we have to cut down the inflammation as early as possible to reduce the damage or radiographic progression. So similar concept has been applied by ASAS in axial spondyloarthritis also. And although we don't know the window of opportunity, arbitrarily they have given a definition of less than 2 years. So for 2025, early diagnosis is very important for diagnosing this disease. So treatment part, the first line is the role of NSAIDs and physical therapy. NSAIDs, whether they reduce the radiographic progression, data is conflicting. Physical therapy definitely improves the functionality as well as the inflammation also. So intensive physical therapy is must. No role of steroids or conventional DMARDs in axial disease, only for peripheral arthritis or uveitis. For second line, we have TNF-alpha inhibitors or anti-IL-17 agents. The third line is JAK inhibitors. So broadly, if we see the treatment of axial spondyloarthritis, 25% patients, they settle down with NSAIDs, but 75% patients, they need biologicals or JAK inhibitors. So best anti-TNF, we have 5 molecules with us. All are equally effective. All they reduce radiographic progression also. What if there is failure? If primary failure, switch to other class. If there is secondary failure, you may choose another agent from the same class also. So among IL-17, we have 3 molecules. Then JAK inhibitor, tofacitinib and upadacitinib. Secukinumab and adalimumab, both they have good role in radiographic progression, slowing down. So options available in India are etanercept. I am talking about biosimilars. It is costing around 15,000. Adalimumab 12,000. Infliximab 40,000 every dose. Golimumab, Reliance has recently launched a biosimilar with costing of 18,000. Secukinumab 14,000. Tofacitinib, the generic version, is quite cheaper, 30 rupees per day, around 900 rupees per month. So this is the most effective and most cheap available treatment option. Can we taper biologicals? Yes, we can plan. When should we taper? When the disease is inactive for at least 6 months. Can we stop biologicals? No, because 12 different trials have seen that over stopping, around 53 to 100% patients, they relapse in 12 months of discontinuation. There is upcoming role of low-dose CT scan, role of artificial intelligence in imaging analysis and making earlier and faster diagnosis of spondyloarthritis. Then targeting autoreactive T cell also is upcoming therapy for this disease. So my take-home message for this disease is early diagnosis and early aggressive treatment, which will improve the outcome. Thank you.
Thank you. Large topic, but covered in a reasonable time. I think a little bit more time was taken. But if there anybody wants any questions or any more things people want to ask or clarifications people want to add, and you didn't mention much about sulfasalazine.
So sulfasalazine you can use for peripheral arthritis. The conventional DMARDs, they are not effective for the axial disease.
And what is your experience with the possibility that tofacitinib has a little more higher level of herpes developing in them? How much have you seen that?
So clinically till date I have not seen any single patient of herpes zoster.
Yeah, but the text does mention it occurs. Yeah, so we see the occasional patient who does. But is there any way to prevent it?
So ideally recommendation is to give vaccination for herpes zoster, but that is recommended for more than 50 years of age. And usually in axial spondyloarthritis, it is a disease of youngsters. So all the cardiovascular risk factors or herpes zoster, we can very well manage because our group of these patients of this disease are younger population. Vaccine we can give, but again the cost is the issue. One shot is around 10,000 rupees and we have to give 2 doses 2 months apart.
Thanks. Thank you, sir. With that, I think if there are no more questions or any discussion, we can close the topic. Thank you very much.
Thank you, sir. Thank you.
Thank you, chairpersons. Thank you, sir, for such an informative talk. Next up is our session on potpourri. We'll get to hear from eloquent speakers from our allied specialities. First talk is on GI involvement in sarcoidosis and IgG4 related disease from Professor S.K. Sinha, sir, from the Department of Gastroenterology, PGIMER. To chair this session, may I invite Professor Mary John, Head Department of Medicine at CMC Ludhiana, and Dr. Sandeep Chauhan, sir, from Panchkula.
Before I start, I would like to thank Professor Aman for the opportunity and the Department of Internal Medicine and Rheumatology for giving me the opportunity. Disclaimer is that I am not a rheumatologist. I am basically a gastroenterologist with some interest in these conditions, rheumatology, which I am going to discuss now. So,
Okay. So, so basically we start with IgG4 related disease. This is relatively new condition, maybe 3 decades old or so, that lots of information is being added and lots of presentation is getting changed. So the information tends to become outdated in less than 3 years, less than 4 years time. So this is multi-system disease, and unlike many of the rheumatological conditions, this is dominantly seen in middle-aged or older population, more male-dominant compared to many of the other autoimmune diseases, and can affect virtually every organ of the body, but some organs dominantly bear the brunt more than the others. And typically, how as a gastroenterologist I become interested is because of this, the biggest chunk presents with the autoimmune hepatitis, autoimmune pancreatitis. So that is the situation, but there was a time when we used to diagnose one case of autoimmune pancreatitis. We used to be very happy. No more. The situation has changed because that presentation is called typical presentation. So we keep diagnosing those cases and no more so much excited about that. The next biggest chunk is involvement of the salivary glands and sialadenitis and dacroadenitis. So that is very typical involvement. So that helps us to diagnose. And if we say the dominantly middle-aged elder population, male-dominant disease, and association with allergy is common. So what has happened over the years, this I'm going to highlight subsequently also, that CT and PET-CT are very useful for the diagnosis, and we are relying more and more. And I'm going to show some of the cases where I will also show that how the PET-CT helped us. So PET-CT shows that pancreas is not the most dominant involvement, most common involvement. It is the submandibular gland which is most commonly involved, or the other salivary glands. So whenever we make a diagnosis of IgG4 related disease, then we always rely on PET-CT, and we always try to see the mediastinal nodes and the salivary glands. Our colleague who is helping us with CT, he is nodding in affirmation, so that is he is ratifying our statement. So when we talk of pancreatic involvement, it is dominantly a stricturing disease, and typically the collections, the ductal disruption, pleural effusion, pancreatic ascites, those things are rare. So it is dominantly obstruction. So this obstruction will be either pancreatic duct or bile duct obstruction. That I'm going to show you a little short while now. So there are certain lesions which are histological lesions which are very typical of IgG4 related disease, and one is lymphoplasmacytic infiltrate, which are so tuned to see in rheumatological conditions. But what is important that these are dominated by IgG4 positive cells, and different diagnostic criteria have taken different cutoff, like 30 cell, 40 cell, 20 cell positivity per hyperfield field. So that can be used. One interesting form of fibrosis is described, which is called a storiform fibrosis. So normally what happens that when fibrosis starts setting in, the inflammation starts getting decreasing. But this is one situation where fibrosis starts sets in, and still dominant, lots of inflammation goes on. So that is the storiform fibrosis. And then we have phlebitis obliterans, and then something called predominant neutrophil infiltration that we are going to see when we are taking type. So this is, you can see all the cervical major and minor salivary gland involvement, and then there are lymph nodal involvement, and such type of appearances are there. We don't have any hesitation making the diagnosis. And typically for the pancreatic disorders, we rely very, very heavily on CT and PET-CT. And in the CT, we typically there are certain changes described. So what is there, that there are a stricturous lesion here in the pancreatic duct, there are a stricturous lesion here in the bile duct, and what we see here is called sausage-shaped pancreas. So these are the typical lesions when we diagnose. So then we tend to consider possibility of autoimmune pancreatitis, and there are two types. Type 1 is much more common compared to type 2. So practically all cases will be type 1 and very occasional or rare cases, and type 2 typically may not have IgG4 elevation that much. So that is the major difference. In Asia particularly, the type 1 dominates more, whereas in Europe, the type 2 is maybe slightly more common. Now, more and more people are talking about when there is no serum rise of IgG4. So this is typical scenario what we talk of type 2 autoimmune pancreatitis, that like scenario, but there may not be non-pancreatic manifestation also. And then they have the Japanese registry, they checked for the natural history, and what they have shown that those who don't have serum IgG4 elevation, that tends to be relatively benign or do better compared to the serum positivity group. So what we say, this is compared to idiopathic and alcoholic pancreatitis. These patients tend to be older, but rest of the manifestation are not much different, although calcific pancreatitis is said to be less common early in the course or at the time of diagnosis. So pancreatobiliary, I have already said that on pancreatitis, the sauces of pancreas, there is delayed enhancement, so enhancement is dominantly seen in hepatic phase. There is capsule or envelope, and MPD is typically not dilated, which is in contrast to other situation in chronic pancreatitis where MPD will be dilated in most of the patients. And then we have extra pancreatic lesions, some of which I am going to show you. So what we see, what I'm showing you here is typical sauces of pancreas. So that makes us suspect, but what makes us confirm literally is that these lesions, which we are in non-enhancing lesions, which we are seeing in kidney. So extra pancreatic lesion helps in confirming the diagnosis. And PET CT, I already told you, you can see that you are seeing lesion in kidney, you are seeing in cervical glands, salivary glands, and etc. And then you have pancreatic, which is so well seen. So pancreatic lesion, I have already talked that pancreagram, it is mostly a stricturous lesion, and bile duct also a stricturous lesion. The most important, there can be millions of differential diagnoses for that. But when somebody sees something like one stricture here, another stricture here, another stricture here, and multifocal stricture, then the situation becomes very suggestive of IgG4 related disease, because that is typically multifocal. And here, despite having a stricture in head region, the PD is not dilating. That is another clue that it can be IgG4 related disease. So typically multifocal stricture, lack of upstream dilatation, and both pancreatic and bile duct stricture, that becomes very suspicious. So that type of presentation, we are not very excited. Now we are diagnosing more and more cases which have atypical presentation, and esophageal involvement in IgG4 disease, uncommon or rare. I am showing you here a case of, so this 49-year lady presented in 2014 with 4 years history of dysphagia, and investigation were unremarkable. There was evidence of iron deficiency. So typically when somebody coming with 4 years history of dysphagia and iron deficiency, we tend to think of cervical esophageal web. And actually on barium swallow, it was reported as cervical esophageal web. But when we did endoscopy, there was no evidence of esophageal web. There was a stricture in upper third, and there were changes in esophagus, which we typically describe with eosinophilic esophagitis, like linear mucosal breaks, crepe paper mucosa, and rings and webs. So dilatation was done, and we kept on dilating this patient for another 4 years, multiple sessions, giving PPI without reaching any diagnosis. And every time we used to take diagnosis, considering with the intention of ruling out esophagitis. There was no evidence of eosinophilic infiltration, and we reviewed serial of biopsies, 4, 5, 6 biopsies, and it was reported as reflex esophagitis. And barium X-ray was reported, which showed benign stricture, which we anyway knew by virtue of endoscopy. So ultimately, having gained experience in and diagnosed another case of IgG4 related esophageal disease, we worked up this patient, and we did ultimately PET CT, and PET CT showed a very typical pattern, which is so similar to IgG4 related disease. Serum IgG4 was elevated grossly, more than 4-fold, And then we did biopsy, gave a feedback to histopathologist that we are suspecting IgG4 related disease. IgG4 staining was done and it showed more than 40 IgG4 positive cells per hyper field. So diagnosis was confirmed. So was started on prednisolone, did well, but on tapering, the symptoms recurred the moment we tapered steroid. So then after having done TPMT and NUDT, we put on azathioprine and we have continued, and for 4 years she is okay, she is doing fine. And nowadays for IgG4 related disease, before tapering of steroid, we always go for PET-CT. PET-CT is not showing any avid lesion now. And so azathioprine we have tapered off, she continues to be asymptomatic. So this was IgG4 related esophageal disease who had stricture and anemia. Then this is very, very odd case that IgG4 tends to be involve liver, but that is because of obstructive lesion. This lady presented, 56-year lady presented with acute cholestatic hepatitis, and all the markers which we did was, 50-year presented with pain abdomen, and then she was walked up outside. So she was walked up, and that showed that there was a gallbladder stone, and there was evidence of GV mass, GV thickening, and this mass seems to be infiltrating into the surrounding adjacent liver parenchyma. And then she was referred with the diagnosis of carcinoma gallbladder, was taken up and she was operated here. Extended cholecystectomy was done, and cholecystectomy specimen showed that there was evidence of IgG4 related disease. So she has been started on prednisolone, and we plan to continue for 8 weeks, and then we will taper it off. So if you see the treatment, then initial course of prednisolone should be 4 to 12 weeks and then tapered off, and has to be give a maintenance therapy somewhere 1 to 2 years. Many patients tend to recur. So what we in patients who have recurrences or who have risk factor for GI intolerance for the steroid, then we try to use azathioprine, mycophenolate mofetil, methotrexate, or rituximab. So there is that is how it works out to be. In as a third line therapy, we also use rituximab, but there rituximab for we have meta-analysis available and it has shown efficacy. But recently a new class of monoclonal antibody, which is CD19 antibody, and against CD19, this is inebilizumab that has been used. This is not a comparative study. This is open label type of a study. So virtually no treatment or placebo. This has been shown to efficacy both in terms of relapse and remission. It was found to be useful. The IgG4 related gallbladder disease is distinctly uncommon, and even in this era there are only very few cases, case series, tiny case series, or the case reports are available, and this type of case reports comes up. Gets published even in 2013. There is a GV mass, and then biopsy is taken using ERCP from GB or US guided ERCP, US guided gallbladder biopsy, and that shows IgG4 related disease. So that type of things happen, but IgG4 related esophageal disease is still uncommon and very rare condition, and only rare case reports are available. So one sees here there is esophageal mass, and there are lots of IgG4 positive cells are there. This is another case which is probably got published as a case report, thickening of esophagus, lower esophageal stricture, and this is our own another case of which I was talking, that based on that case we were able to diagnose the previous case. Lower esophageal stricture, this is narrow band imaging and a smooth mucosa and biopsy, and then we had PET which helped us the diagnosis. So having covered, now I'm going to discuss little bit of sarcoidosis. So sarcoidosis, again, typically the liver gets involved infrequently. Most remain asymptomatic or oligosymptomatic. Liver involvement is seen in very small percentage of cases, and occasionally on laparoscopy will appear like this. So even whatever liver involvement occurs, that tends to remain oligosymptomatic virtually, asymptomatic or oligosymptomatic, and overt jaundice and pruritus are extremely rare, seen in only 1% cases. So this case I am showing you, this lady presented like acute cholestatic hepatitis. She was diabetic on OHA, And then we walked up, everything was nearly normal, LFT deranged. And then we did again CT chest abdomen, which helped us, and then multiple umbilicated nodule. She was again operated with the diagnosis of mass lesion, and what turned out to be is granulomatous inflammation. So suspecting carcinoma gallbladder, she was operated, and what turned out to be granulomatous inflammation. And then we further worked up, and then it showed that she had raised ACE level. HRCT was consistent with sarcoidosis. We treated with steroid, and she is doing fine. So this is another case who presented with acute cholestatic hepatitis. There was no obvious etiology, and when we walked up, the LFT was deranged, but other parameters was okay. There was no gallstone, all viral markers negative, ceruloplasmin normal, autoimmune markers negative, and MRCP because she was post-coli, so we suspected there must be CVD stone. So that turned out to be completely normal. So endoscopic ultrasound was also done because sometimes tiny stones get missed. So no evidence of CVD stone. And after 4 weeks, we repeated viral markers, autoimmune markers, still negative. So she was so much troubled by cholestasis that there was intense pruritus. We went ahead with ERCP and did external biliary drainage, which is knob in cholestatic hepatitis. She responded, but not fully, partially only. So ultimately, by the time 6 weeks, she had crossed 6 months, so we went ahead with liver biopsy, and that showed granulomatous inflammation, portal fibrosis, and biductal proliferation. So as a part of workup of granulomatous hepatitis, we did ACE level, which was high. We did MAN2, which was negative. 24 hours urinary calcium was high, and CT chest was done, which was showed hilar and mediastinal lymph node and changes of ILD suggestive of sarcoidosis, and PET CT again was suggestive. So this was sarcoid with hepatic involvement presenting as acute hepatitis. Sarcoidosis again is treated dominantly with steroid like IgE4 related disease, and those who have relapses, azathioprine we add, or sometimes rituximab can be added. So in summaries, I will say both IgE4 related disease, sarcoidosis typically involve multiple organs, and presentation is extremely varied. Predominant hepatic or GI involvement is uncommon. Both conditions respond well to steroid. Azathioprine, 6-mercaptopurine, and mycophenolate are useful drugs for maintenance therapy and also in non-responders. Rituximab and inavolisumab are effective monoclonals but are currently being used as a second or third line drug, and relapses are significant problem in both the conditions. Thank you.
Thank you, Professor Sinha, for that very lucid talk and for taking us through various cases of GI sarcoidosis as well as IgG4 related disease. Are there any questions or comments? Thank you, sir. Thank you. We'll end this session here.
Thank you, chairpersons, and thank you, sir, for enlightening us on this aspect. Next talk will be on role of PET scan in rheumatology. PET has indeed helped us in more ways than one in solving enigmatic situations. So this talk will be delivered by Dr. Rajendra Kumar from Department of Nuclear Medicine at PGI. To chair this session, may I invite Professor Pankaj Malhotra, sir, Head Department of Clinical Hematology and Medical Oncology at PGI, and Professor Rajesh Vijayvargiya, sir, from Department of Cardiology at PGI. Over to you, sir.
So good afternoon, everybody. Now it's our pleasure to invite Dr. Rajendra, who is actually the most sought after person with all these specialties, whether it is hematology, oncology, whether it is rheumatology, and you just listen to Dr. Sinha, the rheumatology, IgG4, and I'm sure he is going to show many, and cardiology, yes, the cardiologist is sitting. So you're going to listen to him on the role of PET CT scan. So today he's going to focus on rheumatology.
Yes, sir.
Yeah, Dr. Rajendra. Thank you.
Thank you, Chairpersons. And first of all, I would like to thank Professor Aman Sharma for giving me opportunity to speak over here. So my talk is in PET in rheumatology. So we all know that CT, MR, and ultrasounds, they are the anatomical imaging modalities. And by doing PET, we are adding masala into these anatomical imaging. And what flavor we are getting, that flavor is functional details of that particular organs. So PET CT is the functional and anatomical, functional and morphological imaging. Our main customers are Professor Malhotra. So we are getting most of the referral from him only. But now we are venturing our new customers, that is internal medicine and pyrexia of an origin, and our new customers are also. Yes, okay, thank you. So we have many possibilities in medicine, in surgery, and our new customers are rheumatologists. So in rheumatology, where we have where we have a role, we have a role in vasculitis, rheumatoid arthritis, relapsing polychondritis, IgG4 related disease, and Professor Sinha had described very clearly the role of PET-CT in IgG4 related disease and Erdem-Chester disease. So first I will be covering vasculitis. In FDG PET-CT in vasculitis, by FDG PET, we can know the extent of the disease, we can demonstrate the whole body inflammatory changes, and we can document the site of the biopsy from where biopsy can be taken and diagnosis can be made. We can assess the response to therapy and monitoring the disease activity. We can identify the association of the PMR with the vasculitis. We can identify the chronic complication of large vessel vasculitis, including secondary aortic dilations and aneurysm formations. And FDG PET-CT have a higher sensitivity and specificity to diagnose large vessel vasculitis. So first I'm coming to the giant cell arteritis. Giant cell arteritis have two variants. One is cranial giant cell arteritis, one is large vessel giant cell arteritis. In cranial giant cell arteritis, what we can see, there is an extracranial branch of the ECA that is involved, and temporal artery biopsy is the most positive in these cases. And for large vessel vasculitis, aorta and its major branches are involved, and the less likely the temporal biopsy is positive. So in PET, what we see in giant cell arteritis, this is the case of cranial giant cell arteritis. What we can see, there is an intense focal uptake in the temporal artery, and that can be missed on CT images. And we had added the masala, and after that we can see the flavor of functionality. Now this is a case of large vessel vasculitis, showing intense uptake in the major vessels of the major vessels and aortic arch and descending thoracic aorta and femoral arteries, and then the branches low down the legs. And we can see there is involvement of the vertebral artery and carotid arteries also. Now coming to the Takayasu arteritis, CT is the imaging modality for Takayasu arteritis, but PET, we are adding masala to the CT images, and what we can get is the functionality of these vessels, whether they are functional or not, whether the disease is functionally active or not. And this is a case of post-treatment case. This is a prior to treatment image, and this is a post-treatment image. Prior to treatment image, there is a increased FDG uptake along the aortic, along the ascending aorta, and this is a post-treatment PET. We can see the increased uptake along the ascending aorta, along with there is increased uptake along the pulmonary artery. So there is no response to treatment. So PET can assess the response, and this is a failure to therapy. Now, how we interpret the PET CTs? There are multiple grades to interpret the PET. Grade 0, no vascular uptake. Uptake is less than medicinal blood pool activity. Grade 1, vascular uptake, that is less than the liver. And grade 2, vascular uptake, but that is equal to the liver. And grade 3, the vascular uptake, that is more than the liver. And that should be considered as PET positive. According to Euler criteria, PET-CT can be alternative to the ultrasound to assess the cranial arteries and extracranial arteries. And in case of suspected GCA, and with normal laboratory markers, and laboratory markers are unreliable or normals, the PET-CT can be used, and alternatively MRI can be used. For multivessel vasculitis, like PAN and Kawasaki, PET have hardly any role, and Kawasaki PET have no role. And in PEN, what we can see on CT angio, there is multiple microaneurysm, but on PET we can miss this picture. But what we can see the end organ damage, like this is a patient with pen having multiple necrotizing granuloma on the skin, and what we can see on the PET scan is leopard skin appearance of cutaneous polyarteritis nodosa. Now coming to the small vessel vasculitis, again PET have very minimal or no role in small cell vasculitis except GPA, that is Wegener's. And on GPA, what we can see, this is a case of GPA post-treatment, and the Arman sir had sent this patient to us for to look whether this is there is patient is having active disease or relapse. And what we can see, there is increase of disease uptake in the nasopharynx and increase of disease lesions in the lungs. So we had given active GPA. Now coming to CNS vasculitis, the PET is showing high uptake in the brain. So PET hardly have any role in CNS vasculitis, and the MRI is the most touted investigation for CNS vasculitis. But in few cases, we can see there is a flare, a small flare in the frontal lobe, but PET showing intense uptake in the both sides, and that is corresponding to the symptoms. The patient have more lesions on PET as compared to MRI. So PET can be used in CNS vasculitis also. Now coming to the PMR. PMR, the diagnosis is mainly clinical on clinical assessment, and inflammatory biomarker may be increased, may not be increased, and it has many pathognomic features with giant cell arteritis. It's rarely seen single, and it can be mostly seen with GCA, GCA with PMR, or PMR alone with GCA can be seen. So the pathognomic feature for PMR on PET is increased FDG uptake at the ischial tuberosity, greater trochanteric region, and interspinous ligament. That is indicative of PMR. This is a case with showing increased uptake at in the trochanteric region, in the interspinous ligament, and this is we can say this is a case of PMR. And this can be missed by multiple PET nucleomedicine physicians because they are not aware of these findings, and we can say GCA PMR is also associated with GCA. Increased FDG uptake noted in the bilateral temporal superficial temporal artery is most of the time it is associated with GCA with PMR. Now coming to the rheumatoid arthritis, what we can see on PET is synovial uptake. There will be symmetrical distribution. SUMX is strongly correlated with the clinical symptoms and the penis volume, and the DIP joints are usually spared. And sometimes we can see lung infiltrates also. And this is a patient with showing rheumatoid arthritis, showing increased uptake in the multiple small and large joints. This is RGD PET in rheumatoid arthritis. In rheumatoid arthritis, but there is neoangiogenesis, and this paper was published by Professor Aman Sharma in Clinical Nuclear Medicine, and we can see there is RGD PET showing increased uptake in the rheumatoid arthritis, involved rheumatoid arthritis. This is the image from the published literature by Professor Aman Sharma. We can see that increased tracer uptake is correlated with the DSA 828 ESR, and on post-therapy PET we can see there is significant fall in the symptoms and as well as SUMX. Now coming to the relapsing polychondritis. Relapsing polychondritis is a multi-system anatomic autoimmune disorders, and it is characterized by the recurrent episodes of the inflammations in the cartilage and proteoglycans-rich structures. Females are the predominantly involved. Then auricular chondritis is the most common clinical manifestation, followed by arthritis. Some symmetrical uptake in the 2 or more cartilage is pathognomic of relapsing polychondritis. And coming to the FDG PET-CT in relapsing polychondritis, FDG PET-CT has accurately and sensitively detected the active foci of the disease, assess the site for the disease activity, and that are not accessible with clinical examination because airways, vessel involvement, they cannot be assessed clinically. So PET is the useful modality to assess the non-accessible sites. It can also evaluate the presence of the concomitant disorders. Can also be beautiful to monitor the response to the treatment and the potential enabling the early diagnosis and improve the disease control in affected patients. This is the literature from the PGI Chandigarh published by Professor Aman Sharma and me, and we had shown that PET-CT is a very important imaging modality for to diagnose the relapsing polychondritis and in follow up the patients. And this is a case from the same literature showing RP with symmetrical cartilage involvement. We can see the symmetrical cartilage uptake in the bilateral ear cartilage, then nasal cartilage, and additionally we can see the increased uptake in the bilateral lower limbs that was missed on clinical examination. Now coming to the hidden site on RP on PET-CT, we can see increased uptake in the eustachian cartilage that was missed on clinical examination. Patient had vague symptoms and it was missed on clinical examination, and PET very beautifully detected by the PET-CT. Now coming to the response assessment. On PET-CT, we can assess the response to relapsing polychondritis, when to stop the therapy or not. These are pre-treatment, upper two panels are the pre-treatment PET and the lower panels are the post-treatment PET. We can see increased uptake in the nasal septum, in the tracheal cartilages, and on follow-up PET-CT, we can see a significant decrease in the uptake in the nasal septum, and along with tracheal cartilages, there is significant showing significant response to the treatment. Now coming to the vascular involvement in RP. The PET is a very beautiful imaging to detect the vascular involvement in relapsing polychondritis, because that can be missed clinically. So we can see there is this is a patient with relapsing polychondritis, so increased uptake in the bilateral bronchial cartilages along with uptake in the ascending aorta and along with this abdominal aorta. Relapsing polychondritis presenting as a paraneoplastic syndrome. This is a case, 70-year-old male patient presenting with the pain in the left ear, and we did a regional PET image, and resident forgot to involve the chest, and what we found that there is intense uptake in the left pinna cartilage, and this patient was kept on prednisolone, and after that this patient again landed to PGI with the symptom of loss of weight and shortness of breath. CT scan was done of the chest that revealed a nodule in the left lung, and he underwent PET-CT, which revealed FDG-avid soft tissue nodule in the lung, and FDG-avid thickening was also noted in the pinna. And after that, this patient underwent PET-CT guided biopsy from this nodule, and that revealed adenocarcinoma. And this is the pre-treatment PET, and this is the follow-up PET. And pre-treatment PET, these are the axial images, pre-treatment PET, and this is the post-treatment PET. We can see increased uptake in the nasal cartilage, in the auricular cartilage, and along with the increased uptake in the lung nodules. On post-treatment PET, there is significant decrease in the uptake in the lung nodule, along with significant decrease in the uptake in the auricular cartilage, showing again confirming the diagnosis of paraneoplastic relapsing polychondritis. Sometimes relapsing polychondritis may also present as a fever of unknown origin. This is a 32-year-old male presented with fever and cough, and he underwent PET-CT. On PET-CT, what we see, there is increased FDG uptake in the tracheal and bronchial cartilages, and we thought of that this is a case of relapsing polychondritis, and we referred to Professor Aman, and post-treatment there was significant decrease in uptake was noted. And this is the follow-up scan of this patient showing a significant decrease in uptake in the tracheal and bronchial cartilages. And now coming to the FAPI PET-CT in relapsing polychondritis. This is the upper one is a FDG PET, and lower panel is FAPI PET. And FDG PET, we can see there is increased uptake in the bilateral pinna. It's not seen clearly over here, and FAPI PET also increased uptake in the pinna. But additionally, what we can see on FAPI PET is there is a uptake in the cricoid cartilage, thyroid cartilage, and it's again missing over here, and tracheal cartilage that were not seen on FDG PET. So FAPI PET is more beautifully demonstrate the lesions on PET as compared to FDG PET. Now coming to the IG4, most of the IG4 related diseases had discussed by the Professor Sinha. I will be discussing very little. So how to identify IG4 related disease on PET? So we have to look for the pattern of the FDG uptake: symmetrical, diffuse, salivary, and lacrimal gland uptake, orbital myositis, orbital adnexal soft tissue uptake, and on lung we can see bronchovascular thickening and nodules, and that there is diffuse pancreatic uptake with loss of fetal oblations, with or without CBD narrowing, or peripancreatic rim enhancement can be seen. And sometimes we may see vascular uptake, involvement of the iliac arteries and infrarenal aortas, and uptake in the renal cortices and prostate uptake. So we have to check for prostatic uptake, pancreatic uptake, and parotid uptake. All three P's, if are involved, then the diagnosis of IgG4 related disease should be considered. So this is a case showing increased uptake in the parotids, submandibular glands, multiple lymph nodes in the mediastinum, uptake in the bilateral kidneys, and uptake in the prostate, and uptake in the pancreas. So the diagnosis of IgG4 related disease should be considered. So this is an atypical case with the involvement of infrarenal aorta with IgG4 related disease. And this is another patient, young male, presenting with paraplegia, having increased uptake in the lower lumbar vertebrae, and we did a PET-CT guided biopsy from this site that revealed IgG4 related disease with vasculitis. Now coming to Erdheim-Chester disease. Erdheim-Chester disease is another histiocytic disorder, and PET has a very useful role to demonstrate in the Erdheim-Chester disease. We can see uptake in the cavernous sinus, we can see pericardial effusion, we can see paraortic cufflinks, and we can see hairy kidneys. And now coming to the conclusion, PET can demonstrate the extent of the disease and demonstrate the whole body active inflammations. We can identify the site of the occult or occult site of disease that conventional imaging cannot detect, and we can identify the safe and access site of the biopsy to obtain the histological diagnosis, and to assess the response to treatment. PET is a very important imaging modality. Thank you.
We are really in diagnostic dilemma, right? I was regarding atherosclerotic, say coronary aneurysm versus Kawasaki disease associated sequelae and coronary, that's one thing. And second thing, for the peripheral arterial disease with the elderly or adult patient, we are in dilemma whether it is vasculitis associated accelerated atherosclerosis or atherosclerosis as such causing peripheral arterial disease.
Sir, in atherosclerosis, what we can see, there is asymmetrical narrowing will be seen. And secondly, FDG PET is itself is not good modality to image atherosclerosis. We can do sodium fluoride PET that will show beautiful increased FDG uptake in the atherosclerotic plaques, which are calcified. And it will show increased, sometimes it will show increased uptake in the early plaques also. There is many studies in the literature, even some are published in nuclear cardiology. They are showing beautiful demonstration of the uptake on sodium fluoride PET, so demonstrating atherosclerotic plaques.
No, my question is, vasculitis like Takayasu arthritis associated accelerated atherosclerosis. We do come across the patient who do have a disease, and now there is atheromatous infiltration and the peripheral. So here comes the diagnostic dilemma whether to start with the steroid therapy or immunosuppressive therapy after the intervention.
Sir, it's a difficult.
Regarding the calcification, we have come across calcification very frequently in Takayasu, and same is true for the atherosclerosis as well.
When calcification is there, it's a diagnostic challenge for us, sir.
Right.
Ask you a question. So when you are doing the PET-CT scan, you are getting the requisition from almost all the specialties. So how many times you have seen that you have requisition from one specialty, let's say for lymphoma, but you are able to diagnose something else, or you get a requisition from rheumatology, but you are diagnosed, something else also. What is the percentage of those things? Can you, or is it a rare thing, or do you, with so much of, role of PET-CT scan in all these specialties, are you able to diagnose multiple things which are happening in a given patient?
Sir, most of the load what we are getting from oncology sites only, around 70 to 80% from the oncology side, and the rest of the loads we are getting from emergency medicine with fever of unknown region, and then from surgical department with multiple with pancreatic lesions, mass lesions. Sometimes patients landed to us with pancreatic lesions who were planned for surgery, and just before they done a PET-CT, and on PET-CT what we have noticed that patient have parotid uptake, prostatic uptake and pancreatic uptake, and surgery was deferred just because of that only. So we are getting good number of the patients from this side also. So around 10 to 20% of the patients are coming from the non-oncological.
So let me rephrase. You showed one example where only the limited PET scan was done, and
Yes,
then
yes.
later on it was found to
Yes.
be, there was a nodule in the chest, and it was a lung carcinoma.
Yes, sir.
So, do you have any suggestion to give to the audience that, when there is something they are getting it done, and we know that, paraneoplastic syndrome can happen.
Yes, sir.
So, do you have any suggestion, any?
Sir, in that patient, that particular patient, actually our residents were busy and they thought of the relapsing polychondritis is there and ear cartilage will be inflamed. So they did regional PET only. That was by chance only. Otherwise, we would have included
The full
lung. Yeah.
Well, we were just buying times. Yeah, it's always a whole body PET, but
For relapsing polychondritis, we are not doing whole body PET. We are doing head, neck, and
Limited.
chest only.
The other thing is PET actually tells you about the site where an uptake is in.
Yes, sir.
It doesn't tell you the disease.
Yes, but the pattern of the uptake, sir. Yes.
Yeah, pattern can suggest something.
Yes, sir.
That pattern can be present in other illnesses also.
Yes, sir.
For example, if you are Sjogren's, you will have the salivary gland which will take up. So for you to say it is IgG4 versus...
No, only salivary gland uptake we will not consider as IgG4 related disease, sir. We are daily getting salivary gland uptake. We never ever report them as IgG4 related disease. Yeah.
So, lot to learn actually. So, thank you so much, Dr. Rajender, and on behalf of Dr. Rajesh Vijayvergia, we thanks the organizers for giving us the opportunity to chair this important session. Thank you.
Thank you very much.
Thank you, chairpersons. And thank you, sir, for such an elaborate discussion and for such wonderful illustration of cases. Now, we'll be hearing on imaging and rheumatology from Professor Anindita Sinha, ma'am, from Department of Radiodiagnosis and Imaging at PGI. May I invite Dr. Anil Abrol, sir, may I invite Dr. Ashwini Jha, sir, from AFMC Pune, and Dr. Jitin Matthew from Hyderabad to chair this session.
Yeah, good afternoon. So let's hear from Anindita madam about musculoskeletal and imaging in rheumatology.
Thank you, Dr. Aman, for inviting me. And so after the advanced modalities, we'll be going back and forth among the basics. So just a timeline over here. So if you see over here in the 1960s, I don't want you to see everything. There's the color. The yellow color is the radiographs or the X-rays, and the blue is the ultrasound, and the green ones are the MRI. So these are the timelines of specific milestones in imaging in radiology. And this is a 2013 article, so this is I just thought this was an elegant way to describe what has happened. So it is almost filled with blue. And this is what happened in, I think, 1972. The first publication on ultrasound in musculoskeletal happened. And when we were doing our residency around this time, this was the first time that this consensus of the ultrasound definitions happened. And I tell you, when I was doing residency, we were told, don't look at the bones on ultrasound. You cannot look at the bones. This was what was taught to us. And we never really learned how to look at the bones on ultrasound. It was only after this, around 2012-13, when we started looking at ultrasound for rheumatology here, at least in my experience. And by that time, there was already the criteria for development of these guidelines was almost maturing over here. You can see the semi-quantitative scoring system has been developed at this time with Doppler and these synovitis scores that we now currently use. So it takes a lot of time for knowledge transfer to happen and does not happen immediately after the articles are published or even around the time the articles are published. So again, back to the basics. We're starting with rheumatoid arthritis. The first on the radiographs is the periarticular osteopenia, the earliest manifestation. You may not get erosions manifesting on radiographs early on. and that is why we later require the advanced modalities. And then you see these erosions prominently along the wrist and the metacarpophalangeal joints and the PIP, sparing the DIPs classically. And later on, you have these gross structural changes with multiple deformities, multiple dislocations, erosions. And over here, what you see as these overhanging edges, these are the secondary osteoarthritic changes that are developing in an advanced case of RA. So what is the shifting paradigm? We know that radiographs will only reflect the established disease, and this is occurring late in the course. But for monitoring the disease or catching them early, we need something with some modality which catches them early for early treatment so that complications do not arise, deformities do not arise. So there was a need to detect these early and subclinical changes, and these early and subclinical changes are the synovitis, the bone marrow edema, the erosions which are caught late on radiographs. And so now the criteria is that you will, if the earlier, of course, the earlier you diagnose, will get a better outcome, and wait and watch policy, masterly inactivity may not be really acceptable. So what is the current status of ultrasound? Over here you see there is just a soft tissue thickening. This is the tendon, the flexor digitorum superficialis and profundus tendons, and the hypoechoic or the darker thickening around these tendons. This is a tenosynovitis. And you see gross, severe vascular, this Doppler signal around the tendons. So there is active and gross inflammation. And so the sensitivity of the ultrasound is much higher than radiography. You can also assess response easily. And the plus point of ultrasound is that you can do either therapeutic or even diagnostic taps and aspirations. And other than that, there are now, for follow-up or for studies, you need some quantitative scores. And you need to know the normal appearance of synovium. So normal appearing synovium is bright or hyperechoic. And this is the bony margins. So it should not project above the bony margin, right? So here you see that there is a grossly elevated synovium. This is the synovial part, and you see the synovium is projecting outside the bony margin, so there is synovial hypertrophy. We have put up color box in, so there is no flow, but there is synovial hypertrophy. Again, here you see the synovium is bulging out and also going beyond the bone margin from here and going back on the, this is the hyperechoic or bright bone over here, and you also see that there is a discontinuity over here, so there is an erosion. So these are the things that you are picking up on ultrasound much earlier than on radiographs. And you do a Doppler, so this score or whatever is based on two things, the synovial hypertrophy grading and the Doppler grading, where the Doppler, the add both scores or whichever is higher, you give that score. And Doppler, it can be 0 with no flow, just 1 or 3, up to 3 flows is a grade 1. Less than 50% of the Doppler box filling up with color flow is grade 2, and more than 50% is grade 3 Doppler flow. So what are the advantages of ultrasound? Of course, it's widely available, low cost. It is patient friendly. You can use it in patients with pacemakers, with implants. You can use it multiple times for follow-ups. Many rheumatologists are using it at the point of care. And you can use Doppler for activity, for follow-up easily, because the Doppler activity has been shown in follow-up studies to be the first within 1 week to decrease if there is response to therapeutic interventions. And the disadvantages are that most of it, although there is an attempt at standardization, it is operator dependent. There is a time involved. So if today I'm doing a Doppler, the synovial and synovitis assessment and Doppler assessment of all the joints, I can tell you it will take me 15 to 20 minutes earliest to evaluate both the hands, even if I'm doing a rapid scan. Because there are, I'm looking not only at the joint from one aspect, I'm looking at the volar aspect, the dorsal aspect, the wrist, all the small joints up to the PIP and the DIP. And so there is a lot of standardization still left, although there are some guidances given with the GLOS score, that is the Global Omeracular Synovitis score, which looks at the synovial hypertrophy of the second, third, fourth and fifth metacarpophalangeal joints. But this is a very focused study. When you don't know what the patient has and the rheumatologist has sent to you to evaluate for synovitis or evaluate for early inflammatory arthritis, you have to look at all joints. So these are very specific guidances, but otherwise you need to look at all the joints, all the tendons also, to see if there are tenosynovitis, if you don't find any synovitis or any Doppler for anywhere else. Even erosions, you have to be very careful. You're looking at the midline and not off midline, because the metacarpal bones, they slant off midline, and you'll be erroneously diagnosing erosion. So there's a learning curve involved. So there are multiple scores, and remembering each score is very difficult. And the basic score that I told you is just the synovial thickening score and the hypertrophy score and the power Doppler score. So now MRI also is utilized, and there are qualitative as well as quantitative scoring done. The advantages over ultrasound, bone marrow edema is not picked up on ultrasound obviously, and bone marrow edema is important to pick up because we know that bone marrow edema is a precursor to erosions. It can lead to deforming changes, and MRI can pick up bone marrow edema and erosions very, very early on. In fact, sometimes even 1 year earlier than routine radiographs. And if you see contrast enhancement along the erosions, again, that implies that there is an actively inflamed synovium. It can also be used for a prognostic marker with contrast, and where you see there is still active contrast enhancement, that means that there is active disease, and so you can use it for response assessment. So there are atlases available where you calculate each of these scores. It's a very, very cumbersome atlas. We have used it in studies, and I'm telling you there are 10-point scoring systems in some of these, and it takes 1.5 to 2 to 2.5 hours to evaluate the MRI features of all the joints. I mean, it cannot be done in a routine clinical setup. That is one of the greatest drawbacks of these atlases. But in MRI, you do get standardized images. In ultrasound, if you have adequate experience, you will also get standardized experience. So it's all about learning curve. So the disadvantages of MRI, of course, that is a very cumbersome thing to do. Even patients don't like it because you have to lie still for 45 to 1 hour. And the positioning is very cumbersome again for wrist and hands. It has to be a specific position. Many patients cannot manage it. There's a lot of movement. Other than that, again we go back to the basics. If you have to differentiate it into what type of arthritis is it, both ultrasound and MRI are used just for grading the type of synovitis. Is it there or not, then grading. So most of the role is in finding out whether it is present or not, and where is it present. Anatomical guidance can be there, but you really cannot differentiate sometimes whether it's RA versus psoriatic arthritis versus other type of inflammatory arthritis. And of course on MRI you cannot do a therapeutic intervention. And also another important point is that many rheumatologists I know, they do not base their outcomes on the findings on ultrasound and MR. So this is a disclaimer from us. Now there are some advantages, advanced imaging mechanisms like CT dual energy, but again this is not standardized. We CT dual energy both for gout as well as for bone marrow edema. The bone marrow edema studies are mostly on large bones. You see this article, we don't have the bone marrow edema, nor the gout protocol in this institute till now. So here this is the green area which shows the bone marrow edema, which is corresponding to the bone marrow edema on MRI. This is an article from Radiographics. But you see there is an artifactual uptake of suggesting bone marrow edema in the distal phalanx, whereas there was no edema in the distal phalanx on the MRI. And on the virtual non-contrast, you can see that there is synovitis, but so there is a lot of standardization left in CT dual energy. Again, you see here beautifully there is synovial thickening or synovial hypertrophy, and adjacent to the synovial hypertrophy, like we learned that the pannus adjacent to it causes that subchondral edema erosion. You can see that osteitis has developed here. This is the bright area, which is the osteitis or bone marrow edema seen. And again, adjacent to the synovial thickening, adjacent to the scaphoid bone, here you see again subchondral bone marrow edema. There are similarly subchondral edema areas in the metacarpal bases, and adjacent to that you see this is the sagittal section, you see an erosion. So it really follows what the textbook teaches you, but it is not only teaching you about the synovitis erosions, you can also do it for diagnosing some complications early on. For instance, in rheumatoid arthritis, here there is this erosion of the dens, and that can sometimes happen, and this catches them early on before any subluxation happens. This is another case where this erosion was there, but you can see on the hands there are gross erosions and synovitis with inflammation. So characteristic features I told you are picked up on radiographs only, with this penicillin cup with arthritis mucilans in psoriatic arthropathy, new bone formation in psoriasis. And next on to psoriatic arthropathy, new bone formation is the sine qua non, which is not found in RA. And you have these mouse here, appearance in the interphalangeal joints here, and involvement of the PIP as well as the DIP. But I'm not going into the differentiating features. Gout, the radiological hallmark is tophus, but the diagnosis is mostly clinical. The tophus can be non-calcified or it can be calcified, and it can be in any place like the juxta or intraarticular or subchondral. You can have erosions with overhanging margins, and the characteristic feature is the joint space is preserved till late. And in ultrasound, again, you get the same features of synovitis, erosions, but you can get typical features which are included in the diagnostic criteria like double contour and snowstorm. I'll be showing in the next slide. And here you see this in the hand, again, an atypical area where you see these overhanging margins suggestive of gout. Dual energy picture, again, borrowed from another, showing that urate deposition, color-coded here. The green ones here, these are the urate crystals. So gout, again, ultrasound can show this double contour sign here. You see along the bone margin there's a double contour and a calcified deposit of a gout. And you can also have bursitis in gout, which shows these urate crystals over here in this patient. And this is excellent for imaging all the entheses, bursa, for the intradental deposition and the subcutaneous nodules. For crystal arthropathies, the picture almost mimics the OA, but they are in atypical sites. So if you have an OA-like picture over here, with this scaphoid and lunate advanced collapse, look at the TFCC, there is calcification, so there is chondrocalcinosis. And this is an osteoarthritis developing at an atypical site. So this is a SLAC, which is a scapholunate advanced collapse, occurs in the crystal arthropathy. Similarly here, this is a shoulder with calcification in the bursa within the tendon. Here, this is a calcification within the ligament in the hip. So these are all evidences of early to late crystal arthropathies. But beware, here we thought this was a crystal arthropathy, but see the area of calcification going down. There is no bursa in this area. This was actually a calcified tubercular abscess, so there are always mimickers at hand. Spondyloarthropathy, again in a vast spectrum of disease. Dagger sign, enthesopathy with whiskering, and complete ankylosis is not the stage where you want to pick these up on. This is again one syndesmophyte, the smooth, thin lining, the squaring of the vertebra, and some shiny corner sign over here. MRI we do for diagnosing sacroiliitis and also for adjacent bones, which can be, if you do a pelvic screening, you can pick them up. We don't generally use contrast, but in this young patient where cartilage appears hyperintense, you see contrast enhancement, and it helps you differentiate whether it's actual cartilage or spondyloarthropathy. For MRI of the spondyloarthropathy, coronal sections are required because costovertebral joint involvement is typically present. And you also have to image for complications with the Anderson lesion, and sometimes you get atypical fractures with hyperextension type of injuries, which can mimic either infection or trauma. Systemic sclerosis, again acrosteolysis or calcinosis cutis, and the barium swallows were the standards. Now you have, we do the chest CT, you will find the NSIP pattern or fibrotic type of NSIP. Look at the esophagus always. Skin thickening, we are doing ultrasounds also to look at whether there is edematous thickening, what type of thickening between the epidermis, dermis, and elastography, which is coming into the guidelines also. And ultrasound and MRI, again our study showed that low-grade inflammation is present, including erosions, edema, synovitis, acrosteolysis. There was agreement, fair agreement, and you see that there are erosions and synovial thickening in the PIP and the DIP, as well as acrosteolysis in the same patient over here. Whole body imaging or head-to-toe imaging in Sjogren's syndrome, not only the parotids with anechoic thickening. May I continue with a few more?
Yes, please.
Thank you. So anechoic or hypoechoic cysts within the parotid glands, again the definitions are being standardized now. MR cyclography showing these cysts within the parotid gland, but these patients have multisystemic involvement, like Dr. Sinha showed. There is this narrowing of the on the MRCP. This is an involvement with Sjogren's syndrome here at the primary confluence. Systemic intracranial vasculitis with narrowing of the MC over here. And these patients are also prone to having lymphomas. So this is a patient with Sjogren's who had this nodes in the pelvic region, also had a lung nodule, and this was an NHL. So we have to think beyond it for complications. For muscle inflammation, it can be as obvious like inflammatory myopathies. There can be diffuse hyperintensity, or also look at the skin and subcutaneous tissue where there will be reticular appearance. Lung involvement can also be there, and sometimes it is just limited to fascial involvement. And on the you also have to image for complications like myonecrosis. So whole body imaging we sometimes do in JIA to look for inflammations, but the typical radiographic feature advanced is the carpal fusion, carpal collapse over here, widening and almost mushroom-like appearance of the pelvis and the mega epiphysis due to inflammation from childhood. and this is the complication which leads to the.
Ma'am, we have to take some questions also. So if we
So
can.
I'll just. Okay, so for just last slide. From head to toe, there is a lot of imaging that you have to do as a radiologist, and so this is the Coombs sign in SLE. This is the temporal artery halo sign. I'm not covering most of this. This is the Behçet's. This is a borrowed image showing the cascade sign in Behçet's. And this is a case of Sappho where you see the hyperostosis and the bullseye pattern in nuclear medicine. And again, there is no lack of standardization. So just the take-home points is that there is a lot of positive correlation between subclinical synovitis and radiographic progression, including ultrasound and MRI. Validation process is an ongoing process. And again, to conclude, substantial amount of rheumatologists don't really let ultrasound and MRI influence their clinical decision making. Thank you. This is a 3D ultrasound image, and my mind boggles. If I have to look at this image again, it will take me 1.5 to 2 hours to decode these. So sometimes all advancements are really not clinically relevant. Thank you.
Thank you, Professor Ananta, for that very lucid talk. Now, if there are any more questions, any questions from the audience, we would like to take them, please.
Ma'am, can I ask a question? One of the common reasons why we send across to radiology is usually when we have a single joint or a couple of joints involvement, and we always this question of infection versus mostly tubercular versus inflammatory. So in your practice, from all these referrals that you get, what would you say is the rough proportion of whom on radiology itself you can say most likely this is infectious on an average out of every 10 that you get?
That is actually the most practical question that we always face in our rounds. And there are very, very few signs which are actually specific. So if you look on the radiograph, if you have a patient with arthritis and you see a lot of periostitis away from the joint, that is again a marker for infection, whether it be in a monoarthritis, whether it be in a diabetic foot scenario. So that is a marker for infection. Other than that, if you see a lot of extra articular collections, extra articular myositis which is beyond the joint and not explaining what is happening around the joint, these are the few features which help us tilt our diagnosis in favor of infection rather than inflammation. It is not foolproof. We do send for culture and sensitivity, and sometimes we wait for that to come as positive. So nothing is foolproof. Thank you.
Thank you, Professor Ananta, for a very enlightening talk. Thank you so much.
Thank you.
Then we close this session. Thank you.
We announce this session to be closed.
Thank you, chairpersons, and thank you, ma'am, for such a beautiful display of cases. Now we move on to our next session on systemic sclerosis. First up is debate on the topic whether antifibrotics should be used upfront in scleroderma ILD. So there are many cobwebs regarding this proposition and no clear answer. So dissipate this confusion, we have Dr. Chirag Kope who will be speaking for this topic and Dr. Nupur Acharya who will be against it. May I invite our chairpersons, Dr. Ashit Singhal from Fortis Mohali and Dr. Prateek Dio from Bhopal.
Can we have his slides, please? Slides? Okay. Good evening, everyone. At the outset, I would like to thank the organizing committee, especially Aman sir and Shankar Naidu sir, for inviting me here for this talk. So today I'll be debating for the motion that antifibrotics should be used upfront in systemic sclerosis related ILD. So my arguments will be based upon the evidence supporting the use of antifibrotics in systemic sclerosis related ILD. I would also emphasize on the mechanistic role for early intervention. And lastly, I would conclude by saying how benefits outweigh the risk and cost consideration in this condition. So when you look at the natural history of systemic sclerosis ILD, just the mere presence of ILD has got an increased mortality in these patients over long term. They tend to do poor over long term, especially when there is pH associated. They have furthermore increased mortality. Looking at the natural history of the lung disease, so most of the patients have the lung involvement in the initial 5 years of the disease. The 5 years of the disease is very crucial, and in the later part of the years, very hardly few percentage of patients develop ILD. And when you look at the time course in systemic sclerosis, there is initially activity and irreversible damage going on simultaneously together, wherein the patient may land up in irreversible fibrosis more, which can affect his long-term survival. On average, there's a delay of 3 years from the onset of Raynaud's phenomenon to diagnosis of ILD, and from non-Raynaud's phenomenon onset, there is roughly a delay of 1 year. So already their damage has been setting in. So what's the critical point where you want to start the antifibrotics? So to answer this, there's one more slide. So this is one of the old paper from Virginia D's team, where they have looked at the rate of loss of lung function in patients with systemic sclerosis, and the damage was highest in the initial 2 years. And most of the patients in this early phase of disease did not manifest any symptoms. Their lung damaged very silently over this phase. If any interruption and prevention of the fibrotic process is to occur, we should do here in the early phase. So to support this, this is the long-term follow-up data from SLS1 and SLS2 trial. So what happens if the patients have a critical lung damage in the initial period, and how does it affect their mortality in the long term? So this is the SLS1 trial data. So the patients who had a QOLD score change of more than 2% in the initial 1 or 2 years, they tend to have higher mortality in the long term. That is at 10-year and 12-year follow-up. So the preservation of, the halting the fibrosis is very important. So higher fibrosis translates to long-term mortality, especially in the initial years. Similar conclusion we can see from the SLS2 trial, wherein we can see the ILD score change of more than 2%, where they have defined that is the critical zone. So in the early years has got a higher mortality in up to 4 years. Then also when we look at the lung function decline, the FVC decline in the initial years, that also has got higher hospitalization rates, death, and ICU admission. So preservation of FVC and halting the fibrotic process is crucially important as early as possible in systemic sclerosis related ILD. And already there is a 1 year delay in the diagnosis. Initiation of antifibrotics upfront is beneficial. So there are 2 antifibrotics which we use clinically. One is nintedanib and the other is pirfenidone. So nintedanib acts by inhibiting platelet-derived growth factor receptor, alpha and beta, and also by inhibiting fibroblast growth factor receptor and vascular endothelial growth factor receptor. So by inhibiting this inhibits the fibroblast migration in the lung tissue and decreases the transformation of fibroblast to myofibroblast. And it also further helps decrease the extracellular matrix deposition in the lung tissue, thereby halting the fibrotic process. So this is evidence from this large randomized controlled trial, the Census trial, which was published in NEJM 2019, where around 576 patients of systemic sclerosis related ILD were randomized into 2 groups. So 288 patients in each arm. So one group received nintedanib, 150 mg BD, the other group received placebo. And at the end of 52 weeks, we see there is a remarkable preservation of FVC in the nintedanib arm as compared to placebo. There is almost 44% risk reduction with nintedanib. So preservation of FVC is more with nintedanib as compared to placebo. So in the Census trial, when you see, both early and established group of patients were included. So the median duration of disease was around 3.4 years, ranging from 0.3 to 7.1 years. So in early ILD also, nintedanib helped. And in inclusion criteria, they had taken HRCT demonstrating at least 10% fibrosis of the lung parenchyma. And if you see, 1/3 of the patients recruited in this trial did not have any cough or dyspnea. They were asymptomatic. So most of the patients have ILD going on silently in their lung, which contributes to long-term mortality. And as we have seen, nintedanib significantly reduces the rate of FVC decline over time, thereby decreasing the risk of hospitalization and death over time. So looking at the risk factors for decline in FVC in systemic sclerosis or ILD, shorter SEC duration, that is less than 18 months, has got a poor prognosis for ILD. And apart from that, male sex, elevated inflammatory markers, progression of skin fibrosis, and presence of diffuse cutaneous type of scleroderma has got a increase in FVC decline over time. when you look at the data, when nintedanib was initiated in early subset of patients here, the efficacy decline is much less at 52 weeks as compared to the placebo arm. So even in early subset of patients, nintedanib has got an important disease modifying role. And even in patients who did not have any dyspnea and who did not have any cough here, nintedanib numerically fared better as compared to placebo in preserving the lung capacity. This is the extended follow-up census on trial, the 1 year and 3 year extended data. Here if you see, the patients who had initiated later on in the course after 1 year, that is the lower line, they had more efficacy decline at the end of 2 years. So this shows that early initiation of antifibrotic, that is nintedanib, helps preserve lung capacity over long time. That is demonstrated by the 2 year data here. Similar findings were reflected in the 3 year data also. So delaying treatment leads to irreversible lung function loss, as shown in late nintedanib initiation outcomes. Early nintedanib use should be the standard to stabilize the ILD and improve the long-term outcomes. So lastly, I'll be showing this mouse model, this FRA2 mouse model of systemic sclerosis, where the mouse had both both fibrotic and inflammatory phenotype. So here, after the census trial, they have seen whether MMF would work better or nintedanib would work better in the mice. So after that, they have seen. So this is the mice. So this is the fibrotic area which is seen in the red color here. The mice which are given MMF, they had little bit more fibrosis, and who had given nintedanib, they had literally no fibrosis at all. So nintedanib helps in halting the fibrotic process very effectively, as shown in the lung tissue here. So also the fibrotic scores, when you see MMF shows no significant response in the fibrotic scores over time, but whereas nintedanib has got a significant decrease in the fibrotic scores. And also the fold change in hydroxychloroquine, which is extracellular matrix deposition protein. So that also is significantly less in this mice in nintedanib group as compared to the MMF group. Thank you.
Dr. Nupur for speaking against the motion.
Good afternoon, everyone. I'm Dr. Nupur, and I'll be speaking against the motion that nintedanib antifibrotics should not be used upfront in scleroderma ILD. There is a little bit of delay with the presentation. So my colleague Chirag has already spoke in favor of the motion, and he has shown you very beautiful diagrams and lots of studies and numbers and mouse models. But now we'll look a little bit critically on the results of those studies, and then we'll reach to the conclusion that it should not be used upfront, and I'll give you the causes why it should not be used. Only if we could find my PPT, we'll start. Yeah, this topic is it's close to my heart because my thesis was in this same field. I studied the efficacy of pirfenidone, which is another antifibrotic, in scleroderma patients. And it was the first RCT to be done in that field.
Seems like the delay is equivalent to the delay in starting treatment with antifibrotic.
The Perfenidone study has been highly
It's
cited
a
and is a
heavily
part of the
cited
guidelines
paper.
also.
Yes,
The guidelines
it has
also
been
recommend
included.
using citation of the Perfenidone study done from PGI.
I mailed it to them, but I always have it in my mail.
Can you download from your email actually if you have a slide set on the email?
Right. Probably is gone to do that.
Come back to this presentation later.
Sure.
It's a debate.
Ma'am, would you like to speak without the presentation? Extempore, since you are, since you are, this subject is close to your heart.
I can start, but then I'll need to go back to it.
You can use this slide if you want to show the same study.
So whenever we talk about using a new therapy in any disease, we have to look at three factors. First, its efficacy. What is the evidence we have of efficacy of that drug in any particular disease? And next, we have to look at its safety profile, its tolerance. And third is cost effectiveness, which is very important in our setup because we have to look at the cost of therapy. Okay, so when we talk about antifibrotics in scleroderma ILD, we basically have two drugs that have been studied. First one is nintedanib and second is perfenidone. So we have two RCTs done till date in perfenidone in scleroderma ILD. The first study was done here at PGI. I was the investigator in that study, and we failed to show any significant improvement in terms of lung disease or skin disease with perfenidone. Similarly, SLS3 study was carried out in US, and that study was also underpowered, and no significant improvement was shown in that study as well. So Chirag has already gone through the pathophysiology of systemic sclerosis and the prognosis and disease course. So I'll not go into the details of those. I will directly go to the evidence and why the evidence does not support the upfront use of antifibrotics in scleroderma ILD.
It's there. It's there.
Extend करना था क्या? So we have already gone through the role of fibroblast and fibrosis in the pathogenesis of systemic sclerosis. I'll not go through that again. We have already discussed this. So there are 3 drugs that were studied: nintedanib, pirfenidone, and lenabizim. So let's coming to the recommendations on antifibrotic therapy in scleroderma ILD. So there are 4 recommendations in last 2 to 3 years that have recommended the use of nintedanib in systemic sclerosis ILD. So EULAR states that nintedanib should be used alone or in combination with MMF for treatment of scleroderma ILD. Similarly, BSR 2024 guidelines suggest the use of nintedanib in progressive pulmonary fibrosis despite immunosuppressants use dependent on tolerability. It may be considered as a first line in combination with MMF where there is extensive fibrosis on presentation. Similarly, in ACR Chest 2023 guidelines, they have recommended the use of nintedanib conditionally as a first line, and they have elaborated that immunosuppressive medications are favored as first line therapy, and nintedanib should be used as an additional rather than a preferred option when we are treating scleroderma. In the American Thoracic Society clinical practice guidelines, they have also recommended nintedanib to treat patients under conditional recommendation because they have said that the quality of evidence is very low. We'll come back to the recommendations that why these kind of recommendations were made. So pirfenidone, I have already discussed that there are only 2 RCTs published for the use of pirfenidone. First was from PGI and second one was SLS3 study, and both these studies have failed to show any significant benefit with pirfenidone, and so it has not made into recommendations so far. Second drug was lenabizim, and it also failed to show any improvement in both Resolve 1 and 2 trial, and it is not currently being studied in scleroderma as of my knowledge. Now coming to nintedanib trials. So nintedanib is the only antifibrotic that is currently recommended. So the evidence for the use of nintedanib primarily comes from Census trial, which is the largest RCT in scleroderma ILD patients. And some evidence comes from INBUILD trial and Census on trial, that is a carry forward trial of Census. So Census trial was published in 2019 where they studied the use of nintedanib 150 milligram twice a day in patients of scleroderma ILD with or without immunosuppressants. So in a Census study, they found a difference of 41 ml per year, that is 1.2% difference in the decline of FVC at the end of 52 weeks between the placebo group and the nintedanib group. Why is it important? We'll come to that. INBUILD trial studied INBUILD trial was not in scleroderma ILD patients. This included progressive pulmonary fibrosis patients who had ILD due to any cause, and here they found a little bit greater difference of 107 ml per year in the decline of FVC at the end of 1 year. So here almost 70 to 80% patients were of UIP variant and significant fibrosis. In Census on trial, they studied the effect of nintedanib in patients, in subset of patients who had limited cutaneous involvement. In all these trials, if you look at the adverse effects, diarrhea was a very common adverse effect seen in almost 70 to 80% of these patients. Now, why is it very important? Because in scleroderma patients, GI problems are already very troublesome. Most of these patients, they suffer from regurgitation, reflux, and many of these patients suffer from recurrent diarrhea. So diarrhea is a big problem in such patients. And if you look at the numbers, almost 16 to 19% patients discontinued this drug in all these trials because of this side effect. Now let's have a closer look at the Census trial. So this trial included more than 500 patients. If you look at it, the baseline characteristics, almost 40% patients had extensive fibrosis. Now, they have already mentioned in their data that they have provided that almost 50% patients, including in nintedanib and placebo group, were either on MMF or methotrexate. And they have excluded the patients who were on other therapies, but they have not provided any background information of immunosuppressants that these patients might have received 6 months prior to the enrollment of in this trial. So we can safely assume that many of these patients would have received some immunosuppressants in the past before they were enrolled. Now coming to the results. Now this is very important. When you look at the data and you look at the significant results, they have only provided statistical significance. Now we have to realize whether that is clinically significant or not. Now if you look at it, yes, there is a significant difference between the placebo and the nintedanib group. But how much was the difference? It was only 41 ml per year. That also in decline, not improvement. There was no improvement shown in any trial by nintedanib in any subset of patients. So it is very important to know, because I'll come to other drugs and other trials and you will see the difference in efficacy. Okay. Now when we talk about percentage in decline, so there was only a difference of 1.2% per year in the FVC decline. When we talk about clinically significant decline in FVC, most studies consider more than 5% or more than 10% decline as clinically significant. There is no difference between the two groups when we come to the clinically significant decline part. And also there is no mortality difference. I have already talked about the adverse effects, so I will not go there. Now let's compare the efficacy between nintedanib and other drugs, other immunosuppressants that are commonly used. So if we look at cyclophosphamide, so it was studied in SLS1 and SLS2 trial. In SLS1, there was no improvement, but there is a difference of 2.5% between cyclophosphamide and placebo group. And in SLS2, cyclophosphamide actually showed an improvement of almost 3% in the two groups. Similarly, MMF also showed an improvement in FVC at the end of 1 year. Rituximab is also used in scleroderma ILD, and in a meta-analysis showed 7% improvement in FVC. Now when you compare this to nintedanib, what is the difference? No improvement, just 1.2% difference in decline. I have not included tocilizumab and stem cell therapy because the difference is even more pronounced there. So now coming back to the recommendations. So now you have seen the results. You have seen the comparison between the results from different trials on different drugs. Now you can understand why these recommendations were made like this. Because immunosuppressants have shown a much better response than nintedanib. Now, if we talk about the cost of therapy, one tablet of 150 milligram of nintedanib, its MRP is 80 to 100 rupees. That is much more than MMF. So if you give 150 milligram twice a day, you add on to almost 5 to 6,000 to the therapy with a very minimal improvement, not even improvement, with a very minimal change in the results. So I would like to emphasize that nintedanib, yes, it should be used, but we have to be very selective where to use it, because it has shown very modest stabilization in scleroderma ILD, and the recommendations are based on a single study. When we compare it to other immunosuppressives, the results are not that impressive. Adverse effects were also quite common and discontinuation rate was quite high. So if we add nintedanib upfront in all patients in scleroderma ILD, will increase the pill burden, will increase the side effects, and a significant increase in the cost of therapy. We need future research. More research should be done where nintedanib has been used upfront in patients of scleroderma ILD, not on previous immunosuppression. And currently, I would suggest that it should be used as an add-on therapy where the patient is worsening despite immunosuppressants, or where the patient has extensive fibrosis on presentation itself. Thank you.
Thank you, ma'am, for that presentation. So there are a few points I want to rebut. So when you look at the natural FVC decline of a normal person who is around 50 to 60 years of age, it's roughly around 30 to 40 ml per year. So in this trial, So in this census trial, when you see the FVC decline, it's around 52 ml. So it's near close to there. When you see in the placebo arm, it's around 94 ml per year, which is nearly double as compared to what a natural person would have a FVC decline over 1 year. The second point is the diarrhea point. So diarrhea is an inherent class effect due to the nature of the drug. It's a tyrosine kinase inhibitor, and tyrosine kinase inhibitor irritates the gut mucosa and it can cause diarrhea. So what experts recommend is that it should be taken along with food, and the food should be low fiber, low protein, and low fat diet. And other important point is that it can cause weight loss in some of the patients, and it can increase the mortality in some of the patients. So to counteract that again, so there are specific expert recommendations such that the patient should have at least 5 times meal per day, 3 major meals and 2 small meals. So in this way, you can mitigate the side effects of nintedanib. The other thing is that if the patient has diarrhea, you can start at a low dose, 100 mg BD, and when the patient tolerates, you can increase it further. And the other point is that some of the patients have very severe diarrhea. In some patients, they have used this ramosetron, which is 5-HT3 inhibitor, to mitigate the diarrheal effect of nintedanib. And this is the only FDA-approved drug till now for systemic sclerosis apart from tocilizumab. Neither MMF nor cyclophosphamide has been approved by the FDA for treating systemic sclerosis. And what ma'am showed was that this MMF and cyclophosphamide rituximab has got a greater effect size in the FVC decline. So if you see in the census subset analysis, where nintedanib was used with MMF or without MMF, the FVC decline is same. There is no difference at all. So adding MMF makes no difference. In the last mice model, which I showed you, there is an increase in the fibrosis at 16 weeks, whereas in nintedanib treated mice, there is no fibrosis at all. So I would recommend treating my patients upfront with antifibrotics.
Just one small point.
After Dr. Nupur, actually.
So Chirag has very well explained that what a patient should do to avoid those side effects. But the point is not that. Whether we should subject every patient to that side effect, whether it is worth those side effects is the question. Yes, nintedanib should be used. Yes, it helps. But should it be used in every patient upfront who are being treated for scleroderma ILD, or should we wait to see the response of immunosuppressants who have shown to have a greater response? See, even in census trial, there was no difference between the group, whether in the MMF treated or untreated group, but that was not the question here. Obviously, nintedanib has a difference with placebo, but it was not compared with any other immunosuppressants. The effect were not studied there. So I'll still say, yes, yes, 50%. 50% patients were, nahi, ma'am, 50% patients were, almost 50% were on MMF during the study. We don't know whether they received immunosuppressants before the study. That data we don't have. So whether these patients, yes. No, it showed a difference anyways, but that is not the question here. Whether we should give it in every patient, or we should first try immunosuppressants, look for the effects. Yes, whether. So I'll still say that we should not use it upfront. We should use it with discretion, whether the patient need it or not, whether the fibrosis is significant enough, or whether immunosuppression alone will work. Thank you.
You wanted to make a point, yeah.
I just wanted to ask Dr. Chirag, is spirometry accurate to 1%? What is the same for the same patient? If you have 3 attempts, is it accurate to 30 ml? So this is something where you have to understand numerical difference and clinically significant difference. Has got a lot of. It is something like saying after taking so-and-so drug for 2 years, I have 0.2 erosion score better. Right? Numerical difference and clinically significant.
Point well taken. Point well taken, actually.
First few slides, where the FVC decline has shown increase in the hospitalization rates and increase in mortality. So it matters for the even 30 for him also.
Dr. Aman wants to make a point here. Dr. Aman.
actually, this debate has been going on since SLS1. In UR, based upon 2% improvement in FDC, in one hall they were saying you should use it. And in the other hall, it was been said that just because there was some improvement in cough scores, which may or may not be significant, you should not be using it. So either it is half, whether you look at it, the glass is half empty or half full. We don't have a very ideal treatment since because we don't have anything else. Many times there are recommendations not based upon the primary treatment outcome being met, but just because you don't have something else to offer. And just like the SLS2 trial, probably the answer that immunosuppression or non-immunosuppression, the answer probably would come from SLS3. Oh, no. So वो cabinet हो गया.
Sir, I would like to ask a question, sir. Since I've been in practice, sir, even when we take a decision to start nintedanib, whether upfront or as an add-on agent, when do we decide to stop, or what is the end goal of giving nintedanib? Because even at PGI, we used to see that patients continue nintedanib for 4 or 5 years. So if it is an iffy role, when to stop it? That is a question, sir.
It is a very difficult question actually, because what effect will you study at the end? Because the difference is so minuscule. I currently saw a patient who was taking pirfenidone for 15 years with no difference in, no improvement.
The answer is that many of these patients, the disease does. So you can stop it sequentially, you can stop MMF, but most people give both antifibrotics and
immunosuppressant
Nobody is giving antifibrotics
as a monotherapy.
I think this is there is no data to support. Probably this has to be expert driven and individual, as we are discussing for the ANCA vasculitis, which holds true for all rheumatic diseases. We don't have guidelines to stop, and then individual treatment decisions has to be taken on case to case basis and person's own experience.
Let's throw the vote open to the House. Let's see how many favor by show of hands an early initiation of antifibrotic upfront in. So one. Of course.
At least इसने अपना तो हाथ खड़ा किया है.
He believes in himself at least. So do I
it was
take
a tough call, Chirag.
What about? Yeah. What about the people who will delay in initiating nintedanib upfront? Actually, antifibrotic.
Jitin wants to say something.
Delay.
So how many people would favor a delay in initiating antifibrotic? Okay. So the majority is with that. Okay. I think we would both like to thank the organizers, especially Dr. Aman, for inviting us for such an insightful session. We learned quite a new things, and thank you so much. And now this session is closed. I think Dr. Shifali has the next talk.
Thank you, chairpersons, and thank you, debaters, for such a thought-provoking discussion and persuasive arguments. Now we'll be hearing from Professor Shifali Sharma ma'am on how to manage scleroderma ILD in 2025. And to chair this session, may I invite Professor Ashish Bhalla sir, Chief of Infectious Diseases Unit at PGI, and Dr. Sadbir Gaur from Fortis Hospital, Mohali.
Slide कहाँ से है? Okay, there were a lot of problems. So the talk which I have been allotted is managing systemic sclerosis ILD in 2025. So so as we all know that systemic sclerosis is a multi-system disease having skin sclerosis, inflammation and vasculopathy. And the most important organ which leads to the most morbidity and mortality today is the interstitial lung disease. So I will be focusing on ILD here. Any person who has been diagnosed with systemic sclerosis and has ILD requires treatment for the same. And mostly we see that we have fibrotic NSIP, 60% involvement, 20% has cellular NSIP, and 8% of the patients have UIP. Very rarely we come across other forms like organizing pneumonia and other forms of ILD. And like we have seen the debate that has already been going on, so it has been found that antifibrotics work best with fibrotic NSIP. So many people start antifibrotics for the fibrotic NSIP upfront rather than the cellular NSIP. So I have taken the latest American Thoracic Society guidelines for how they recommended treating systemic sclerosis associated ILD. So they divided ILD on the basis of initial diagnosis, stable scleroderma ILD and progressive scleroderma ILD. So as we all know that patients, we upscaled the treatment if the FVC decline was more than 10% within the last 12 months, or if the FVC predicted was less than 70%, or there was increase in fibrosis in the HRCT, which was more than 20%. But now, according to the latest guidelines, progressive scleroderma ILD is defined as worsening dyspnea or cough and physiological evidence of disease progression, which is now more than 5% absolute decline in FVC or more than 10% absolute decline in the DLCO, and the radiological evidence of disease progression in CT. So we know that the ILD treatment we detect either by a PFT, HRCT, and we stage according to the CTs, and we give additional therapy like the PPIs, H2 antagonists, prokinetics, oxygen therapy when required. And there is one best clinical practice statement that the daily dose of corticosteroid should not exceed the equivalent of 15 milligrams of prednisolone. So what drugs do we have in our kitty? So the cyclophosphamide, mycophenolate, rituximab, tocilizumab, and the antifibrotics. So going to through the some of the few main studies which have been done in scleroderma ILD, the SLS 1, 2, and 3. So the SLS1, as has been already said, that it was on done on oral cyclophosphamide 2 milligrams per kg. It showed a modest benefit in improvement in FVC percent, skin score, and the health-related quality of life measure at the end of 1 year. However, the benefits decreased and disappeared at 2 years. So that meant that we usually induce with cyclophosphamide and maintain with something like azathioprine or MMF. That is what we routinely do. So then this study was done way back in I think 2004, in which high-dose prednisolone bolus cyclophosphamide in ILD was given. But here we gave it once monthly for 6 months, and then we tapered it to once in 3 months. And this was also showed significant benefit. However, we continue to give maintenance therapy with azathioprine or MMF. Then the SLS2 came, which showed that MMF, an inhibitor of the inosine monophosphate dehydrogenase, which impairs the T and B cell proliferation. And it compared MMF with cyclophosphamide, which was till now the standard of care because of the success of SLS1. So this was a double-blind trial in which one group got MMF 1500 milligrams BD for 2 years, whereas the cyclophosphamide got oral cyclophosphamide for 1 year, and it got placebo for the next year. So in this, there was change from baseline in both the arms, which was significant as far as the FVC was concerned. The p-value was 0.24 between the two arms. So both the MMF and the cyclophosphamide showed improvement in FVC percent predicted and DLCO percent predicted at both 12 months and 24 months. But there were fewer withdrawals in the MMF group, and there were much less side effects in the MMF group. So the MMF became the new favorite for scleroderma ILD. And we have this study from our center, the effect of MMF on systemic sclerosis related ILD with mildly impaired lung functions. Here we used MMF for an FVC greater than 80% as well. So The other drug which we have is rituximab. Rituximab is a monoclonal antibody that binds to the cell surface proteins found on B cells to eliminate them. B cells are thought to play a key part in the pathogenesis of systemic sclerosis. Now, systemic review shows that there are 3 RCTs on scleroderma ILD. However, 2 of the studies enrolled participants of scleroderma without a prior confirmation of ILD, providing only indirect data on scleroderma ILD. And in all the 3 studies, the dose of rituximab that was used was different. In one study, the rituximab was given on day 1 and 15 and at 6 months. In the other, weekly 4 doses was given at baseline and at 6 months. And in one, only 4 doses were given at baseline. So all had different treatment protocols that were followed, and the committee made a conditional recommendation for use of rituximab because there was very low quality evidence in favor of rituximab. So what is the other drug which is available? It is tocilizumab. We know that elevated concentrations of IL-6 have been associated with skin fibrosis and development of scleroderma ILD. So tocilizumab is a monoclonal antibody that targets the IL-6 receptor. So we have 2 studies, the FASCINATE and the FOCUS trial. And the FASCINATE trial was a phase 2 RCT that assigned 87 subjects with scleroderma across 5 countries to subcutaneous tocilizumab or placebo for 48 weeks. The open label extension was extended to 96 weeks and gave tocilizumab to 30 subjects in the original tocilizumab and 31 subjects in the original placebo arm. So, as you can see that there was a significant improvement in the MRSS in the tocilizumab arm, and also there was less decline in the FVC in the tocilizumab arm. The FOCUS trial was a phase 3 RCT that assigned 210 subjects with scleroderma across 20 countries to subcutaneous tocilizumab or placebo over 48 weeks. The open label extension extended to 96 weeks to 60 subjects in the original TOSI arm and 54 subjects in the original placebo arm. The post hoc analysis assessed the QILD and the quantitative lung scores. The difference in the mean absolute change from baseline in FVC between the TOSI and the placebo arm was 118 ml less at 24 weeks, 241 ml less at 48 weeks, and 128 ml less at 96 weeks in favor of tocilizumab arm. The difference in the mean change from baseline to 48 weeks in the FVC percent predicted was 6.5% less in the TOSI arm. However, there is only conditional recommendation for TOSI in patients of scleroderma ILD, balancing the significant reduction in disease progression against the very low quality evidence. Despite there being RCTs with a true placebo arm in which participants were not exposed to any other medication, the patient population indirectly related to the scleroderma ILD because of a lack of a priori inclusion of patients with ILD as defined by the committee. In addition, the primary outcome of change in the MRSS was not met either in the FASCINATE or in the FOCUS trial. So now coming to the antifibrotics, I think there has been a lot of discussion on the antifibrotics. So we know we've already talked about nintedanib. So this is the census trial, and it showed an increase of 41 ml less decline in the FVC. So I will not go through this because it has already been discussed. So there is a conditional recommendation for use of nintedanib, and also now the question is, should the patient of scleroderma ILD be treated with nintedanib with MMF the committee decided to give a conditional recommendation for the combination of nintedanib with MMF in patients with scleroderma ILD, balancing the significant reduction in disease progression against the GI adverse effects with very low quality evidence due to primarily the post hoc data analysis. The decision to initiate the combination therapy should be informed based on the patient values and preferences in this situation, given the increased risk of the GI side effects. So if your patient is willing to tolerate the GI or doesn't have any GI side effects, so they can be started on the same. So now the other antifibrotic which is being used is pirfenidone. It is not that pirfenidone is less effective than nintedanib, it's only that a trial as big as the census was not done for pirfenidone. In our study also, the patients were less. We only had 34 subjects in the for pirfenidone study. So, and they were only followed up for 6 months to 1 year. So that was less time for us to to follow for that profound, for the p-value to become significant. So this is the patients in the pirfenidone group. So they definitely improved more than the ones who were in the placebo group. But the sample size was less and we followed them only for 6 months. So the p-value was not significant. And similarly in the Lotus trial, which was the SLS3, it was terminated because enough people could not be recruited during the COVID period. Had that study been done for a sufficient amount of time, probably we would have gathered enough data to use pirfenidone as frequently as we could use nintedanib. So these are the recommendations presently: strongly in favor of mycophenolate, conditionally in favor of cyclophosphamide, rituximab, tocilizumab, nintedanib, nintedanib plus mycophenolate, and research recommendations for pirfenidone and pirfenidone plus mycophenolate. And we have other drugs which we have used for scleroderma ILD, which are not currently this data has not been, it has been presented in the ACR as an oral presentation, but it has not been published yet. So we have used mycophenolate with tacrolimus, and the primary outcome was delta change in FVC percentage, and this is the comparative. So both MMF and TAC did act on scleroderma ILD. So there were no, so use of TAC did not result in any significant difference from MMF with respect to primary outcome percentage in FVC change at 24 weeks. So also we have attended session on PET CT imaging in rheumatic diseases, and I would like to add that we are doing PET CT, regional PET CT for patients who have been treated with for systemic sclerosis ILD prior to treatment and after treatment. And this is actually Chirag's thesis, in which he did the CXCR expression in PET CT in systemic sclerosis ILD, which has been published in Rheumatology. Thank you.
Thank you, Shafari. I just have 2 questions for you. I thought you were going to give us the final verdict, but you probably confused me a little more. I was already confused after the debate was over. I don't know. You want to give a drug to a patient who's already troubled with his breathlessness, and you want to tell him not to eat this, not to eat this, not to do this, not to do that, and you expect a good quality of life. I don't understand that bit. You know, one is that a person is already troubled, you giving him a treatment, you are changing his dietary habits, and then you expect a quality of life. Little beyond me. But I just have a question for you. Quickly, if you can answer. You have 2 groups of patients. One is a non-fibrotic ILD in systemic sclerosis, young patient, and then you have a fibrotic ILD in a young patient. Both of them come from a modest kind of a background. What would be your treatment preferences in them? 1, 2, 3.
Immunosuppression, immunosuppression, and immunosuppression.
Immunosuppression is a very wide term.
Okay, so MMF or cyclophosphamide, depending upon the patient and your convenience.
Both the group of patients?
Yes, yes.
Thank you. Any questions? Any questions? Thank you, Shefali, and I must thank the organizers for giving us a chance to be here and listen to this interesting kind of a session on systemic sclerosis ILD. Thank you very much.
Thank you, chairpersons, and thank you for such an insightful talk. Now we are heading to last session of the day on systemic lupus erythematosus. Our most recent graduates will be locking their horns on topic of lupus nephritis, voclosporin over belimumab, and particularly eager for this since morning because I'm next in the row. So Dr. Jitin will be speaking for this topic and Dr. Niladri will stand against it. To chair this session, may I invite Dr. Manish Kumar from Patna and Dr. Vikas Sharma from IGMC Shimla. Great, sir. All the best.
फ्लाइट का ज़्यादा टेंशन है कौन सा है भाई F5 ये आपका है ना Yeah.
So good evening, everyone. Can I have the slides, please? I'll try to make it quick because both of us have the same flight to catch in a couple of hours. So I am Jitin. I am currently working at Yashoda Hospitals at Hyderabad as a consultant rheumatologist. Can I have my slides? Yeah. इसको कैसे use करूँ? नहीं हो रहा ठीक कौन सा है next slide इसमें से करना है ठीक है okay so this particular picture might be confusing you. That's a kind of an appropriate pictorial representation of both of us. The title, I'll come to it later why I've chosen this. So I'll be speaking for voclosporin and I think Niladri will be speaking for belimumab in lupus nephritis. Okay, so as we all know that ESRD still develops in up to 1/3 of the patients with lupus nephritis within around 10 years after the initial diagnosis. Lupus nephritis, there are a lot of guidelines, varying recommendations. Initial treatment is fairly straightforward, but when they don't respond or they have an inadequate response, that is where the challenge starts. So you have a lot of recommendations. I'm not going here. I'll speak, okay, so this is the latest ACR lupus nephritis guideline overview. The final document has still not been published, but this is the pictorial representation. So this is where this topic is, debate is happening from as compared to the standard treatment now, wherein we start with glucocorticoids or mycophenolate or plus cyclophosphamide. The current recommendation is to upfront go for a triple therapy. So that means steroids, mycophenolate, and one of the two, which is either belimumab or calcineurin inhibitors, which is cyclosporin or tacrolimus. For this discussion, I'll stick to voclosporin or cyclosporin. I'll stick to voclosporin here. So this is why we are, whether we need this third one, what exactly, which one to choose, that is the purpose of the debate here. So my primary contention is that proteinuria is a very, very important component of management of patients with lupus nephritis. So why am I stressing it so much? Why is proteinuria so important? So let us look at two long-term follow-ups of two important randomized controlled trials in lupus nephritis. The first one is the ELNT trial, low dose cyclophosphamide versus high dose in lupus nephritis. If we look at the long-term data, so this figure is at around 6 years of follow-up. So at 6 years of follow-up, when they looked at patients who had a good renal outcome versus poor renal outcome, what is striking is that the ones who had a poor renal outcome had much lesser decline in proteinuria versus the patients who had a good renal outcome. So the decline was more marked in the patients who had a good renal outcome. And again, the same thing showed by a graph. If at 6 months your proteinuria declined by 50% or 75%, you are much higher, more likely to eventually land up with good renal outcomes as compared to poor renal outcomes. Extending this data even further to this lower graph is at 10 years. The same trial, 10 years of follow-up, this is what we see. So if at 6 months, at the initial 6 months of therapy, if you're able to achieve a significant drop in the proteinuria as compared to, for example, these black bars, these patients eventually end up with a good renal outcome 10 years down the line. So lupus nephritis, it's a long game, it's a marathon, not short term. So my point is, the earlier the treatment, the better the proteinuria decline, it translates into good renal outcomes. Again, when they did a multivariate analysis, the only two factors which were striking for long-term outcomes is serum creatinine at 6 months, the creatinine levels at 6 months, and a drop in proteinuria of less than 1 gram. So these were the only variables, and the positive predictive value was as high as 90%, who have a reduction in proteinuria by around 50 to 75% at the end of the first 6 months of therapy. The second trial which I'll speak about is this. Now, again, this is a very old trial published in 1992 in the New England Journal of Medicine on the role of plasma exchange. My only point is to look at this, the predictive value of an initial 50% decline in proteinuria. Now, after 15 to 20 years of follow-up, again, a very long-term follow-up from the context of lupus nephritis, what they have seen is, you see how strikingly different these curves are over almost 200 months of follow-up. The patients who had a 50% decline in the initial 6 months, they were the ones who, the survival, this is patient survival and this is renal survival. You see this marked contrast between the two curves, and the same figures described in numbers. So my point is, are you confused? My point is very simple. Early proteinuria reduction is a consistent and a very key predictor of long-term renal as well as patient survival in lupus nephritis. So so coming to calcineurin inhibitors or voclosporin, so they have varied mechanisms of actions, immunomodulatory, hemodynamic, and more importantly, podocyte stimulation. So just in brief, it is similar to cyclosporin. An extra double bond is there which is not seen in cyclosporin here. That is the only difference, but this difference makes the binding of this molecule to calcineurin different, which alters into better safety profile, more predictable pharmacokinetic and pharmacodynamic profile. You don't require drug monitoring like you do for cyclosporin or tacrolimus for that matter. So that is where voclosporin comes into the picture. Now, because I'm comparing two drugs, my friend will be discussing on belimumab, I'll talk from the perspective of efficacy, safety, and cost. Now, coming to efficacy, this is the standard trial, the initial phase 2 trial, which is the AURA-NLN trial, in which, as compared to baseline, they have added on voclosporin in patients with active lupus nephritis, and it was a positive trial. Patients who received voclosporin had better complete renal remission rates at 6 months and 12 months as compared to placebo, 40% versus 24% here. Now, again, coming back to my main point, what are the effects on proteinuria? Again, what you see is a marked reduction in proteinuria as compared to baseline in the patients who received voclosporin in this trial. And consequently, there is an increase in serum albumin, which is noted. Now, this led to the eventual phase 3 trial. So this is the Aurora 1 study, the trial based on which the US FDA has approved this medicine, with this particular drug. Again, what I wanted to look at is this: at 52 weeks, 41% versus 23%. So placebo arm already had MMF also. Voclosporin arm had voclosporin and MMF. So 41% CRR rates versus 23% complete renal response rates. So the same thing is shown, CRR and PRR rates. Now again, my whole point, what happens to the proteinuria in this trial? So look at this chart. So if the time to a proteinuria reduction of less than 0.5 mg per gram is 169 days as compared to almost more than a year in patients who just received background standard of care. And a time to a 50% reduction from diagnosis is just 1 month. So in 1 month, your proteinuria reduces by almost 50% as compared to almost 2.5 months for standard of care. So what is the key message?
early proteinuria reduction is a consistent and key predictor of long-term renal outcomes in patients with lupus nephritis. So therein I rest my point regarding the efficacy of voclosporin. Wait, but what about belimumab? I'm sure my friend is going to come and harp on about a lot of things about belimumab. It is this, it is that. I'll highlight what he's not going to tell you right now. So if we look at this trial, so this is the BLISS-LN trial. A key look, just a focused look into it. What exactly happened is something which we really don't understand till date. The original primary endpoint was something called the ordinal renal response. I mean the complete renal response. And after 5 years of trial onset, they have mysteriously changed it to something called primary efficacy renal response. Now, why this change was done, this is the only explanation available as per the article. There is no other explanation available in any public domain or anywhere as of date. So, a change of a trial endpoint 5 years after trial onset, a standard endpoint, and creating an entirely new endpoint which has never been used before, it's a bit suspicious, isn't it? Yeah. So we are actually comparing different goalposts. So just for the numbers also, if I want to compare the two, it becomes a bit difficult for me. So I'll just put into context. So this was the original complete renal response as mentioned in when they initially began the trial, the CRR. So it was calculated GFR of more than 90 with a UPCR of less than 0.5. 5 years down the line, they have decided for some strange reason, they are going to reduce this to 0.7. And we changed calculated GFR to estimated GFR. Now, very simply put, this is a less stringent and this is a much more stringent approach. So what exactly happens? The beauty of it is what exactly happens if they had still used this particular endpoint? What if they had used a complete renal response? Let's see. So if they had used the original complete renal response, this is pretty similar, right? It's around 12% and 12%. CRR at 2 years and PRR is 13 and 21, P value is 0.1. Very, very surprising indeed. Okay, if we look at the new endpoint that they created out of thin air, so this was around 30 and 20, so this was statistically significant and this is based on which the trial was eventually, the drug was approved. Numerically comparing, this is 30 and this is 41. Two different trials, two different designs. I know we can't compare, but just putting it out there. So 30 versus 41. And even for partial response rates, it's around 18, quite low, versus 70. Not comparing, just putting it out there. So what is the problem? One more problem with belimumab. So the Achilles heel of belimumab is actually if there is a significant proteinuria. When you do a subgroup analysis of the BLISS-LN trial, what you see, if the proteinuria is more than 3 grams per day, the confidence interval for both CRR and the newly created PERR are not significant. So it only works if the proteinuria is less than 3 grams per day. Basically, it does not work in class 5. Class 4 with significant proteinuria, out of the question. Just to summarize the last part, so this is Aurora 2, which is, so we have long-term data for voclosporin, which shows sustained CRR responses of almost 56%, which is maintained. This is the same Aurora 2 study, which is the long-term follow-up over a total period of 3 years. Yes, so what happens to GFR? So I've just been talking about proteinuria. What happens to GFR? It's a very important component. So what happens to GFR is, look at the blue line. The blue line is voclosporin. The GFR slope has remained exactly on a straight line, or very strictly speaking, it just declined by 0.2 ml per minute over a period of 5 years. Whereas this is placebo. So as compared to placebo, which shows a gradual decline, which is expected. So what I'm trying to put across is, if you use voclosporin, it maintains your GFR, which is again what we're looking for eventually, isn't it, in lupus nephritis. So, okay, fine. So what about safety? Now I know pretty much sure that Niladri is going to talk a lot about safety. It is going to cause AKI, it is going to cause blood pressure, it is going to cause antihypertension, TMA, etc., etc. Well, as I already told, it's a new in class CNI, so the safety profile is much better. Look at the, let's bust the myth that is going to create right now. So this decline in eGFR is actually a reversible hemodynamic effect. There is no sustained decline in eGFR. Whatever decline happens, it just maintains over a period of 3 years. We saw that the line graph remains the same. So this is out. Next probably is going to speak about blood pressure rises, creatinine rises. Creatinine I already spoke about. Blood pressure rise was only 3 patients actually required antihypertensive versus 10 patients in the control arm. So it actually helped patients from lupus nephritis prevent progressing and requiring antihypertensive therapy. So it is safe from that point of view also. Safety profile, it's comparable. Serious infections are comparable. Just for comparison purpose, this is 26% in the Bliss LN group versus 21% comparable. Serious infections 7 and 10, again comparable. So what about the cost? Well, this is where my first picture comes. Both of these medicines are, this is a purely theoretical discussion. Both of these are not available to us. The prices are exorbitant and we don't have any practical experience with the same. So thank you.
Thank you. I would invite Dr. Niladri to present his case.
Good evening, everyone. So at the onset, I am really thankful to Aman sir, to Naidu sir, and to the entire department for inviting me here. It has been a really great experience meeting everyone and interacting with everyone. So I'll be bunking Dr. Jitin's argument. So I'll be speaking against the motion. So let's start off with what belimumab would say to voclosporin right away. Why is this? This is because in simple terms, belimumab was approved for SLE in 2011, while voclosporin is yet to be even approved. So we all can guess which is the BAP here in the among the two drugs. So my arguments for belimumab rest on this clinical trial. So it is the Bliss LN trial. So Bliss LN trial was a, just a second. So Bliss LN trial was a double-blind in 107 centers with active lupus nephritis. And so we'll go deeper into this trial to understand where this trial beats voclosporin. So the primary efficacy renal response was 43% in belimumab versus 32% in placebo, which was statistically significant, was the primary outcome. Aurora 1 has already been discussed by Dr. Jitin, so I'll not go into it any further. So it's basically Bliss LN versus Aurora 1. So is it actually going to turn out like this? So let's see. First of all, the baseline demographics in this study. So 51% in this study were Asians. We are also Asians, by the way. So 30% in the Aurora 1 trial were Asians. Coming to the next very surprising thing, this in the median time from initial diagnosis of lupus nephritis to randomization, in the Bliss LN trial it was just 0.2 years, which is somewhere close to where we stand in our clinical practice. While for the Aurora 1 trial, it was 4.6 years. So that is a very big surprise. That why was there a 4.6 years gap in the diagnosis to this randomization? Also, next thing I want to show is that the class 5 and the proteinuria has been, so the proteinuria in this Bliss LN trial, which was a successful trial, I want to remind, was 3.2 compared to 4.3 grams per day. 36% had class 5 in the Aurora 1, while in around 43% had in the Bliss LN trial. And the estimated GFR above 60 were similar. So the renal functions were similar in both the studies. But what's surprising is the Bliss LN trial, it needed that a biopsy needed to be done in the last 6 months, while it was not the case in Aurora 1. So what was the renal functional status as per the histopathology is not clear in the Aurora 1 trial. So coming to the head-on-head trial. So first of all, as Dr. Jitin has in this 5 minutes ago said that it's a marathon, while the trial for Bliss LN was 104 weeks, this trial of Aurora 1 was just for 52 weeks. Okay, so that's a surprise. Second of all, the cyclophosphamide and azathioprine or mycophenolate both could be used in Bliss LN, while only 2 grams of MMF was allowed in the Aurora 1 trial. So the guidelines, coming to the guidelines, this actually limits the armamentarium that we have for treating of SLE, because belimumab can be used either with cyclophosphamide or mycophenolate mofetil, while calcineurin inhibitor, it does not even mention just voclosporin, it mentions voclosporin or tacrolimus, and it can be combined only with mycophenolate. So that limits our armamentarium, and this is as per the EULAR guidelines. So moving on, the dosing. So dosing of belimumab is once 0, 15 and 28 days followed by a IV monthly. While voclosporin needs 6 tablets. Can you imagine 6 tablets of voclosporin, 4 tablets of MMF, pantoprazole and all other drugs? And so what would be the patient feeling like? This is the condition of the patient after taking so many tablets. And also the adherence is much better with IV drugs, we all know that. So, and as Dr. Jitin has said, let's address the elephant in the room, the change in the trial outcome. So it was initially an ordinal renal response, which Dr. Jitin failed to mention is that it included urinary sediments as well in the but it was changed to a primary efficacy renal response and a complete renal response, but it was not out of thin air. So as we grow older, we have evolved with the gain of knowledge. So what knowledge was there that was initial from the starting to the after the trial? So first of all, we can see from the ELNT trial, the predictors of long-term renal outcome in lupus nephritis. So we can see when the proteinuria and creatinine was taken for the composite predictor 12 months, the sensitivity was 0.7. While it reduced when urinary RBCs were included into the factor, it was reduced to 0.47. And when all these three were taken together, it was just 0.4. So there was a significant reduction in, so this new data had come into the fore, which led them to change the outcomes. Also, there was a long-term outcome of the maintained trial, so which they showed that when they saw the patients who had long-term good renal outcomes, the numbers at the 3 months, the CR and the complete and the partial remission were almost similar. It was 80 and 92, 91%, 92%. At 6 months, 90 and 75%, 92 and 80%. And it was significantly different from the no response versus partial response. So clubbing the complete response and the partial response into a PERR made much more sense than bringing them as per the different ones. So this justifies the change in the outcome that they have, that Dr. Jitin was harping about continuously. So the efficacy of the drug is not a very thing up for debate, and even for meta-analysis has further shown that the effect is almost 1.31 was the risk ratio which favored belimumab in the total response. In complete response it was around 1.47, and the response in the MMF group was around 1.45. All of these three are significant. As Dr. Jitin has already told, that it decreases proteinuria early. So as Brad Robin had initially mentioned in one of the ACR talks, that time is nephrons. So let's see, let's not remove the surrogate marker of UPC and come down to directly to the renal outcomes. So what is the probability of PR? We see the graph starts differentiating at 8 weeks. That is pretty early. Even the probability of the complete renal response starts differentiating almost at 8 to 10 weeks, it starts differentiating. The probability of renal-related effects or death, that also starts separating pretty early. And the EGFR, the absolute EGFR, not any proteinuria, is significantly different as we can see. So it stands that it also starts working pretty early. And the nephroprotective action of belimumab, so we can see that the probability of experiencing lupus nephritis flare is actually significantly increased with placebo, and the gap keeps on widening as we move on in time in the long-term part. So is all well with voclosporin? So Dr. Jitin again has shown the data of the Aurora 2 trial, which was an extension of the Aurora 1 trial. But if we look deeply into the Aurora 1 trial, we can see, and it is given in the supplements, not in the main paper, that the EGFR actually, the EGFR actually is the blue one, which is lesser than the placebo in the 52 weeks Aurora 1 trial. And also the BP is significantly higher. So here we are actually increasing the BP and calling it a nephroprotective agent. So isn't that a bit like this situation? So and also, so we have to see that belimumab also does cause reduction in proteinuria, as we can see for the PR component group. For the UPCR less than 0.7, the odds ratio is 1.5, and for 0.5 it is 1.58. So belimumab also causes a reduction in proteinuria. So I thought that Dr. Jitin will be talking about the blacks also, but it has been, there is a controversy regarding if it works only in the blacks or not, but that's not really relevant here. So also we are Eastern Asian, so for the Eastern Asian population, we can see that as though the overall population, the response was only 43%, it increased to 53% in the Eastern Asian subpopulation. So it works very well for the Eastern population group as well. What Dr. Jitin did not mention, I want to really say, that lupus nephritis is a part of the entire lupus disease. So while voclosporin is looking only at the kidneys and to the podocytes, actually belimumab causes improvement in the parameters of the dsDNA levels are reducing, the C3 and the C4 levels are actually increasing. And when to do a deep dive into the supplementary part of the article, we can actually see that the C3, C4 and the dsDNA levels for voclosporin are given, but again the p-value is not significant for any of them. So there is no immunological modulation that voclosporin provides other than for the podocyte stabilization. And so to prove that, the BLISS 52 and the BLISS 76 studies already exist, for which 2011 the drug received approval from the FDA. Now, which one of the following drugs can be used in pregnancy? Belimumab is not teratogenic. It can be used in management of severe maternal disease and also its exposure is unlikely to be harmful. While voclosporin is not like other CNIs, voclosporin has an alcohol content in the drug formulation, and so it is harmful in pregnancy and it is harmful in lactation. I did not hear that during the previous deliberation. Also in the belimumab in children, also it is also approved for childhood onset SLE. It suppresses lupus activity and it also relieves refractory symptoms of monogenic SLE. So what's common between Dr. Jitin and belimumab? Let's have a guess. Both are actually green flags. Congratulations on getting married, Dr. Jitin. The safety profile out of these, so the serious infection risks are actually, it actually crosses 1, so it's actually very significantly, it's not really increased, and these serious adverse events are marginally increased. And the CNI toxicity profile, we are all aware of it: nephrotoxicity, hypertension, diabetes, dyslipidemia, hyperuricemia. Do I need to go on and on? So the simple mantra is keep calm and use belimumab. Thank you.
I'll take 2 minutes because beyond that we'll miss our flight. Okay, so I'll just put my views on some of the pointers that he has told. So if you have not read the debate topic, it is lupus nephritis, it is not SLE. I agree that lupus nephritis is a systemic disease, SLE is SLE is a bigger picture, but we are talking about lupus nephritis. Bringing SLE is just like, you are trying to use unfair advantage, that is one. And voclosporin by default has been used only for lupus nephritis. Systemic involvement was excluded from the trial, so it does not apply. I think, okay, he told about childhood lupus. Again, we are talking about lupus nephritis, and he was talking about cutaneous lupus. I don't see the connect really here. Next one, okay, he told that, I think Dr. Niladri mentioned it is only used, it has been, only belimumab has been approved. FDA has approved in 2021 voclosporin based on the Aurora 1 trial, so you stand corrected, I guess. He showed a big table about CNIs and gingival hyperplasia and diabetes and hyperuricemia and hypertension, blah, blah, blah. I already mentioned that voclosporin is a specific drug with a specific, it's a CNI, but it is pharmacokinetically and dynamically different. It does not cause most of the CNI side effect. That is why this new drug has come into the picture now. So that is also out. Some of it has got smudged, sorry. I guess. Okay, so he mentioned that the initial GFR decline had been seen. Yes, but if you remember my slide, I had shown a 36-month graph in which the GFR line was flat straight, exactly straight, maintenance of GFR, that's what I told. So an initial decline is what is expected. I already told, I was expecting this from him. He tried to just beat on about it, but I just showed you the flat line over 3 years. That is Aurora 2. Aurora 1, 1 year, Aurora 2, 3 years extension, 2 years extension, total 3 years of data. Remaining 2 points I got smudged, so I'll call it a day. Thank you. Yeah, congratulations Niladri also on the wedding.
Just for the FDA approval, I did mention that the SLE and SLE nephritis were 2 different approvals. So for SLE, 2011, the belimumab was approved, and 2020 belimumab for lupus nephritis, while voclosporin is only for lupus nephritis and not for lupus. So that is the part I wanted to say. And I also for Aurora 2, not all patients of Aurora were while including to Aurora 2. So how much extrapolation of that one data into another data, I am not really sure about that. Thank you. Thank you.
Thank you, Chairperson, and thank you for such a lively and intense debate. So now it's been a long day of learning, but we will conclude our day with the most discussed topic, how to manage lupus nephritis in 2025. Dr. Shankar Naidu sir will be speaking on this topic. To chair this session, may I invite Professor H.S. Kohli sir, Head Department of Nephrology at PGI, and Professor R.S. Sibia sir, if he is around. Okay. Over to you, sir.
Okay, so we are at the fag end of the day. Thanks Aman, for giving me this opportunity. So now at the moment, at least, I think the eyes are a little high and we are all feeling a bit sleepy. So to charge up all, I think it's your job, Dr. Shankar Naidu. I think your designation is this or changed?
It has changed, sir.
I think it's changed. So you're an additional professor in the
I
department.
couldn't get time to change. I did this, sir.
So that's important. You have to look after yourself first. Nobody else will look after you. Okay, Dr. Shankar, please.
So thank you, sir, and good evening, everyone. So I think I will not take much of a time because the previous two speakers had actually made my work a lot easier. I will not be going into the details. They have gone into details of those two molecules. So this would be the plan of my discussion. So as we have heard previously, renal involvement is seen in about 20 to 60%, and in Asians it is about 45 to 55%. And most patients develop nephritis very early in the course of the disease, and it is a very important cause of both morbidity and mortality in patients with lupus. And as you can see the figures, 10-year survival rate is about 92% overall in lupus compared to around 83 to 85% in patients who are having lupus nephritis. So going to the topic, definition of lupus nephritis, there are various definitions given by different groups. So this is one consolidation of all the various parameters that we usually consider. Persistent proteinuria of more than 500 milligrams per day, active urinary sediments either by presence of RBCs or RBC casts or WBCs, and renal dysfunction, that is elevation of serum creatinine or a decrease in eGFR, or a renal biopsy which is showing evidence of lupus nephritis. So one or more of these would definitely make a definition for lupus nephritis. So regarding the kidney biopsy, there are few questions. What is the purpose? Who should be undergoing kidney biopsy, and what is the timing of this biopsy? So the purpose is obviously is to confirm the diagnosis, but also to assess the activity and chronicity, because this is very important to take various therapeutic decisions, and also to prognosticate the patients whether what would be the outcome at the end of the therapy. And who should undergo the biopsy? Unless contraindicated, all the patients should undergo a biopsy possible. However, clinical findings do not always, and when the clinical findings do not always correlate with the extent and severity of the involvement, so it is important to remember that all patients should be encouraged to undergo a biopsy, but it is not essential to initiate therapy. And the timing of biopsy as early as possible, and within 1 month of initiating the immunosuppression. And this is a classification of lupus nephritis which was modified in 2018. I'll not be going into the details. Most of you would be aware of this. The major differentiation is either class 1, 2 versus class 3, 4, with or without class 5. So class 3 and 4 are considered to be more active disease which would result in a lot of renal damage. And on biopsy, this is how chronicity and activity are scored. Again, I'll not be going into the details of the scores, but the activity score ranges from 0 to 24, and certain parameters like fibrinoid necrosis and cellular crescents are given higher score than the other features, and in the chronicity is scored between 0 to 12. So more the score, more is the activity, and more is the damage. So what are the other serological markers that we look at? dsDNA, but remember that it is positive in only about 50 to 75%. So absence of dsDNA or negative dsDNA does not rule out lupus or lupus nephritis. And it may be absent in pure membranous lupus nephritis. And hypocomplementemia, again, seen in almost 80 to 90% of these patients. And usually low C3 correlates with the activity on biopsy. And normalization of levels indicate a good outcome in the patients. So next, coming to the main topic, that is treatment of lupus nephritis, it can be divided into two, class 1 and class 2 versus class 3, 4, with or without 5. So the next few slides I'll be concentrating more on class 3, 4, with or without 5, and not more deliberation on class 1 and 2. And if you look at the treatment, renin-angiotensin antagonist inhibitors with HCQS is to be given in class 1 or 2, with or without maybe low dose glucocorticoids, especially the proteinuria is high and it is in class 2, and maybe azathioprine sometimes. Whereas class 3, 4 and 5 would require aggressive immunosuppression. So next, coming to the evolution of therapy in lupus nephritis. So the initial drugs used were glucocorticoids, started in early 1950s. Till 1970s, glucocorticoids were the alone drugs which were used. But in 1970s to 1980s, the cyclophosphamide use has come up in a big way, especially based on the NIH 1, 2, and 3 trials, and subsequently the Eurolupus trial. Then in mid 1990s to mid 2000s and early 2010s, mycophenolic acid and its prodrug, the MMF, has been proven to be effective both for the induction and maintenance. Both ARMS trial, like ARMS for the induction and ARMS maintenance trial, and also study from our own institute had showed that MMF is a good enough drug to induce remission in this patient. So what we need to remember is that with both these proven drugs, the response rates are only about 50 to 70%. So there is a need for other drugs which would be more, would increase this response rates to near 100%. And also ESRD rates are about 5 to 15%, and to bring down these rates as well. So that is where the role of newer drugs is there. So if you look the recent drugs into 2010s, we started using rituximab and CNIs, which includes cyclosporine, tacrolimus, and the newer drug, the voclosporin. And various other B-cell targeted therapies like belimumab and obinutuzumab. Then again, voclosporin as the newer CNI, and anifrolumab, which is a interferon 1 antagonist. So my next few slides will concentrate more on these drugs and what is the data that we have right now. So first, coming to rituximab in lupus nephritis. This is an old study, but this is one of the initial study of rituximab in lupus nephritis. Even though this is a negative study with respect to the primary endpoint, there was no major difference between the primary endpoint, which is either complete or partial renal response, compared to rituximab versus placebo in a background of MMF. But if you look at the various other observational studies and registry data, we can very clearly see that rituximab did help in few patients who were not responding to the initial cyclophosphamide or MMF. So the role of rituximab comes as a third line drug who are not actually responding to the two previous available drugs. So that is the role of rituximab. As you can see, the remission rates with the rituximab in this observation study is up to 80%, who obviously these are the patients in majority of whom rituximab has been used after cyclophosphamide and MMF have failed. And if you look at the 1 year data, the amount of response in class 3 is slightly more than other two classes. And this is again another pooled data from various centers in Europe. As you can see, nearly 65% had either complete or partial response. And majority of these patients did receive one or more of these drugs. And also, if you look at the class 3, this has a even better response compared to class 4 or in combination with class 5. And this is again another study from French. This is again a registry data. As you can see, this is basically for whole of lupus. But as you can see here, nearly 1/3 of the patients had lupus nephritis, and among them nearly 75% had either partial or complete response. And when we see this data in comparison between patients who are already on immunosuppression versus rituximab has been used upfront, even in those patients there is a better response with rituximab. So with this data, what we can say is that even though RCT has failed to demonstrate benefit in lupus nephritis, it is often used off-label in refractory lupus nephritis, and major guidelines do recommend it as a rescue therapy in patients who are having recalcitrant nephritis. So next, coming to calcineurin inhibitors. I'll not be speaking much about cyclosporin because there is very limited data. It is more on tacrolimus. So this is the initial study which has shown that use of tacrolimus did improve the complete response, complete remission rates, and the partial remission rates, which are actually more superior to cyclophosphamide and almost equal to MMF. And then came the major randomized control trial, which the multi-targeted therapy, where you can see that multi-targeted therapy, that is use of MMF and tacrolimus in combination versus IV cyclophosphamide. If you look at the various time points, this multi-targeted therapy did much better than cyclophosphamide alone. And this improvement is much more in patients who are having class 4 and class 5 lupus nephritis. And even the maintenance therapy, study with the same combination did show that the probability of patients without renal relapse was much better in combination therapy compared to the IV cyclophosphamide, azathioprine as a maintenance therapy. And this is again another randomized control trial which actually compared head-to-head between tacrolimus versus MMF. And as you can see, the probability of having a composite outcome, here the composite outcome are the negative outcomes, patients who are having ESKD or a non-responding renal disease or death. So here the probability of this bad outcomes is less in tacrolimus alone compared to MMF. Whereas the flip side of this study, this drug was that on long term, the number of relapses were much more in tacrolimus compared to MMF. And from this study, if you look at the pure membranous lupus nephritis, the tacrolimus did well compared to MMF alone. So, and the next, I think I'll not be going into details of voclosporin. We had heard enough of this. This is a new generation calcineurin inhibitor with 4-fold higher potency and lesser side effects. And this is the data of Aurora 1, which has already been shown. And this is also, I think, has been shown. This is actually subgroup analysis of Aurora 1 trial where they have taken only patients who are having high level of proteinuria. Even in this subgroup, the effect of voclosporin was better. And this is the extension of Aurora 2. So based on this, what we can say is that among the calcineurin inhibitors, tacrolimus is a second-line drug in proliferative lupus nephritis, and in some recommendations did say that it can be used as a first-line in pure membranous lupus nephritis. And however, MMF-TAC combination as a rescue therapy has been recommended by most of the societies. As far as voclosporin is concerned, it has been approved by FDA for active lupus nephritis. And however, it is not recommended when the GFR is less than 45 ml. And it has not to be, actually there is no data to show that it is effective or the side effect profile is better if it is used with cyclophosphamide. So as of today, it cannot be recommended to be given along with cyclophosphamide. However, it is not yet available in India. Regarding belimumab, again, we had heard enough of it. So these are the trials that we have already seen. So I'll be skipping this. And this is he had shown this meta-analysis data as well. So belimumab did show that the complete renal response and the total renal response did improve in patients with lupus nephritis. And also the renal flares are better, like less in belimumab compared to the control group. So based on this data, the FDA has approved belimumab for the use in active lupus nephritis. However, it has, with the approval came with the rider that it has to be used only along with the other standard care of therapy, and it cannot be used as a standalone drug. And and its role in pure class 5 lupus nephritis is yet to be studied in detail. The other newer drug is the obinutuzumab, which is type 2 anti-CD20 monoclonal antibody. So it is similar to rituximab that it acts on the on the CD20 molecule. So what are the differences? Rituximab is a type 1 anti-CD20 molecule, which has more of a complement dependent activity, whereas obinutuzumab is a type 2 where there are some structural changes which have resulted in increased direct cell death and also the increased ADCC and ADCP. So this will result in more deep B cell depletion and also more effective and more sustained deep B cell depletion compared to rituximab. So this is the phase 2 trial of obinutuzumab where they have the dosing is similar to rituximab, 1000 milligrams given at week 0 and week 2, followed by 6 monthly, again two more doses. And as you can see, both the complete renal response and the overall renal response was better in obinutuzumab compared to the comparator arm. And if you look at the B cell depletion, nearly 98 to 99% had B cell depletion, and that was sustained up till 1 year. So in fact, these rates are much higher than what we usually see with the use of rituximab. And based on this data, there is a phase 3 trial which was recently published, obinutuzumab in active lupus nephritis. Here the primary outcome is a complete renal response. As you can see, it is much more significantly higher in obinutuzumab compared to the placebo, as well as the various other secondary key points, including the reduction in proteinuria and other adverse outcomes like death are better in obinutuzumab compared to the placebo. Again, the B cell depletion in this is also reaching about 98 to 99%. And it has been sustained till almost 76 weeks. So this would indicate that obinutuzumab has a very sustained B cell depletion in these patients. So regarding this, the obinutuzumab is more effective, has more effective B cell depletion compared to rituximab. However, it is not yet been approved for lupus nephritis. The important thing, even though it is available in India for other indications like hematological malignancies, right now the cost is about 2 to 4 lakhs for each vial. So to use this drug would be very costly. So if at all we have to use we do have this drug available, so we might consider using it in 1 or 2 patients if it is needed. Then anifrolumab, it is a monoclonal antibody against type 1 interferon subunit 1. What it does is it induces internalization of this receptor, thereby disrupting the interferon 1 self-amplification loop. And as we know, SLE is an interferon 1 mediated disease, so this pathway is very important in the pathogenesis of SLE. The previous trials, like the TULIP 1 and TULIP 2, they were demonstrated efficacy in moderate to severe lupus disease. Among them, some of them had lupus nephritis also, but it was mainly for the overall disease of lupus. And based on this, it has been approved in patients of lupus. So, but if you look at the specific data on lupus nephritis, this is one phase 2 trial where it has not actually met its primary endpoint. So, this is basically phase 2 trial and very small number of patients, so we cannot take much conclusion from this trial. I would say that we need more trials before we say that anifrolumab actually does not act in lupus nephritis. So just to summarize, I'm not going into the details of various recommendations. This I thought is actually summarized most of the things that we are actually doing in our practice right now. This is the latest EULAR recommendations published in 2024. These are the things that we do. Hydroxychloroquine we give in almost all the patients unless contraindicated, like retinopathy is there. And we always give adjunctive therapies with ACE inhibitors or ARBs. Regarding SGLT2, there is not much data as of now. And VKS and heparin to be used if there is concomitant APS nephropathy. And coming to the immunosuppression, glucocorticoids are to be given in all the patients. The dosage can vary depending on the severity. When there is severe renal dysfunction, we can start with IV methylprednisolone followed by oral steroids. And even in the oral steroids, there are certain studies which have compared low dose versus high dose. I did not go into the details for the shortage of time. And regarding the other steroid sparing drugs, MMF and low dose cyclophosphamide can be used alone, and also the high dose cyclophosphamide, especially if there is a severe renal involvement or the biopsy showing high activity and severity. Regarding the various other drugs that we have actually seen, belimumab, voclosporin, tacrolimus, all of these drugs will come in combination with the other standard of care. They are not to be given standalone. And as far as we are concerned, this is what we are following right now, MMF or cyclophosphamide. We do use more of high-dose cyclophosphamide than the urolupus regimen. So for us, MMF or high-dose cyclophosphamide / low-dose cyclophosphamide for the induction therapy. We haven't yet used belimumab or voclosporin, but we did use MMF plus tacrolimus combination in many patients. And rituximab as of now is much lower. So that actually is being reflected in our practice as well. And as far as maintenance is concerned, MMF over azathioprine or a combination of MMF with or azathioprine plus belimumab as maintenance as well. But we don't have belimumab, so we are stuck with MMF or azathioprine. So thank you.
Thank you, Dr. Naidu. I think whatever you have shown all around is somewhere 30% gap is always there, irrespective of whatever drug you may be using, complete and partial response. So I think ultimately it also depends upon what exactly is the pathogenetic mechanism. Maybe until unless that is clear, we are just hitting it hard with different drugs, and we are getting some results, 15%, 20% less, or 30% or 40% less, unlike some oncology where it is getting excellent results and becomes successful. But here it is one disease and which affects the. So those who are going back by road, any questions? The flight people have already left. Right. So with that, I think Varun, you want to say?
Okay, I just asking you, what is your opinion on this coming up of these gliflozins now, like dapagliflozin and all?
Yes, sir. Actually, I could not find any phase 3 trials. There is one phase 2 trial which has shown that SGLT2, it is not a phase 2 trial. I think it's an observational study which had actually compared 1700 matched pairs of patients of lupus who had been on SGLT2 inhibitors for some other reason. And they have seen that those patients who are on SGLT2 inhibitors had a less frequency of developing renal involvement and less frequency of developing cardiac involvement. So, but that was actually not as a part of treatment, but that is a preventive type of data. So, for the treatment purpose, there are no data as such to say whether they are useful, but obviously we know that they do reduce the proteinuria significantly, so they might be renoprotective. But again, the rider here is that they are prone to develop UTIs because of the glycosuria. So whether in combination with the immunosuppression, whether that will result in severe UTIs and adverse effects, that needs to be studied.
Okay. So with that, I think we'll close this last session. Thank you very much. Over to you.
Thanks.
Thank you, Chairperson, and thank you, everyone. Thank you, sir, for such a wonderful discussion. As we come to end of this CME, I want to take a moment to express my gratitude to all esteemed speakers and all of you for your participation.